P16 positive mutations, which is a surrogate marker towards HPV positive disease. Um, so one, you need to be aware that, despite the AJCC8, it downstages from the AJCC7 in terms of its TNM staging. De-escalation is not actually yet universally recommended outside of clinical trials. Metastatic disease, straightforward. Many years ago, we were just sticking to chemotherapy, cisplatin 5-FU, backbone, but nowadays we're adding on immunotherapy like pembrolizumab into its treatment, and irrespective whether you're HPV positive or negative, it's still the standard of care. Maybe there's slightly better prognosis in terms of HPV positive metastatic disease. So why do we de-escalate these patients? What are we looking at? What's the rationale behind it? Now we know that HPV positive disease tend to have a better prognosis. They have, what the data shows is that there's 95% survival rate. So we are still, in this day and age, even in my practice, I'm still delivering 70 grays in 35 fractions. So that tends to lead to long-term sequelae from whether it's radiation side effects or with the chemotherapy side effects. So you'll find a lot of local skin issues, fibrosis, dysphagia, chronic xerostomia, dry mouth, dental issues. Of course, there's also maybe possibility of orthotoxicity secondary to high dose cisplatin. So we need to be aware, as I mentioned earlier, the demographics are, these patients tend to be younger, they are likely to survive longer. And unfortunately, with high dose radiation, they will tend to have higher toxicity and morbidity later down the line. There are three methods of this escalation that I'm going to talk about. I'll try to approach it as best as I can. We're looking at three options here: radiation dose de-escalation, systemic substitution, and personalized approaches. In terms of radiation, just the gist of it, radiation dose de-escalation, straightforward. We're actually trying to reduce the dose from the general 70 grays to about 50 to 60 grays in the hopes of curing the patients, number one, and number two is minimizing long-term toxicity. Second option, substitute your combined treatment in terms of systemic approach, where from cisplatin, which is the standard chemo, high toxicity, is there any other alternative that we can choose, like targeted therapy? Personalized approach, we are using the patient's own tumor characteristics and the patient's own condition in terms of response. If they respond better or the biomarkers show good response, maybe these patients can have a lower dose of radiation. So one size doesn't fit all, so we have to choose accordingly. So we start with what is radiation dose de-escalation on its own. As I mentioned earlier, we're trying to reduce the dose from 70 to 60 grays or even lower to 50 grays, 30 grays to 50 grays. We are trying to spare the critical structures, pharyngeal constrictors, salivary glands. We're trying to reduce those and toxicity there in terms of early and late. And of course, the late toxicities, we want to, hopefully avoid any functional endpoint like late-term gastrostomy, dependency, fibrosis, and all that, in the aim of minimizing chronic toxicity while maintaining cure. These are many of trials that I've come across. You need to be aware there will be overlaps with the other two options here because there's some using, chemo, some are not using chemo and all that. But the idea here is, if you look at all these trials here that I mentioned, the NRG HN005, the HN002, the ECOG 1308, the 30 ROC, and the Optima. If you code down to the HN005, it's a phase 3 data that shows that 70 grays is still the ideal option. You still can't run away from the fact that you cure your patients with 70 grays, and it's hard to beat with just using 60 grays. On the other hand, you've got a phase 2 data which to decide that you may be able to reduce the dose based on whether the tissue is hypoxic or not. And then, of course, the biomarker, as I mentioned earlier, the ctDNA. So I'll just go through briefly because I find this quite interesting. The two trials that talk about the hypoxia aspect of the patient's tumor, where let's look at the 30 Rock phase 2 data, which shows that, using the F-meso PET to detect the tumor hypoxia. So if they are non-hypoxic, that means they're considered low risk. You can go on with just 30 grays of chemo radiation. And the outcome shows that 100% 2-year local regional control survival. While those hypoxic tumors, we still deem them to be hypoxic and high risk, we would just stick to the 70 grays. Now, then after that, you talk about the MSK exclusive, you're talking about the M-meso stratification, same concept, whether they are low risk or high risk, whether they're hypoxic or not. And it shows that if they are, well oxygenated, the primary outcome shows that it's proven to be non-inferior and in terms of survival, when you give lower dose radiation, less toxicity towards these patients. So there is, quite exciting times ahead for us when you talk about hypoxia to decide whether patients need lower dose or not. The other way of looking at it is by giving induction chemotherapy. These two trials, ECOG 1308 and Optima phase 2, basically they show whether by giving 3 cycles of chemo, the ECOG 1308 showed that if there's complete response after 3 cycles, okay, then you can probably tell yourself, okay, this is probably low risk chemo. I'm going to give 54 grays rather than 70 grays. And so far, what the data shows is that the 2-year survival seems to be about 96%, quite high. In terms of the Optima, same thing, induction chemo is given 3 cycles. And this trial only requires 50% tumor shrinkage from 100% to 50%. That tells us, okay, this is low risk. I'm going to give lower radiation dose towards this patient. So the goal for this trial is giving induction chemo. You monitor them closely. If they respond really, really well, then you may want to consider lower dose chemo radiation. Finally, the Redden trial, the ctDNA, uses adaptive radiation to de-escalate. So initial strategy is that basically you've confirmed oropharyngeal HPV positive tumors, you do your ctDNA at baseline and monitoring every 3 weeks. What I remember is that you're going to give about 3 cycles of chemotherapy. And then, you're given about 24 grays in 12 fractions of chemoradiation to the tumor. And if there's rapid clearance after about 3 to 4 weeks, more than 95%, then these patients are deemed to be low risk, and you can de-escalate your radiation to 30 grays, thus sparing the healthy tissue. And so far, it shows that there is excellent regional control by this using the ctDNA. And on cost, if your clearance is poor, then you stick to your 70 grays in 35 fractions. So this slide, again, I'm just summarizing everything that I've spoken about in terms of, you can take a snapshot of this where you're looking at lowering your radiation dose, systemic substitution. However, it doesn't tell us that you can substitute. You're just going to stick to your cisplatin. There's not much new that can tell us. There's no new agent that can help us reduce, not use cisplatin. I think cisplatin still plays a big role. Personalized markers this is where the exciting times of using hypoxia. Those, or on the other hand, oxygenated tumors tend to respond much well to radiotherapy, so you can technically use lower dose. So now it comes to, in your clinic, would you practice? Now, if you ask me, probably I'm not ready to practice yet. I probably want to see the long-term aspects of local control. But the previous data, they're talking about two years of control or no relapse yet. But maybe in your clinic, you could consider choosing your patients properly between the ideal and the high risk. I guess you just look at the ideal risk, how to de-escalate or when to de-escalate. Patients who are P16 positive oropharyngeal tumors, T1, T2 disease, and not N1. I guess you're looking at the AJCC 8 edition here, less than 10 years back of smoking. Those patients who are non-hypoxic or very oxygenated tumors, and you monitor with ctDNA. I mean, if it's available in your country, monitor the ctDNA after a certain duration of time. If there's more than 95%, as they mentioned earlier, then you could consider de-escalating your patients. So this is my final slide. In a way, in summary, the gold standard still, however, the gold standard of 70 grade 35 fraction still remains quite strong as the standard of care in treating your patients with HPV positive oropharyngeal cancer. It's difficult to beat this standard of care, but I think we should, cisplatin is still indispensable. There's no other agents that can help us. Biological selection probably works, and I feel that there's more, how do I say, research that needs to be done here before we decide that we can switch over. But I think the way I look at it is that if you're looking at low risk features, then chances are we may be able to get away in the future using lower dose of chemoradiation too, in order to improve their quality of life, reduce the risk of long-term toxicity, which a lot of us are familiar with in the radiation as a radiation oncologist. So thank you for listening to my talk, and I hope I presume later that there may be questions that may be asked, and I hope to hear from you later. Thank you.
So that was Dr. Arnil from Malaysia. I would like to welcome Dr. Naveed Humayun. He's a senior consultant and head department of ENT, Head and Neck Surgery, Patel Hospital, Karachi. Sir, thank you for joining us in panel of experts today. Because of my sins, I am the next speaker. So I'll be briefly talking about management of locally advanced oral cavity cancers. There's no consensus on the definition of what is locally advanced oral cavity cancer. Most of the trials have included stage 3 and 4, that means T3, T4, N2, N3, and with risk factors as well. So this is a meta-analysis of systemic therapy in head and neck cancers. The graph A is about the new adjuvant. We see that there is little, if no, benefit from addition of new adjuvant chemotherapy in the treatment of head and neck cancers. The best results are from, which we see in the chart, in the B, which is the concurrent chemotherapy. That gives more than 5% benefit. So chemoradiotherapy or RT after surgery or upfront chemoradiotherapy has been the standard of care for almost 2 decades, unchallenged. But we are living in a very exciting times. The landscape is changing. How is it changing? We'll see about it. This is the slide I presented around 3 years back in the PSCO conference. What's the difference now? Let's talk about new urgent chemotherapy. So let me be clear here. If a tumor is upfront resectable, surgery followed by chemoradiotherapy still is the standard of care. If the tumor is unresectable or borderline resectable, these approaches can be utilized, and we'll see what is the evidence here. I was asked to discuss local regional evidence as well as the international evidence. So first trial I would like to share is the phase 3 randomized controlled trial comparing two-drug versus three-drug combination in neoadjuvant setting. This trial is from India. And they say that addition of TPA, which is three-drug combination, docetaxel, platinum, and 5-FU versus two-drug combination, platinum and docetaxel, it gives us overall survival benefit at the cost of increased toxicity. And if the patient gets a pathological complete response, which is something not that common in head and neck cancers, then the survival advantage is quite meaningful. So this is the randomized trial that reveals that addition of neoadjuvant chemotherapy improves overall survival. And three-drug combination is better than the two-drug combination. And if I go back to the meta-analysis, which shows that there was only about 1 to 2% benefit, but the things are changing here. So this is something really important. Almost the same team that did a randomized controlled trial, they shared their real-world evidence of more than 3,000 patients, something unheard in head and neck oncology, more than 3,000 patients real-world data of neoadjuvant chemotherapy in borderline resectable oral cavity cancers. And we have some very interesting findings here. This is almost something same that does 10-year survival. It's head and neck, locally advanced, borderline resectable tumor, and we are talking about 10-year survival here. The 10-year survival is around 5% with two-drug combination, and it is around 20% with more than two-drug combination. Again, here we see that those patients who become resectable after neoadjuvant chemotherapy, the 10-year survival is around 20%. 10-year survival in locally advanced head and neck cancer, which was borderline resectable, is now 20% with the addition of chemotherapy. And for those patients who were still unresectable after chemotherapy, the 10-year survival was less than 4%, less than 5%. Again, pathological complete response gives us meaningful survival advantage. So the key points which I get from this trial is neoadjuvant chemotherapy, if it leads to resectability, if the surgery is possible, it gives a maximum benefit in survival. So role of surgery is highlighted here. 3 drugs are better than the 2 drugs, of course, at the cost of increased toxicity. And pathological response, if there is a good pathological response, we are getting meaningful survival here. So far, this was the conventional chemotherapeutic drugs which everybody is using for so many years. Now coming to addition of immunotherapy in the locally advanced head and neck cancers. Keynote 689 trial that gives after resection of locally advanced head and neck cancer, that is T3, T4 or node positive, they give 2 cycles of neoadjuvant pembrolizumab followed by surgery, followed by radiation or chemoradiation, depending upon the risk factors, with the addition of concurrent and maintenance pembrolizumab for 1 year. The standard arm was surgery followed by radiation or chemoradiotherapy. Chemo was given in margin positive or with extranodal extension cases. So neoadjuvant immunotherapy, surgery, and concurrent and adjuvant immunotherapy. Here we see that if we look at the bottom C graph, in all patients that are intention to treat, as well as in those who are CPS 1 or 10 positive, we see that there was event-free survival benefit. The advantage was more in CPS score more than 10. Again, there is survival advantage with the addition of neoadjuvant and concurrent and maintenance pembrolizumab in all patients, and the benefit is more in those who are CPS positive. So this is NIVO post-op trial. This was presented in PSCO 2025. What they did, that in the standard of care, which was cisplatin chemoradiotherapy, they add 1 cycle of nivolumab, 240 milligram, for 2 weeks, followed by concurrent along with radiotherapy and then a maintenance 6 doses of monthly nivolumab. One interesting point about this trial was that conventionally we have been adding chemotherapy in margin positive and with external extension. Here what they did, they give chemotherapy to those who have more than 4 nodes positive or if there was extensive perineural invasion. So immunotherapy with nivolumab in the adjuvant setting here. We see that 3-year disease-free survival was increased from 52% to 63%, which was statistically significant as well. So in the adjuvant setting, we are having a role of immunotherapy coming. Now, this is an interesting study. I remember 2 years back on the same forum, I presented this as a negative trial, Keynote 412. For unresectable patients, standard of care is concurrent chemoradiotherapy. So they add pembrolizumab with concurrent chemoradiotherapy followed by 14 cycles of maintenance pembrolizumab. And around 3 years back, the results were negative. The updated analysis that is presented in PSCO this year, they say that there is a trend toward increase in overall survival. The hazard ratio still is not significant, 0.86, and we can see that it is crossing 1. But from 59%, it is 64%. So there is a trend. Maybe the next update may show that there is role of immunotherapy in concurrent chemoradiotherapy in unresectable tumors as well. This trial, again from India, usually what we give is we use cisplatin in concurrent chemoradiotherapy. But there's so many patients in which are cisplatin ineligible either because of age or renal toxicity or their performance status. They included PS2 patients as well and elderly people. There were quite a lot of people who were more than 70 years of age, and they gave 15 milligram per meter square docetaxel in concurrent setting with radiotherapy. And it shows that the disease-free survival as well as overall survival are statistically improved. So this is one of the options to be used in concurrent chemoradiotherapy. Again, this is something interesting. With addition of so many things, we see that addition of more drugs of chemotherapy, new adjuvant chemotherapy, we are getting good survivals. If a patient that has been given us quite a lot of time disease-free, then we can consider going for re-radiation. It is still a lot of work is going on in this field. Usually we say that if it is more than 2 years before first radiotherapy, it is quite safe to go for it. But the evidence is now showing that even after 1 year or after 6 months, there's not much data of using it before 6 months. If there is a recurrence within 6 months, probably we are dealing with a very aggressive biology. Re-radiation probably may not work. But if the time interval is long, then adding re-radiation can give us some meaningful survival benefit here. And again, when we are doing re-radiation, we need to be sure that instead of taking large volumes, we try to take as small volumes as possible, and MDT decision, because MDT tells us whether it is resectable or not resectable. It is for the unresectable ones. And using modern radiotherapy techniques, IMRT, VMET, local control, the various studies, and there have been reports that the local control can be as good as 60% at 2 years. Of course, we need to be very careful about toxicities, critical OARs, because head and neck is an area where so many OARs are jungled up in a small space. It's always better to have a previous radiotherapy plan, the cumulative toxicity doses to OARs, and then it's something that we need to be dealing with very carefully. Again, as stereotactic radiation is, I would say, it has already placed its foot in various sites. Head and neck is no exception. It gives an option for recurrent or oligorecurrent disease, which are unresectable, but lesion need to be small, away from critical OARs. Even in the re-radiation, stereotactic could be used. We need to be, as with all cases of stereotactic, we take tight PTV volumes, and dose ranges from 35 to 50 in 3 to 8 fractions in various studies. But again, this is something new, need to be very careful about this. Immunotherapy will be debated quite extensively. I just want to show a local trial for those patients who are not candidate for any local treatment, unresectable or metastatic, or even after radiation. This is a trial of low-dose immunotherapy, where only 20 milligram of nivolumab every 3 weekly with metforminic, low-dose methotrexate, erlotinib, and celecoxib was tried in the Tata Memorial. And they give us progression-free survival and overall survival with a very low dose of immunotherapy. So immunotherapy, the philosophy here was that the low-dose immunotherapy, there's pharmacokinetic studies that reveal that the effect of immunotherapy doesn't change pharmacokinetically if the dose is from dose of 0.3 milligram per kg up to 10 milligram per kg. So on the basis of that data, they tried low dose and they get promising results from it. This may be important for our patients when we will have the immunotherapy, that low dose which patients can afford easily. Well, of course, there is a lot to be achieved now. We have talked about 10-year survivals in locally advanced head and neck cancer, which was something never heard of. So, but a lot to be done, and we encourage all of us to collaborate for future researches. I thank you all. Sir, please.
Thank you very much for this presentation. So you have mentioned about SBRT in head and neck cancer. So is it now the standard of care for especially oral cavity cancers? So I'm asking this in the background that we frequently see late complications of radiation, especially osteoradionecrosis in the patients in which the bony reconstruction has been done. And this is something which is very devastating for these patients who has come out of all these big surgeries and now ready to have a good life, and suddenly something come up. So now is the SBRT is the standard of care, and if it is, then I think it is not being used in our, at least in Karachi. So we should go ahead towards it.
Thank you very much, Dr. Nabil. That's a very interesting question. And the one-line answer is no. It's not the standard of care. Standard of care still remains surgery, high risk, RT, or plus minus chemotherapy. Stereotactic comes in if patient is unresectable, small volume disease, and mostly because of the medical reasons. But we are using mostly, we are not using in the oral cavity, we are using in oligorecurrent node. Patient unresectable because of medical diseases, or patient already have received previous radiotherapy, it's away from organ at risk, then we can add stereotactic. But as a standard of care, as a first line, no, it is not. The first line remain as surgery, followed by chemoradiotherapy. We are coming evidence that addition of immunotherapy after or in neoadjuvant setting may help. But for as a standard of care, no, it is investigational. I hope that answers your question. सर आपकी आवाज़ नहीं आ रही.
The low dose of nivolumab, you have used it, okay? It is totally for irresectable patients or locally advanced. We are receiving mostly locally advanced patients in this era. I don't know about the KPK, because they might have a lip or oral cancer, but we have oropharynx and tongue and the other part of the oral cavity. Do you use it, nivolumab, methotrexate, and erlotinib in the low dose?
Sir, I have used very few, handpick of number.
And how much response you got and how many cycles?
We get good response. we get good response. But there were few
After
cases.
the failure of platinum compound, or you have given direct?
Upfront.
After the failure of platinum compound.
We have used in upfront, first line, as a first line as well.
Because the gold standard is the platinum compound, right?
Exactly, sir. This trial was also upfront first line, and what I have used is also upfront first line. I have used this as a second line as well.
And you are giving the methotrexate weekly for 3 weeks, then you start the cycle after the 21 days.
So methotrexate is weekly, erlotinib continuous, celecoxib is continuous, and the nivolumab is 3 weekly, 20 milligram per meter square.
Then after
20 milligram flat, sorry.
After the 3 weeks of methotrexate, you have to restart the nivolumab after 3 weeks, or after the completion of 3 weeks of methotrexate.
Sir, methotrexate continues on a weekly basis. Erlotinib is continuous, celecoxib is continuous, and the immunotherapy nivolumab is 3 weekly.
Okay. No, the last methotrexate you are giving in the 3 weeks. After the 3 weeks, you have to restart the cycle of nivolumab.
Restart the cycle.
There will be no gap. Right?
No, there will be no
And
gap.
how much response you have got in how many cycles?
Sir, I have one case. After 3 weeks, I take it to MDT. It was unresectable. Now there was barely any disease. But this is one case. We need to be very careful here. This was one case.
Okay, as a Dr. Saab said, the standard care of head and neck is the surgery, and you also agree, and I also agree. Most of the people, when we are receiving the patients, the margins are very positive, and the tumor recurrence within 6 months or within 9 months. So do you recommend the induction chemotherapy, adjuvant chemotherapy in these people, the nivolumab?
So we haven't used adjuvant nivolumab. I don't have any experience. But if the margin is positive and further surgery cannot be done, what is our practice is we offer concurrent chemoradiotherapy. And if the disease recurs, we take it to MDT. If it is resectable, we go for surgery. If it is not resectable, then we go for palliative chemotherapy. Sometime I have a handful of cases where the recurrence was after so many years. I have few cases where recurrence was after 2 years. Then we take to MDT, they say it is unresectable, we re-radiate it.
Okay, thank you.
Welcome, sir.
Can I just comment over here? So here we are talking about two different groups of patients, you know. If this is a positive margin or accelerated extension, it's still radical patient and we intend for cure. And after surgery, we go for chemoradiation, that's standard.
That's right.
This nivolumab thing is purely palliative when we have like failed all local treatments and now disease is recurrent and there's no other local options. So this is a palliative setting. Actually, the question will come that from extreme trial, this used to be chemotherapy and then Pembro. Will it be now nivolumab with methotrexate?
We are going to have a discussion on immunotherapy, yes.
Yeah.
Still, you're right, surgery followed by chemoradiotherapy or radiotherapy is the standard of care. The nivolumab, the trial, Patel's trial, it is in the palliative setting. So what I will say that if you have a good response, the biology is different for everyone. If you have a good response, addition of surgery, addition of more number of cycles, addition of re-radiation is giving meaningful response. But we have to tell it individually as per the patient's need. As far as the standard of care we are talking, it still is for a resectable surgery followed by radiotherapy or chemoradiotherapy. For borderline, we are offering neoadjuvant. These are the MDT decisions.
So the question is, again, as Dr. Saab said, pembrolizumab along with cisplatinum, what you will say about the cetuximab, pembrolizumab, nivolumab, which one you will choose?
Sir, sorry, can you repeat, please?
We have our next speaker that will talk about systemic treatment, isn't it?
Okay. Okay. Let's go with our next speaker. So we are now going to have a talk by Dr. Khurram Shehzad on systemic therapy for recurrent metastatic head and neck cancer, immunotherapy in practice. Dr. Khurram Shehzad is a radiation and clinical oncologist at King Faisal Specialty Hospital, adjunct assistant professor, King Faisal University, Riyadh, Saudi Arabia. And Dr. Khurram, please.
Thank you so much for inviting me here, especially to the organizers and Dr. Azhar, who is president. Talk. It will be from here. So when I was given this talk, what I was conveyed that Dr. Arif is the moderator of this meeting. He's no more with us, but mashallah, he was such a crowd puller that if he would have been here, this whole hall will be full audience almost. He's no more with us, but he's my mentor and many others like me, and he will remain in our hearts forever. How can I? Okay. So, okay. So, systemic therapy in metastatic and recurrent head and neck cancer is my topic. Basically, what we will, as we know that metastatic cancers are recurrent cancers, the basic intent is palliation. Goal is to prolong survival, symptom control, and maintain function and quality of life. We have to consider before starting systemic therapy what prior therapies patient has received. If we are considering immunotherapy, we have to get CPS score, and also we have to consider the comorbidities, if there is any autoimmune risk with the patient, post-transplant on immunosuppression, and we should test key biomarkers, especially PD-L1, CPS score. And in all cancers, but especially in head and neck cancer, we have to consider nutrition, speech, swallowing, and other palliative like pain control. So if we see as a standard before PD-L1 era was for this population of patients which are metastatic, the standard was chemo, and later on chemo EGFR combination was the backbone. And this was the trial, Extreme, that gave us the pivotal evidence about combination chemotherapy with EGFR inhibitors. This was, the population was untreated recurrent metastatic head and neck cancers. And as you can see, it showed some survival advantage, but there was significant progression-free survival advantage, and also there was very good objective response rates. So after that, Extreme became the benchmark control for subsequent first-line recurrent metastatic trials. But in Extreme, 5-FU was used, which was infusional, and also the toxicities of 5-FU, diarrhea, mucositis, neutropenias, that raised to consider some alternative. And this came from this GOTEC trial where they used docetaxel instead of 5-FU. And the result was not as impressive as Extreme trial, but still it showed lower grade 3 toxicities, and it was interpreted as alternative regime, not superior, not new standard, but as an alternative to 5-FU, it was used. If we are thinking of using immunotherapy in first line in these metastatic patients, so Keynote 048 is the trial which gave us the evidence. The population of Keynote was basically, as we said, untreated metastatic head and neck cancers with good performance status, and they were assessed for PD-L1 CPS score. As we all know that it is combined positive score, which shows tumor staining of PD-L1 along with lymphocytes and macrophages, and it is divided by the total tumor population to get CPS score. They randomized equally 3 arms. One was Pembro monogroup, other was Pembro with 5-FU platinum, and third was the control arm, which was Extreme like platinum, 5-FU, and Stuximab. And the endpoints were overall survival and progression-free survival as the primary endpoint. Secondary included objective response rates and response. If we see this bar graph, the color coding, the dark green color is showing Pembro chemo combination, light green is Pembro alone, and light gray, dark gray is the control arm, Stuximab 5-FU. This is the total population, and we can see the Pembro containing regimes are showing survival advantage. If we see the subgroups, the group with more than CPS score and the group with less than CPS score, both of these are showing survival advantage. So adding of immunotherapies is showing survival advantage in all groups. As we know that chemotherapy is quicker in showing responses as compared to the immunos. So if we see the objective response rate, the gray bar is showing more heights. The reason is the quick response with chemo-containing regimes. But if you see the median duration of response, once they responded to immunotherapy, you can see the response is more durable with immuno-containing or pembro-containing regimes, pembro alone or with chemotherapy. And also the toxicities, especially the hematological toxicities, are lesser in the pembro-containing groups, and especially the pembro mono group is showing very minimal hematological toxicities. So what should be the practical algorithm? If we find a patient with recurrent metastatic head and neck cancer, we want to treat them incorporating immunotherapy. We should get PD-L1 score, and if it is more than 1 and we do not need some rapid regression of the tumor, we can start with pembro alone. If CPS is less than 1 or we want a rapid response, we should consider a combination of pembro with chemotherapy, or if it is not available upfront, we can start with the extreme-like regimen. What about if we use these immunotherapies, PD-L1 inhibitors, as second line? We got the evidence from these two trials, Checkmate 141 and KN040. Checkmate used nivolumab single agent versus investigator of choice single agent chemotherapy post-platinum. It was a phase 3 trial, and they randomized in 2:1, nivolumab versus investigator's choice single agent chemotherapy, methotrexate, dosi, or cetuximab, whatever. And primary endpoint was overall survival. Here, the overall survival was showing some favor in the nivolumab arm, but it was not impressive. But if you see at the landmark, 1 year's overall survival, it was 2 times higher patients were alive in the nivolumab group. And even at 2 years, it persisted. Even it was three times more patients were alive in the nivolumab group as compared to the chemo group. Also, progression-free survival was better, toxicities were lesser, response rate were also favoring nivolumab group. This evidence was consolidated with the KN040 trial, which used pembro post-platinum versus, again, single-agent investigator's choice chemotherapy. And here, again, primary endpoint was overall survival. Overall survival was not statistically significant, but there was lesser immune-related events and side effects in the pembro group, which supported the PD-L1 as standard option after platinum chemotherapy. So if patient progresses on first-line drugs, which for first-line treatments, if the progression is on immunomonotherapy, we can switch them to chemotherapy. And if there is progression on immunochemotherapy, we can start with single-agent chemotherapies or cetuximab-containing regimes if they are not used before. If, we have talked about the positive trials. People have tried combinations with PD-L1 agents and with CTLA-4 blockers, but they all resulted so far negative. They used durvalumab. In Checkmate, Nivo was combined with EPI, and Checkmate 651, Nivo, EPI again versus extreme. But all this came as negative so far. So dual checkpoint inhibitors, we should still we do not have any evidence of them to use as a combination in this population of patients. As always, every cancer treatment has some side effects, and especially the immunos, as they are new in this field. Their side effects are also somewhat unique. They are mainly immune-mediated, and they are not dose-related. They can affect any system in the body, starting from skin, GI, lungs, liver, and endocrine pathogens can be there also. There are some rare events in the form of myocarditis and neurological syndromes, but if these side effects appear, we should not consider to re-challenge them with immunotherapies. The management of the immuno side effects are grade-based. Grade 1, we can use with close monitoring aminos. I mean, we can use aminos. Grade 2, we can hold them for a while and can use oral steroids. For grade 3, we have to stop drug maybe, and then we have to, this patient may need admission with high dose steroids and observation. And as we said before, supportive care along with the chemo or immunotherapy is also part of the management in this group of patients, and we should consider all these things when we are managing them. So what are the key takeaways? First line standard is pembro-based chemotherapy or pembro alone, depending upon the CPS score. If it is more than 1 and patient is stable, we can consider pembro monotherapy. If we need urgent response, we can use pembro platinum, but CPS should all, or if it is CPS is less than 1, we should also consider combination. After platinum, we can use nivolumab and pembrolizumab, and we have evidence for that also. Chemo EGFR regimes are also, they can remain standard after drug progression. Dual checkpoint inhibitors have been tested, but so far has not replaced the standards. Briefly about systemic therapy for metastatic nasopharyngeal cancers, as they are a different population than the other head and neck cancers. As we know that these cancers are heavily influenced by EBV. The EBV is one of their, in 90 to 95% of the patients, they are associated with EBV. So this is the biomarker we should consider when treating EBV as a baseline to assess the prognosis. And if we do it, we can use it for a response evaluation. And also on follow-ups, it can give us a hint of progression or metastasis. And now we can also consider PD-L1 testing in these patients. In nasopharyngeal cancer, with this Chinese trial, we know that in this population of patients, GEMCIS is a validative chemo backbone. We can add a PD-L1 inhibitor with GEMCIS to improve the first-line outcomes, and we have 3 phase 3 trials, which shows halving of progression risk with addition of immunotherapies. What should be it? It's chemotherapy along with PD-L1 and followed by maintenance. How it works? It works in all cancer patients. If we consider immunotherapy, we know that nasopharyngeal cancers are having a PD-L1 legend. PD-1 receptors are linked on the T cells, which is an inhibitory receptor. This inhibitory receptor is activated by combining with the PD-L1 and causing inhibition of the T cell anti-tumor activity. What we administer amino drugs are PD-L1 blockers. They inhibit PD-L1, PD-1, and it causes reactivation of T cells and its action on the cancer killing. These 3 trials are showing addition of immunotherapy along with GEMCIS have shown progression-free survival advantage. Jupiter, they used toripalimab. Captain trial used pembrolizumab, and Rational used silazolumab. And all these have shown progression-free survival advantage. As we talked, that gemcitabine cisplatin is the new standard, and this as first line in metastatic nasopharyngeal cancers also, and it was compared with the previous standard 5-FU cisplatin, and we can show statistically significant results in overall survival and progression-free survival. And addition of immunotherapies we can see all are showing a good progression-free hazard ratio in all these trials, Jupiter, Captain, Rational. Jupiter 02 is the only trial which has also shown established overall survival benefit for tremelimumab when it was added with chemotherapy. Maintenance is also an essential part when we start immunotherapy. Maintenance is there until progression or toxicity, and all of these trials, they kept on using till progression. There is another trial which used TPC as induction, and they used capecitabine as maintenance. So if we use capecitabine as maintenance after taxanes, it has its own side effects. But we can also use, after progression with chemotherapy, we can use capecitabine as single agent, taxanes, gemcitabine, and we can re-challenge platinum, but we have to consider how much was the platinum-free interval. So this is the algorithm for metastatic cancers. If they are fit for cisplatin, we should start with PD-L1 and gemcitabine cisplatin. And if progression, we can consider some clinical trial or immunotherapy if not used before. Not fit for cisplatin, we can replace it with carbo along with PD-L1, PD-1 combination. And on progression, we can use other chemo options or a clinical trial. So again, the tip is, if a patient is on immunotherapy having some side effects like cough, dyspnea, and diarrhea, we should act early. Thank you so much. Actually, maybe this was alarm for me to finish. So thank you so much.
Thank you, Dr. Khurram Shahzad. Now I am going to invite the team lead of ONCO 2026 Organizing Committee, Dr. Muhammad Ali Memon, who is one of our most senior clinical oncologists with over 30 years of experience and legacy of leadership at JPMC Karachi. He will be talking about oral cancer prevention strategies survey. Dr. Muhammad Ali Memon, please.
Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Thank you very much, Dr. Salman and the panelists. It's a really great pleasure to have you people here. And actually, I've been involved with the oncology, field of oncology since 1986. I started my career at JPMC, then Nimra Jamshoro, the birthplace of the Pakistan Society of Clinical Oncology, and then Shaukat Khanum Cancer Hospital, Lahore, and then the rest of my career until my retirement, I've been affiliated with Pakistan Atomic Energy Commission, AEMC, Jinnah Hospital. Currently, I'm working at Indus Medical College, Tand Mohammad Khan, and as a clinical oncologist at NCCI Hospital, Karachi. Today's topic is oral cancer prevention strategy proposal. Actually, with Pakistan Atomic Energy Commission and Pakistan Society of Clinical Oncology, we have been involved in the preventive oncology for over a period of decades. And we've come across that oral cavity cancer is a real problem in this part of the country. And so much so that it's the most common cancers globally. It's in the Pakistan, which is the most common cancer in Pakistan. So we try to make some effort to see what the status of problem in our setup. So it's saying when there is a problem, there is a solution. So we come across this problem with oral cancer. So first we identify the problem, then the gravity of the problem, and then we can identify the solution. So social sector is well aware of the poor oral health in our community. You can see this is, where is pointer? This is the problem in social setup. Pakistan, especially in Karachi, we are looking at around that most of the people are taking gutka, manpuris, and spit here and there with bad oral cavity status. Civil society and public health authorities realizes that oral cancer is a major health issue in Pakistan, especially in south of Pakistan. Globocan estimates suggest this is the lip and oral cancer cavity rank 16 globally. This is ranking 16 in globally, but unfortunately, this is the, again, Globocan estimates that Pakistan has the topmost, the most common cancer in Pakistan is oral cavity cancer in males, while it is second most common cancer. Oral cancer is the second most common in both the sexes. It amount for 8.6% of the patients in both the sexes, while it's 12.3% of the cases in males. This is the real-time data Pakistan, from 21 cancer hospitals of Pakistan Oncology Commission serving throughout Pakistan. That data suggests the 14.5% of the cancers are oral cancers in male, while 5.9% of the cancers are in female, and that is the second most common cancer, third most common cancer, and second most common cancer in overall, both the sexes. That is amount for 9.7. Now we try to get into the gravity of the problem. We have conducted a survey and oral health assessment of randomly selected otherwise healthy population. Objective was to assess the gravity of the oral health issues in our community. Method was to a pre-defined questionnaire was given to a study population to respond accordingly. Then in the same sitting, they all them subject to assessment of oral health by a qualified dentist. The health assessment was done according to Australian Welfare Dental Score Protocol. Dr. Mohammed Ali sitting from Australia. And setting was with the consent of the study population. Information technology students were there at Selani International Welfare Trust, Karachi, and attendance of cancer patients at St. Elizabeth Hospital, Hyderabad. And all belongs to low socioeconomic status. This was the pro forma which we have given to study population, and then this was the assessment protocol which our dental surgeon gone through and examining those of our patients. Total population, study population is 71, 62 male and 9 were female. Age ranges from 13 to 61 years, mean 32, median 30, and mode was 19. Comorbs were seen in 14% of the patient, 84% had no comorbs, 1.4 missing data. Use of tobacco products were seen in 40% of the patients, while no tobacco consumption was recorded in 60% of the patients, population. Addict of narcotics were documented in 2.8%, while 55% of the study population had no narcotic addicts. 42 data missing. Dental care in those study population were evaluated, and toothbrush and with or without paste were used in 70% were using toothpaste and toothbrush and paste, while miswak was used by 15% of the study population. No dental care was also noted in 8.4% of the study population. 7% had missing data. Bad smell from mouth was documented in 30%, while sensitive teeth and pain was in 23% of the study population. Trismus, the submucous fibrosis, usually we have quite frequently seen. 15% was noted in this study population. Then our dental surgeon who were recording or examining these study population had that score of 0, that is healthy. Oral condition was noted in 5.6% of the population, while score 1, those who need dental consult, had 43% of the study population, while score 2, that is unhealthy and need intervention, orodental intervention, was noted in 45% of the study population. That is actually the bigger one, and we are very much conscious about this unhealthy population. Limitations faced during the interaction with study population was quite a few need active assistant to fill the survey questionnaire. Understanding issues were there. Study population had no or limited knowledge of proper dental care. Most of the study population clean their teeth only in the morning, with or without brush, or without paste, or some people are doing nothing. So now we are coming to the possible remedy. What should be done? How can we reduce risk of oral cancer? So these are the 6 parameters which can be utilized for proper oral hygiene or can reduce the risk of cancer. 1, visit your dentist, which is costly in our setup. Check your mouth regularly. This can be done. Avoid smoking and alcohol. This can be done in our setup. Protect your skin with sunscreen. This can be done. And look after the dental teeth and mouth. This can be done in our setup. Don't delay in seeking advice from dentist or a medical professional that is actually expensive. So we try to make something about compare the toothbrush and miswak use. After going through the literature, it has been noticed that the toothbrush is made up of plastic handles and nylon bristles. And their paste is composed of many ingredients which are oral cavity protective. While miswak is a natural chewing stick, and it has the ingredient which also helping our oral health, and it can be anti-cancer. So this is the list of 15 ingredients which are present in the Salvadora persica, that is miswak. Toothbrush, actually, risk of illness, especially cancers, I'm talking about the risk related to toothbrush and the miswak. So handle is made up of plastic, that is biodegradation is many years, it's almost 500 years. If a plastic is thrown into the domestic waste. So its degradation is over 500 or more years, while the nylon can be degraded in 30 to 40 years. Relatively cost is higher than the miswak, and the high risk for environmental pollution, water and food contamination is common if we throw it into the domestic waste without treating it. Miswak is a natural, Salvadora persica is a natural biodegradation. There is no environmental problem. Ingredient help to prevent many diseases, including oral cancers. That is cost effective. Miswak is a religious practice in our Islam, So, we come across that that was our opinion that miswak is better than toothbrush because it contain oral health promoting ingredients. It can, sorry, I'm just running out of time. It can contain oral health promoting ingredient. It can prevent many diseases, including oral cancer. It is environmental friendly and it is cost effective. So we propose that a visit dentist periodically is a costly issue. Check our mouth regularly is easy to manage. Avoid tobacco and alcohol is also easy to manage. Look after teeth and mouth is important, and that is we can use miswak instead of toothbrush and toothpaste. We are not actually against the toothbrush and paste, but relatively, if you use miswak, that is better than toothbrush because it is environmental friendly as well. Don't delay in taking advice from dentists or medical professionals. These are our proposals. So thank you very much. Any question? I'll be try to answer. Thank you.
Can I just comment on maswak and brush? So I think the message is dental hygiene. And if we look at the oral cavity incidence, the highest incidence is in Pakistan and India. Yes. If we look at the Western world where they're not using maswak, they're using toothbrush for years and years. And the incidence of oral cancer is almost negligible. So I think the message should be dental hygiene rather than saying that miswak is better than toothbrush, I would say.
Yes, you're right. Our actually the bottom line is oral hygiene. That can be done better with miswak, in our opinion, in our group of people we are working on. So this is our proposal. It can be worked because our target is, this is the data of 71 population. Otherwise normal population. And our target is 1,000. We will try to survey the 1,000 people, and then we will try to publish the data of those 1,000. Because we have to rectify the problem in this. It's a pilot, actually. And we are trying to modify the sequences. And ultimately, our target is 1,000 cases. So I hope we will come up in next meeting with some better results.
I have one comment. If there is a law, but there is no implementation, there is restrictions to sell the tobacco. If we control the tobacco via social media or print media or electronic media, we can reduce the burden of head and neck cancer by one-third. So we have to focus on reducing the use of tobacco or ban on tobacco. Legally, there is a law, but there is no implementation.
It's a long discussion.
From this society and the other societies which we are working, if we put on the social media, even if one patient can get benefit and he quit the smoking, he may survive.
This is just a proposal, and we will talk. It's a long discussion. We will talk in later on. So, podium is to Zishan.
Thank you, sir. Now I would request Dr. Mariam Noman. She will be participating in the debate on upfront immunotherapy in locally advanced head and neck cancer versus upfront surgery. She will be speaking for promising neoadjuvant data may improve pathological response and survival. She is Assistant Professor and Head of Medical Oncology at Dow University Hospital and Comprehensive Cancer Center, where she established the services of medical oncology. Dr. Mariam Noman, please. Ma'am, we would have question and answer afterwards.
Assalamu alaikum everyone, and a very good morning. First of all, I would like to say thank you to PSCO and specifically to Dr. Azhar for having me here and to talk about it. So before we begin, I've known Dr. Azhar since I was a medical student, and whenever he calls me, he says, I still have your number as an intern. So I tell him, just let it be like that. So long association, thank you so much for having me here, sir. So for the next 10 to 11 minutes, I'll be talking about the role of neoadjuvant immunotherapy in head and neck cancer. We have listened to the talks, and we know where we place immunotherapy in metastatic and locally advanced diseases. So now is the time we move on and we learn about the role of neoadjuvant immunotherapy in head and neck cancer. So why the resistance? Now, why is this a rebuttal? So basically, there are certain concerns which are raised by the surgeons. A debate between a medical oncologist and surgeon happens every now and then, particularly in the MDTs. So the concerns are that there could be delay to surgery, there could be surgical complications, there is no survival benefit, and of course, cost and feasibility in the LMICs. Now, the data now that we're going to discuss in the next 10 minutes will address all of these concerns. So what is the biological rationale? Whenever we are talking about anything in the neoadjuvant or the adjuvant setting, we have to understand that what is the biological rationale behind it. So in the pre-surgery time, there is intact tumor which acts as an antigen reservoir. There is better T-cell priming pre-surgery. There is early control of micrometastatic disease. And there is superior immune memory versus adjuvant therapy. We all know and we all see in the clinics that the kind of head and neck cancer that we see in our clinics, they always present with locally advanced diseases. And even after receiving standard of care surgery and adjuvant concurrent chemoradiation, these patients tend to relapse very early on. In our practice, we tend to do a baseline CT chest in all of these patients, and many of these times, these patients relapse in the chest later on. So micrometastasis is, of course, a concern which has to be addressed earlier on, which is not addressed only by concurrent chemoradiation done in the adjuvant setting. So we all know how PD-1 and PD-L1 blockade works, and it basically helps the T cell to kill the tumor cells, which initially has evaded the immune responses. So coming to the data, the phase 3 trial Keynote 689, which was also presented in ASCO 25, it is a phase 3 trial in which the patients with locally advanced resectable head and neck cancers, I would really stress upon the word resectable, because this trial did not include patients which were borderline resectable or were unresectable to begin with. So we are talking about patients who had locally advanced but resectable head and neck cancers, and they were randomized 1:1. To go on and undergo surgery, followed by standard of care concurrent chemoradiation or radiation by the virtue of their path responses, versus these patients were given two cycles of pembrolizumab at a dose of 200 milligrams IV 3 weekly for 2 weeks, followed by surgery which was done within 6 weeks of giving immunotherapy, followed by adjuvant radiation or concurrent chemoradiation, during which 3 cycles of pembrolizumab were added 3 weekly, followed by 12 further doses of pembrolizumab in the adjuvant setting. So basically, these patients receive a total of 17 cycles of pembrolizumab, 2 in the neoadjuvant setting, 3 along with their radiation or concurrent chemoradiation, followed by 12 further doses of adjuvant pembrolizumab. The primary endpoint of the trial was event-free survival, and secondary endpoint were overall survival and safety. So let's look at the event-free survival. We can see the curves well separating from each other, and at the median follow-up of 36 months, there was a significant difference in event-free survival at around 59% versus 45% for the treatment arm, for the experimental arm versus the control arm respectively, with a significant hazard ratio and p-value. So looking at the CPS 10 or more or 1 or more, we can see the curves are well separating in both the populations, meaning that all the patients, whether they were CPS 1 or more or whether they were CPS 10 or more, they all benefited from the addition of pembrolizumab in the neoadjuvant and then in the adjuvant setting, meaning perioperative immunotherapy. So let's look at the pathological responses. Of course, the standard of care arm did not achieve any pathological responses, but the patients who went on to receive 2 cycles of neoadjuvant pembrolizumab, they did have some major pathological responses, and there were also some complete pathological responses reported. What do we mean by major pathological response? Less than 10% residual disease in the pathological specimen. And we all know that more is the pathological response, more that eventually translates into a better disease-free survival, and it is also a surrogate marker for better survival. So distant metastasis-free survival was also better in the patients who received neoadjuvant immunotherapy. What do we understand by this? We have to understand that it is also curtailing the risk of disease to spread, the distant failure basically, because we'll come back to it. So when we talk about the safety profile, all of these patients who received immunotherapy, they tend to have, 10% of these patients tend to have more immunotherapy-related adverse events as expected. Rest of all side effects were similar between the experimental arm and the control arm. So let's look at this, the time to locoregional failure. So the time to locoregional failure was approximately similar between the 2 arms because the locoregional failure is particularly addressed by the adjuvant radiation or the adjuvant concurrent chemoradiation that we're giving in these patients, which was of course offered to both the arms. But we see major differences in the event-free survival. Now why is that? Because even if the time to locoregional failure is similar, the addition of neoadjuvant or perioperative immunotherapy is actually helping with the distant failure as well. Of course, addressing the micrometastasis and systemic failure, which is why the event-free survival has significant differences. So early versus early neoadjuvant immunotherapy evidence, it comes from the phase 3 Keynote 689 trial. We see pathological responses at somewhere between 20 to 40%. There was no delay in surgery. Both the control arm as well as the experimental arm, around 88 to 90% of these patients went on to receive, to complete surgery. There were acceptable perioperative safety as well. And there was significant improvement, as we said, in the event-free survival, and the benefit was seen across all PD-L1 subgroups. There were higher tumor regressions, there was improved disease control, there was surgical safety, there was no increase in surgical complications, which is primarily a resistance or a concern raised by surgeons. There was no delay to definitive treatment, there was no compromise in R0 resections, and it addresses the core surgical concerns. So why does this matter in LMIC? As I said earlier, that there's always a debate that immunotherapy comes with its cost. But a patient who comes to me in clinic who has a heavy burden of nodal disease, who has a resectable but locally advanced disease, I am bound to advise that patient a PD-L1 score if affordability is not an issue. Because when we talk about evidence, we do have to keep the financial part into consideration, but we talk evidence, right? So if there's a patient who has no financial constraints, who has a resectable locally advanced disease, I would definitely advise PD-L1 testing, and if the patient has a good CPS score, I would advise that patient neoadjuvant immunotherapy, because we know that these patients can tend to relapse early. They can have systemic failure. Many of the times these patients relapse in the lungs. So neoadjuvant immunotherapy ensures early systemic treatment. Cost perspective, you see, we talked about Keynote 048 right now, that in the metastatic setting, that is an immunotherapy which is going on and on until progression, or at least until 2 years. But right now we are talking about 17 cycles only, meaning there's a timeline, there's a limit, and with limited number of cycles, we can achieve a better event-free survival, prevent micrometastasis, prevent systemic failure itself. So limited cycle, we're not talking about lifelong therapy as we do in metastatic settings. There's potential reduction in recurrence. As we know that recurrent cancer is the most expensive outcome that we can see in oncology. So the take-home message would be the neoadjuvant immunotherapy is very safe, it improves disease control and event-free survival. So the main part of the question of this debate is not if neoadjuvant therapy should be offered, but rather who should receive it. So I would conclude by saying that any patient who has locally advanced resectable disease with at least a CPS score of 1 or more, those patients should be offered neoadjuvant immunotherapy. And it is very important to understand, and I would again stress upon it before concluding, that it is only for, the data is only for resectable locally advanced diseases. We are not currently using it as a standard of care evidence-based practice in any patient who has unresectable disease. Hence, there is no role of immunotherapy in induction as such in a patient who has unresectable disease to begin with, or even borderline resectable, because if there's a borderline resectable tumor, and if we tend to give immunotherapy to that patient, we may lose the opportunity to treat that patient altogether. So, with the curative intent, of course. So remember, it is for resectable locally advanced patients who have CPS of 1 or more. With that, I conclude. And Dr. Arif Jamshed, he's deeply missed in the session today. I've known him since more than a decade, and another drive for me to come today was to be able to meet him. So we miss him a lot. Thank you.
Thank you, Dr. Mariam. Now, our speaker who will be speaking against upfront immunotherapy in locally advanced head and neck cancer is Dr. Murtaza Hussain, who will be speaking, not ready for routine practice, no proven survival benefit in definitive setting yet. Dr. Murtaza is working as a postgraduate trainee in Department of ENT Head and Neck Surgery at Patel Hospital, Karachi. Dr. Murtaza, please.
Assalamu alaikum everyone, this is Dr. Murtaza Hussain. So the topic of my presentation is same, which is upfront neoadjuvant chemotherapy in locally advanced head and neck cancers versus the upfront surgery. But I will be presenting the evidence against this routine practice. So starting with the NCCN guidelines. So according to NCCN, if we are treating the patient with a curative intent, whether the disease is T3 or T4A disease, the standard care of treatment is surgery, which is followed by adjuvant treatment. Exception is the T4B disease. When we are treating patient with a palliative intent, then there is a role of induction chemotherapy, but still no role of surgery after the neoadjuvant. So having this brief introduction of the NCCN guidelines, we will move to the role of neoadjuvant chemotherapy. So neoadjuvant chemotherapy is basically considered to have these basically roles, which are the improved locoregional control and overall survival, mandible preservation, borderline resectable or the tumors which are technically irresectable, to reduce the surgical margins, having to achieve R0 resection, and improvement in survival in unresectable tumors. So these basically are the common regimes which are commonly used in the patients in the neoadjuvant setting, which are the TPF, the carbopecli regime, and the newly introduced the triple metronomic chemotherapy. But still, its role has only been observed in the palliative intent, not in the neoadjuvant setting when treating the patient with curative intent. So for this, we have a phase 3 randomized clinical trial study in which there were 114 patients who had locally advanced head and neck cancers, and they have compared the both groups in which the standard chemotherapy regimen was given, and in the treatment arm, the TMC regime was given. And they have shown that after a follow-up median of 258 days, the overall survival and progression-free survival of the disease both have been improved with a significant p-value. But this study was conducted with a palliative intent, basically. So does NACT really improve disease-free survival and overall survival? So we have some studies. So So this is basically a clinical trial which was published in Journal of Clinical Oncology in 2003, and they have divided the patients into two arms. The first is the treatment arm and the other is the control arm. The drawback of this study basically is that they have included both the patients and the tumor demographics include T2, T3, and T4 stage tumors, which include both the initial stage tumors and the advanced stage tumors. And they have reported that the 5-year overall survival estimates were comparable in two groups, and there was no significant survival benefit obtained in both the groups. Similarly, the loco-regional relapse and the distant relapse, along with the occurrence of second primaries, also showed no significant superiority in the NECT group. So basically, as we discussed, its drawback that it includes both the both the initial and the late stage tumors, and we know that neoadjuvant has no role basically in the initial stage tumors. That's why it could be a possible factor that NECT has not shown any survival benefit in this study. So for this, to answer this question, we have another study in which they have included only the locally advanced squamous cell carcinoma patients. And again, they have divided the patients into two groups, the control arm and the treatment arm. And now in this study, they have only included the patients who have advanced stage disease, like T3 and T4A disease. And what they have shown, that in their study, there was inferior 3-year disease-free survival was detected in patients after the neoadjuvant and surgery group as compared to the patients which underwent upfront surgery. And it was 40% versus 58%. However, overall survival was comparable in the two groups. So what caused this basically inferior 3-year disease-free survival? They have reported that the biology of every patient is not same basically. And some patients show response, and while some patients do not show response, and this may delay the timing of treatment and increase the risk of, increase the surgical risk basically. And they have also reported that the timing of neoadjuvant has shown that when the delayed time to surgery is over 34 days, the 3-year disease-free survival is significantly worse. Similarly, to support the evidence against this routine standard of care, we have another article, which is a randomized phase 3 trial, in which again they have taken the advanced stage disease and divided the patients into two arms, in the treatment arm and the control arm. And what they have reported that after follow-up median time of 11.5 years, still there was no significant superiority of the neoadjuvant treatment arm in the disease-free survival and in the overall survival, as can be shown in these two graphs basically. To support the evidence, we have another article in which again they have seen the disease-free survival and the overall survival between the treatment arm and the control arm. And a new thing in this study, they have also compared the margin status between the two groups. And what they have reported, that there was no superiority in getting negative margins or closed margins in the NCT group when compared with the patients who underwent upfront surgery. And again, they have also reported that the disease-free survival in the patients who underwent upfront surgery was quite better when compared with the patients who underwent NCT group. And again, the reason was the patients, a large number of patients did not show good response to the neoadjuvant treatment. Moreover, this study basically includes advanced and very advanced stage diseases like T4A and T4B diseases. And in their results, they have shown that the overall survival and disease-free survival was better in the T4A group who underwent upfront surgery with a significant p-value. However, in the T4B group, the Kaplan-Meier curve showed that the NECT group followed by surgery has better overall significant survival in this very advanced stage T4B disease. So this is basically some role and good evidence of promising results in the T4B stage category. So another role for which usually neoadjuvant is usually given is the preservation of mandible. So as we know that organ preservation is a main task in every patient who is undergoing any oncological procedure. And to support this evidence, we have an article which was taken from Journal of Clinical Oncology. So in this article, basically they enrolled 68 patients who had no radiological evidence of any erosion of the underlying mandible bone. And they divided the patients into two arms, the intervention arm, which underwent 2 cycles of NECT, docetaxel plus cisplatin plus 5-fluorouracil, and the standard arm which underwent upfront surgery in which segmental mandibulectomy was done. So what they found that in the NECT group, there was 47% of the population in which mandible was preserved, and in them patients, there were 15 patients out of 34 in which marginal mandibulectomy was done. So this shows that NECT enabled mandible preservation in nearly half of the patients who underwent induction chemotherapy. However, no survival benefit in terms of overall survival and disease-free survival was observed in both the groups. So we have a large data in which we have an article which highlights, which is a systematic review and a meta-analysis. So it includes 3 randomized clinical trials and 5 retrospective studies, including 493 patients with NECT treatment and control arm, which includes 888 patients who underwent upfront surgery. So in this systematic review, basically they included all the initial stage tumors and the advanced stage tumors, and they have both the arms, the study arm and the treatment arm basically. And what they reported that the meta-analysis for overall survival at 2 years and 5 years revealed no statistically significant difference between the both groups who underwent NECT or upfront surgery. And the overall estimate or relative risk ratio from the study with 5 years of follow-up was 0.92. And the same goes for the disease-free survival at 2 and 5 years. Still no significant data was retrieved in this systematic review and meta-analysis. And the risk ratio for the studies with the 5 years of follow-up was 0.99. And the last, the role of NECT on unresectable tumors. So for this, we have an article from Oral Oncology, in the title of which is Neoadjuvant Chemotherapy followed by surgery in very locally advanced, technically unresectable oral cavity cancers. So basically, they included 721 patients in which technically the tumor was unresectable, and they give the patients a 3-drug regime in 74 patients, and while the remaining 647 patients received 2-drug regime. And what they reported that after giving this regime, a total of 310 patients showed significant reduction in tumor size and underwent surgical resection. And after resection, 100% of the patients received R0 resection, and 97% of the patients had clear margins which were greater than 5 mm. So this basically an evidence which is supporting this NECT treatment. However, it has some cost which is in the form of adverse effects, and this study from Journal of Clinical Oncology basically highlights some of the adverse effects which patients usually encountered during the induction chemotherapy, which are the hematological toxicity, diarrhea, alopecia, nausea, altered liver functions, and febrile neutropenia, and in which the major highlights are the alopecia and nausea and vomiting, which are reported in this randomized clinical phase 3 trial. So concluding my presentation, upfront surgery ensures immediate local control, while neoadjuvant therapy offers no guaranteed tumor response, and non-responders basically are at risk of disease progression, and loss of operability during the neoadjuvant therapy. And neoadjuvant therapy can delay definitive treatment, and plus it also has some cost, which is in the terms of adverse effects. Thank you.
Thank you, Dr. Murtaza Hussain. So far, we are blank on time. So I would request Dr. Nabil Humayun to moderate the discussion for the debate, which was on upfront immunotherapy in locally advanced head and neck cancers.
Assalamu alaikum. Thank you very much. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Thank you very much, organizers of this esteemed conference, to give me this task, actually a difficult task. So after listening to these two discussions related to this I would say, developing thing in the head and neck cancers. So I have prepared a few scenarios, and I would like all of you to actually, we would walk through these scenarios to come up with some conclusion that what should be done. So just briefly, I would explain the first scenario. So this, okay.
Can I just comment before we go in that? I think we will be unable to conclude because these were two entirely different questions. Dr. Mariam spoke about the role of neoadjuvant immunotherapy in head and neck cancer. And actually, that's the debate, that's the question. But our colleague, Dr. Murtaza, he entirely spoke only about chemotherapy. He didn't mention anything about immunotherapy, so it will be really hard to decide, but we are happy to discuss the scenarios.
Yeah, so I have actually made these scenarios that will actually, I will try to encompass both of these sectors. So what we see around in our setting is the cost. So this is one of the major thing that actually that we should take into account to actually demarcate the treatment protocols. So as we walk through this, we will actually encompass both of these. So few of these scenarios would we will be talking about the neoadjuvant immuno, and in others we will be talking about the neoadjuvant chemo. Okay. So so if we have a patient with, I would try to focus only on oral cavity. Okay, so the first thing would be that RMT lesion, it's well-differentiated squamous cell carcinoma, and it was like T3. However, on clinical examination, the mouth opening is very limited. It's hardly one finger, and it's almost impossible to clinically examine the disease. Whatever staging has been done is all based on the radiological findings. The CT chest of this patient is negative for any metastatic disease. So this is the basic scenario of a patient, and we usually see these kind of patients in our OPD. So if I would start with Dr. Noor Mohammad Sumbro, that what would you advise? Should we go for the PLD1 testing for this specific patient, or we should embark on our usual treatment as per NCCN guidelines? Sir, please, if you can switch on your mic.
As you say, the patient's mouth is only one finger, right? So we should have at least his proper documentation to proceed in multidisciplinary team. What they decide, so we have to follow the directions of multidisciplinary team. Right? If the ENT surgeon says we will go for the surgery, we will definitely opt for the surgery. Okay, if he says the team discuss about the induction chemotherapy, we can consider the induction chemotherapy. In my opinion, we should go for the proper staging, nodal status, and we try to give them 2 to 3 cycle induction chemotherapy, as Dr. Mariam told, and then we proceed for the surgery.
Dr. Shoaib, can you comment?
Yeah. We mentioned here this is T3, but at the same time, patient has only trismus, that is like one finger mouth opening. So first of all, I would like to know the reason for that. Is it submucosal fibrosis, or is it T4 disease that is leading to that trismus, you know? So, and also this will, this implement our treatment choice, that will it be, surgery will be even possible with this mouth opening. You know, we have to put this patient under anesthesia. I'm not a surgeon, but just questioning in that scenario, will the surgery be possible even or not? Now, coming to this point, they say the surgery is possible, and then the question is, will we do PD-L1 or not? This is still like quite an early data in head and neck cancers, and head and neck cancers is quite a vast term. I think in future we will be dividing them into oral cavity further into oral tongue and floor of mouth, because they have different prognosis comparative to buccal mucosa and retromolar trigone, or the pharyngeal access, so they are usually treated non-surgically, or salivary gland tumors that are entirely different. So coming to this oral cavity cancers, at the moment, this is in guidelines, coming up in NCCN guidelines 2026, that we shall do PD-L1, check for them, and there's emerging data of neoadjuvant pembrolizumab with this excellent pathologic response. And if we extract this from other tumor sites, for example, colorectal cancers or any other body sites where pembrolizumab has an excellent response. So I believe in future this will be in practice, but at the moment the standard practice will be surgery followed by chemo or radiotherapy only, depending upon pathologic factors.
So up till this point of time, the main thing to decide, or the deciding factor would be that whether surgery is possible or not. So being a surgeon, while looking at this kind of disease, I would say, yes, surgery is possible, but the limited mouth opening is one of the biggest factor that decide the surgical outcomes. So if we cannot assess the tumor clinically, and we are mainly deciding our surgical plan on the basis of imaging, sometimes we come up something unusual during the surgery, like the tumor extending beyond the retromolar fossa, involving the tonsils, and obviously this actually changes everything during the surgery. However, why the reason of decreased mouth opening in this case? The question is put by Dr. Shoaib. So it seems that it is due to the inflammation of the pterygoid muscles, which are very closely related to the retromolar area. There is no submucosal fibrosis present. So this seems to be the reason. So if this is the scenario, that there is no submucosal fibrosis, and as per the surgeon, the surgery is possible, so the question remains the same. Should we go for the PDL testing or not? Dr. Ahmed, I guess? Sorry? Dr. Salman, okay.
Right, so obviously it's this question, I have to see who the patient is, right? If PDL1 testing, can the patient afford this pembrolizumab, and what's the cost of it, right? Till recently, we did not have a registered pembrolizumab in the country. It was coming through the alternate sources, and it was not working. Now we have a few pembrolizumab that is registered in there. So, as such, if it is upfront resectable, I think I would like the surgeon to carry out the surgery, because it is an event-free survival at the moment. It's not an overall survival, and the financial toxicity is going to be very high. Probably just wait for the long-term data and then decide upon doing that. If it is surgically resectable, still a T3 tumor, you have good imaging, and you're confident that you can take it out, then probably an upfront surgery. Don't do a test which is not going to help in deciding the treatment options. That's my take on it.
Okay. So looking at the data as presented by Dr. Mariam, which showed a very good pathological response. So there is a possibility that if this patient receive the immunotherapy based on PD-L1 testing, the mouth opening gets better. So it will put the surgeon in a better box to decide the surgical plan. So if I this take into account, what will your opinion, sir?
I think you said that the pterygoids were not involved.
Yeah, on the imaging, the pterygoids are not involved, but as there is no SMF, clinically it seems that pterygoids must be inflamed.
So inflammation can probably settle with many more things other than pembrolizumab, isn't it?
Yeah. Can I comment on it? Like, look, if we look at the keynote 689, so there are so many things in the data. We know the trial is overall positive. It showed the event-free survival benefit. So important thing is, if your aim is for downstaging, so in keynote 689, you are not getting a lot of downstaging. The pathological response is less than 10%. And another important thing, if we look at the event-free survival, which is derived from the distance spread, so giving pembrolizumab in neoadjuvant, you are not gaining in terms of local control or regional control. And another important thing which you need to, so keynote 689 population, 82% patients were stage 4, and only 18% patients were stage 3. We expect that stage 4 are at higher risk of having distance spread, but surprisingly, in subset analysis, the benefit for event-free survival by distance spread was only for stage 3. And stage 4, the hazard ratio was 0.82, and it was crossing more than 1. And the stage 3, the hazard ratio was around 0.4. So the stage 3 is getting almost 60% relative benefit compared to stage 4, which is just getting 20% benefit. So I personally, just based on one trial, I personally would not go for upfront pembrolizumab. I would suggest still in countries like Pakistan, the standard of care is radical intent surgery followed by chemoradiation. And another thing you need to keep into mind as well, the oral cavity disease which we see in Pakistan, that is more related to local tobacco chewing, is totally different than what we see in the Western world. So in Western world, more we see about alcohol-related or poor oral hygiene. So we don't have good kind of all these things. So it's always challenging, but I personally at this moment is not too much convinced to change my practice based on keynote 689. There is a lot of limitation of the data, and particularly having distance spread benefit, and that is only limited to stage 3, and which was only 18% of the population in this trial.
Okay, so we are actually running short of time. So if one last thing, that as we are looking in our in the patients of our town, the cost is the main thing which is coming up. So is there any evidence of giving the chemo, the neoadjuvant immunotherapy without PDL testing? As the testing has its cost, and then the immuno has another cost. So is there any evidence that we can just give the immuno and avoid the testing, just to reduce the cost?
Don't think so. In UK, we usually check CPS. This is basically for metastatic cancers, and neoadjuvant setting not. But we check CPS score. If this is more than 1, then they are eligible to have pembro. Without checking that, no.
Okay, so recently we have come across data from the India, which was from the Tata Memorial, and which has included a low-cost, low-dose immuno, and they haven't tested the PDL1. Although this whole study was done for the patients in the palliative settings. So can this particular study be used in some sort in the favor that immuno can be done without PDL testing?
I think here we are talking two different scenarios, two different drugs. So again, in UK, for example, this is palliative setting. We do chemotherapy. If chemotherapy for CPS negative patients, so yeah, less than 1 CPS negative patients, they are not eligible to have pembro. they get chemotherapy first, chemotherapy fails, then we don't need CPS for nivolumab, we go on that. And here we are talking about low-dose nivolumab with that. So that's an entirely different scenario. We cannot apply that here. CPS score is for pembrolizumab.
See, this is the disease of the Western country. This is not a disease of Western country. This is a disease of Asian population. So we should have a research. If we collaborate collectively, do some patients from different institutions, and we have so many NGOs which may sponsor such type of the patients. So if we collect 30, 35 patients from each center in a 5 years or 3 years plan from this forum, I request all the people, there are so many NGOs which can afford, which can support you for this purpose. Because the head and neck cancer in India, Bangladesh, Nepal, Pakistan is highest in the world, right? So we should have own research papers to describe these things in our future coming setups.
Okay, thank you very much. As we are running short of time, we should conclude.
Thank you so much.
Thank you very much, ladies and gentlemen. With the permission of Chair, Dr. Salman Arif, sir, may I conclude the session? Thank you very much to all speakers and panelists. I declare the session closed, please. Thank you. There is an announcement for the international faculty. There is a high tea in Ambassador Lounge. In Ambassador 3,
Bismillah ar-Rahman ar-Rahim. Micro testing. Testing 1 to 3. Micro testing. Bismillah ar-Rahman ar-Rahim. Micro testing. Testing.
Bismillahirrahmanirrahim. Thank you so much and welcome back for coming from a nice tea. So we are already 15 minutes late. We are going to start our session. So first of all, I'll call Dr. Shahid Hamid as a chairperson to come on the stage. He's a renowned radiation oncologist and working as a director at Arkansas Cancer Institute in USA. He's the teachers of teachers and he's my mentor. Sir, please come on the stage. Second, I will call Dr. Farhat Abbas. He is a professor of urologist and CEO of Aga Khan University. Sir, please. Third, I will call Dr. Kevin Martel. He is a radiation oncologist at Alberta Health Services Center, Calgary, Canada. Thank you, Kevin, for coming from the Canada. Our fourth chair, Dr. Muhammad Atiq, he is not here. He is in US and he will join us from the US. Fourth one, Dr. Nasir Ali. He is head of Department of Radiation Oncology at Aga Khan University. Sir, please. Thank you. So please have a seat. So with the permission of chairman, we are going to start our session. Our first talk is on prostate cancer 2026, where we are and where we are going, by Dr. Muhammad Atiq. He is in Canada. He's in USA and working in University of Chicago. He could not come because of his personal reasons, so he will be on online.
Privilege for me to speak at this conference. Today, I'll be talking to you about the current treatment landscape for prostate cancer and where it may be expanding. These are my disclosures, none of which are relevant for today's talk. I'll start with a brief background on some of the latest approvals in the metastatic hormone-sensitive setting, and will provide my opinion on the application of this data. I will then discuss a somewhat recently approved addition to the radioligand therapy family in prostate cancer. I'll finish by highlighting studies you should be keeping your eye out for in regards to potential changes on the horizon, and then sharing a summary of ongoing areas in development. The main clinical updates from today's talk are that darolutamide is now FDA approved for metastatic hormone-sensitive prostate cancer in combination with ADT alone. This is in the form of a doublet in addition to the prior approval based on a prior triplet approval based on the Arison study. Niraparib in combination with abiraterone and ADT is approved in the same disease state for patients with BRCA2 mutation. Also, lutetium PSMA 617 is now FDA approved for the pre-chemotherapy metastatic hormone resistant setting, so it has moved earlier in the hormone resistant state. So this is a timeline of the treatment landscape for metastatic hormone-resistant hormone-sensitive prostate cancer prior to the approvals that I just mentioned. It starts with the proof of concept of treatment based on androgen ablation in the 1940s that was discovered by Dr. Charles Huggins at the University of Chicago. But as you can see, the overall trend for treatment has generally shown a large number of changes, mostly within the last decade, with studies supporting the use of treatment intensification on the backbone of ADT. So we went from monotherapy ADT to doublets of chemotherapy and oral androgen receptor pathway inhibitors to most recently data supporting the use of triplet therapy. Arinote is the fourth trial to the metastatic hormone-sensitive prostate cancer space that combines an ARPI with ADT. It took patients with metastatic disease as defined by conventional imaging and randomized them 2-to-1 to darolutamide plus ADT versus placebo plus ADT for metastatic hormone-sensitive prostate cancer. The primary endpoint was radiographic progression-free survival, with key secondary endpoints noted here. The RPFS from the study favored the darolutamide plus ADT arm over the placebo plus ADT arm, as the study met its primary endpoint. The most common grade 3 adverse event was hypertension, and out of all adverse events of all grades, anemia was particularly common as well. This study led to the FDA approval of darolutamide in this setting in June of last year. Another study that led to a new FDA approval in the hormone-sensitive space is the Amplitude study. Now, this was presented at ASCO 2025. This study included metastatic hormone-sensitive prostate cancer patients with homologous recombination repair mutations, randomized 1-to-1 to niraparib plus abiraterone plus ADT versus placebo plus abiraterone plus ADT. The primary endpoint was rPFS, with key secondary endpoints including overall survival. The trial was fairly well balanced. The patient population was primarily comprised of almost 90% de novo metastatic disease. So that's particularly important to note here, I think, when we think of application of this data. Additionally, there were, in terms of volume status, around 80% of the patients in the entire study were of high volume status. The primary endpoint of rPFS was met with a hazard ratio of 0.52 in the BRCA population and 0.63 in the entire homologous recombination repair mutated population. Sub-analysis does suggest BRCA may be doing some of the heavier lifting here, with a hazard ratio in the non-BRCA population of 0.81. The overall survival data is still immature, so we'll await that. Importantly, the primary toxicity was grade 3 anemia and required a pretty significant help with transfusions. So that's something to keep in mind. Still, this led to FDA approval for BRCA2 mutated metastatic hormone-sensitive prostate cancer in December of 2025. So in light of what I presented, here's how I treat metastatic hormone-sensitive prostate cancer. Standard of care should be a doublet, and how I choose the partner to the ADT is based on comorbidities, drug-drug interactions, and cost. There are rare exceptions to this doublet, such as if a patient has a limited life expectancy under 5 years, but then in those situations, I would think of giving ADT alone. But also if the patient can't tolerate doublet combination, then I would also think of ADT alone. Now, I do use triplet therapy for patients who are fit for chemotherapy, but they have de novo high volume metastatic hormone-sensitive prostate cancer. I will not use it in patients with recurrent high volume disease or low volume disease. As for the integration of PARP inhibitors, the overall survival data remains immature, and given the toxicity, I think this requires a shared decision-making approach with BRCA2 mutated patients only, of course, before integrating it into practice. I do refer patients with low volume disease for radiation to the primary, and all of what I've said here is with the caveat that if there's an appropriate clinical trial, then for patients with conventional metastatic disease, for whom it is generally felt that disease is incurable, trials remain a key part of their overall management. Now I'll move to the metastatic hormone-resistant prostate cancer setting with a discussion about the PSMA-targeted radioligand lutetium-177, PSMA-617, and its latest approval in this disease state. Going further, when I refer to this drug, I'll just refer to it as lutetium PSMA. Lutetium PSMA was approved and has been approved for use in the post-ARPI, post-chemo setting on the basis of the VISION study, which demonstrated an overall survival benefit for patients treated with this drug as compared to the standard of care, which for this study was an ARPI switch. Now, it's important to note that the most frequent grade 3 adverse events were fatigue and anemia, while the most frequent adverse events of any grade include diarrhea and dry mouth. So in addition to an established role in the post-chemotherapy setting, lutetium PSMA has also been brought to the pre-chemotherapy setting for metastatic hormone-resistant prostate cancer, as studied here in the PSMA-4 trial. Patients were randomized to either standard dosing lutetium PSMA or an ARPI switch, and this study did allow for crossover upon radiographic progression. The primary endpoint of rPFS was met with a hazard ratio of 0.43 and led to the FDA approval of lutetium in the pre-chemo metastatic hormone-resistant prostate cancer setting in March 2025. The most frequent grade 3 adverse event was anemia in PSMA-4, but it should be noted that no grade 3 adverse event was more commonly seen or at a higher frequency of occurrence in the radioligand therapy arm compared to the placebo arm, or compared to the standard of care arm, rather. Other frequent adverse events included dry mouth and asthenia, although the asthenia here was essentially the same as that in the standard of care only arm. Now, out of non-grade 3 adverse events, so all other adverse events, anemia and GI-related adverse events were seen at the biggest difference between the treatment and control arms. So how has this influenced my practice for hormone-resistant disease? I started by obtaining somatic testing. If there's a DNA damage repair mutation, then I consider using a PARP inhibitor with an ARPI. And I don't tend to switch ARPIs if the patient has been on one already, given that many clinical trials now use ARPI switch in their control arm option. So by doing so, you potentially render the patient ineligible for further studies, which could limit potential options for them going forward. I also look for MSI high particularly and consider Pembro in these settings. I don't tend to use pembrolizumab as much, especially in early MCRPC or MHRPC for T and B high only findings, given the generally poor responses we see for this biomarker in prostate cancer. Now, if there are no mutations discovered, then or no biomarkers discovered on somatic testing, then I will usually proceed with lutetium. Or if there is visceral disease or highly symptomatic disease, then I consider docetaxel, and then obviously cabazitaxel for later stages following this. Now again, the disclaimer regarding clinical trials remains ever present for patients with limited standard options with incurable disease. Now I'd like to transition to discussing a study with recent approvals, but yet to lead, with recent results, but yet to lead to new approvals. So the PSMA addition trial was presented at ESMO in October 2025. Metastatic hormone-sensitive prostate cancer patients were enrolled on the study and randomized to lutetium PSMA plus ADT plus ARPI versus ADT plus ARPI alone. So a triplet versus a doublet here, with ADT ARPI being the control. And the primary endpoint was rPFS. Now, crossover was allowed at time of radiographic progression of disease. The primary endpoint of rPFS was met in this study as well. The population demographics were fairly balanced between the standard of care as well as the investigational arm here. It should be noted that most of the population in this study were high volume patients, while there was an even split between the percentage of de novo and recurrent metastatic patients. The overall survival data remains immature, and not surprisingly, key toxicities include dry mouth and GI side effects and anemia. Now, there have not been any new approvals on the back of this study, so something to keep track of for now. Now I'd like to take a look at some ongoing areas of ongoing development. So one of these relates to targets in prostate cancer. We've already discussed PSMA and PARP targeting therapeutics, but there are others to be targeted here, such as the STEAP protein. And so this is detected at low levels in normal prostate tissue, and metastatic lesions, prostate cancer lesions, tend to have higher expression than the primary tumors. So here are some results from a phase 1 study of a bispecific T-cell engager targeting STEAP, specifically STEAP1 and CD3 as well. So this trial was comprised of heavily pretreated metastatic hormone-resistant prostate cancer patients. And what you can see here are very deep PSA declines, with almost half of patients achieving a 50% drop in PSA, as well as measurable disease regression, which was seen at a greater frequency in the patients who were on target level doses of the drug. Now, the safety profile showed mostly cytokine release syndrome, which is not surprising for a T-cell engager, but this was generally low grade in the study. It was primarily in cycle 1, and that actually improved with pre-medication and step dosing. The most frequent grade 3 or higher adverse event was anemia. Now, this study was essentially proof of the concept validating STEAP as a target in prostate cancer, as well as bispecific T-cell engagers as a potential effective modality. Now, STEAP is not the only target being explored in prostate cancer. This is a non-exhaustive list of proteins being studied in prostate cancer and the various modalities they are being targeted with. This includes even dual targeting of proteins, such as this PSMA-STEAP bispecific antibody drug conjugate, and modalities ranging from different radioactive payloads to T-cell engagers and CAR-T. Now, the red font that you'll see here and has been in other parts of this presentation is to display where we have trials open or are opening trials here at the University of Chicago. Now, this graphic of the treatment landscape for prostate cancer presented in a talk by Dr. Kevin Kelly really displays nicely where we are with current FDA-approved treatments. Granted, it does not include the most recent ones I described, but it still gives a good general overview of that. And it also shows the settings in which we are studying new targets, some of which were not shown on the prior slide, like DLL3 and CD46. I think the most important thing to take away from this slide is that this exploration is not limited to just metastatic prostate cancer, and that we are actively conducting trials even in the neoadjuvant setting, which is a place, in my opinion, of untapped potential in prostate cancer. So why consider the neoadjuvant space? Well, in the United States alone, around 31,000 cases of high-risk localized disease will be expected to be diagnosed this year. Now, this disease has a very high rate of recurrence after definitive upfront treatment, resulting in a large number of patients with potentially curative disease. A pooled analysis of prior neoadjuvant studies demonstrated that out of the patients treated neoadjuvantly with ARPIs who had pathologic complete responses, there was a strong correlation with improved 3-year biochemical recurrence-free survival, suggesting there are patients who can achieve substantial positive outcomes from this approach. Now, the neoadjuvant setting represents a significant area of opportunity to improve the care we provide to prostate cancer patients as we attempt to intervene in a clinical state where disease can potentially be cured. This contrasts to the current predominant paradigm in cancer care of bringing newer approaches to latter metastatic stages of disease, where 1, we expect the disease to be incurable, and 2, the patients have been heavily pretreated, which may limit the ability to tolerate novel therapies. So what are some of the potential benefits of neoadjuvant treatment? Well, this includes delaying time to post-surgical salvage treatments or even reducing the need for these altogether. So think along the lines of potentially longer treatment-free intervals, or rather ADT-free intervals, when we get down to how we are generally treating patients with recurrence. Decreasing tumor burden by time of resection, which may yield more easily resectable disease. And then a third potential benefit is the ability to understand the biological impact of systemic therapies in the environment of the tumor via post-treatment prostatectomy specimens. So this includes exploring potentially correlating changes in the intratumoral environment with changes in peripheral blood. And more thorough understandings of mechanisms of treatment and measurable effects can then lead to more informed approaches in other stages of disease, so not just neoadjuvant, but later stages. There are many ongoing studies in the neoadjuvant space. I want to highlight a few here. So Proteus is an international phase 3 of an ARPI plus ADT versus placebo plus ADT given for 6 months, followed by surgery, and then another 6 months after surgery. Primary endpoints are PAT-CR, metastasis-free survival. The study is fully accrued, and we're awaiting presentation of the results. We have our own randomized phase 2 investigator-initiated study at the University of Chicago, which utilizes ADT plus an ARPI plus a myosin glucocorticoid receptor antagonist, relacorilant, which essentially treats patients for 6 months before surgery and is looking at the primary endpoint PAT-CR. And then finally, there's a large effort being undertaken by the Prostate Cancer Clinical Trials Consortium in the format of ADAPT, a platform trial designed to have a shared control arm similar to STAMPEDE. So this is also a randomized phase 2 for patients with high-risk, localized, or oligometastatic disease as seen on PSMA PET. Patients would be randomized 2-to-1 to an investigational arm or a control of ADT plus ARPI for 6 months of treatment, and those who have oligomets would be treated with SBRT. They would then proceed to surgery. The primary endpoint for this study will also be PAT-CR, and the trial is planned to open in the coming months. So how do I sum up takeaways for the future here? Well, the treatment landscape for prostate cancer is rapidly evolving, and there are a number of exciting options being studied. Now, while I just presented one example of immunotherapy exploration in my talk here today, there are numerous other ongoing efforts that, due to time limitations, I did not proceed further. With all the treatment modalities we have coming into prostate cancer, adaptive dosing strategies are adaptive dosing strategies where we consider giving treatment based on biomarkers of response will be important as we aim to limit toxicity both in the short and long term for patients overall. Radioligand therapeutics are expanding to include isotopes other than beta emitter lutetium. So that includes actinium, terbium, and lead. These are all particularly exciting candidates. The different modalities and targets being explored may present opportunities to use ADT sparing or limited approaches in select scenarios, which is particularly important to the morbidity our patients experience. However, it should be noted that the development of treatments around the androgen receptor is still very relevant, and there are still novel strategies such as AR degraders and CYP11A inhibitors being explored here at the University of Chicago and in the prostate cancer landscape in general. I would once again like to thank all of you for your time and attention. If anyone is ever interested in discussing this disease further or any of the clinical trials we may have at the University of Chicago, please feel free to contact me. Thank you.
Pratik, for a nice comprehensive talk on the updates of prostate cancer. You have really bridged the river. So our next talk, I will invite Dr. Mutahir Alitonio. He's a consultant at the South Wales Cancer Centre in Swansea, UK. His talk is on prostate-only radiations in metastatic hormone-sensitive prostate cancer, evolving practice from Stampede to the real world.
Thank you. I will be talking about the role of prostate-only radiotherapy in metastatic prostate cancer and its evidence which has been evolved over last decade. Before we dive in, just a quick audience poll, how many of you offer or refer patients with the metastatic prostate cancer for a prostate-only radiotherapy? So these are the options. So raise your hands if you send all patients for metastatic hormone-sensitive patients or metastatic, option B, metastatic hormone-sensitive and resistant cases. Option C, only low-volume metastatic. Yeah, fairly good hands, yeah. None. Or for a symptomatic relief only. Okay, so hopefully we will be having some good consensus at the end. So these are important definitions which make the basis for the clinical trial which were designed for a prostate-only radiotherapy. Just I would say, because charted, the volume definition was defined by a charted, and the latitude, they defined the risk high versus. So if you can see here on the slide, it's a high volume has been defined, which we know that more than 4 bony metastases, at least one outside vertebral column and or visceral metastases. So per se, there's no definition of low volume disease. Anything which does not qualify high volume disease is a low volume disease. So we should not confuse it with the oligometastatic disease. So imagine a person who has more than a whole spine is involved, but none of the lesion is outside the spine. So it still will be under the low volume disease. Or a gentleman, any patient who has a lymph nodes, a non-regional lymph nodes in para-aortic, mediastinal, or supraclav, or cervical nodes. So it will be counted as a low volume disease, but it will not be an oligometastatic disease. So there is a biological rationale behind using prostate-only radiotherapy in metastatic disease. As Dr. Mohammed said, so prostate is a combination of hormone-sensitive and resistant clones. When these are exposed to the systemic treatment, more and more the clones are, resistant clones are evolved. And with the more systemic treatments, more resistant clones are evolved, which what we call is a clonal evolutions, or in a clinical practice, what we call is a somatic mutations. On the other hand, The treating primary, either with a prostatectomy or reasonable doses of radiotherapy, it kills the potential future metastases from the primary and changes the ecology of the metastatic disease. Just by the biology, it is very logical to treat prostate even in the metastatic disease, as it improves the local control, it prevents the reseeding, and it improves the efficacy of systemic treatment. This is one of the early piece of evidence which we have. You can see the yellow and the blue lines, the gap seen between the survival curves. The yellow one are just an ADT alone, and versus ADT plus either a prostatectomy or reasonable doses of radiotherapy, you can see there is a survival advantage. And the HORID was the first randomized trial which compared ADT versus ADT plus prostate-only radiotherapy. As you can see, there was no additional benefit by addition of prostate-only radiotherapy to the entire cohort, but the subset, the low-volume disease, you start seeing a signal. And also, there was improvement. The prostate-only radiotherapy helped in delaying the PSA progression. With more than around 2,000 patients, Stampede Arm H provided the strongest evidence in favor of prostate-only radiotherapy in a low-volume disease. As you can see, the overall survival was improved with incorporation of prostate-only radiotherapy. However, this effect was not seen in a high-volume disease. And also similarly, failure-free survivals, they were improved with the addition of prostate-only radiotherapy in a low-volume disease. And updated analysis of year 2022, the Stampede arm showed prolonged benefit of prostate-only radiotherapy compared to the systemic treatment with the hazard ratio of 0.64. Piece 1 used the intensified chemo. We know the triplets. So it was a 2x2 trial. Standard of care was ADT with docetaxel, and intervention was abiraterone or triplets. And the radiotherapy was given in the both arms. So the piece 1A or piece 1B, and if you see, even with the treatment intensification, the radiological progression-free survival was improved in the patients who were on the triplets. Although there was no improvement in terms of overall survival, but in the terms of the secondary outcomes, the addition of prostate-only radiotherapy helped patients to delaying in going into the castration-resistant phase. So you can see here the castration-free survival, resistance-free survival was improved from 2.5 years to 3.5 years. And also secondary endpoint, which is the time to serious genitourinary events, you can see that the addition of prostate-only radiotherapy helped to prolong this period. The stopgap meta-analysis pulled all these studies together, and across all studies, the benefit of prostate-only radiotherapy was seen in terms of, there was a positive trend in terms of overall survival, and also clear benefit in terms of progression-free survival. And this is one of the strongest pool message we have so far. And however, we should know that since the HORID trial, where only the just an ADT was used, with the Stampede, only 18% of patients were given docetaxel chemotherapy, and with the PSCO, the treatment was very much intensified with the triplets. Thus, the goal of prostate-only radiotherapy changed from the giving a survival advantage or local control to a more like a strategic disease modification. And this led us to a sweet spot. You can see the horizontal line is increasing effectiveness of a systemic treatment versus vertical is a benefit of a prostate-only radiotherapy in terms of survival. If you see that there is a clear survival advantage if our patients are on ADT alone or with the chemotherapy, could be on the doublets, any ARPI, but as the treatment becomes more intense, this benefit starts decreasing. Across all trials, the prostate were only the radiotherapy. Volumes, fractionations varied, 70 gray and 35 or 57.7 and 19 fractions were used in HORID. Stampede arm used 55 in 20 or 6 weekly, 36 gray and 6 fractions. And Stampede used 74 in 37. Whether this fractionation has any impact on the overall survival, we did a analysis, and we found, although if you can see here, the 36 in 6 versus 55 in 20, both are common regime in UK. The patients who were given 55 in 20, they had a hazard ratio of 0.83, better than 36 in 6 with a hazard ratio of 1. Whether prostate-only radiotherapy has any role in high-volume disease, so far we don't have a data, but if you see here, the patients, lots of patients, they present with the local symptoms, and when they are going into the castration-resistant phase, these local symptoms are increased proportionally, and these becomes the source of the referral for the urological interventions, including TURPs or stenting, or referral for symptomatic prostate primary treatment. So this could be an area of investigations. Shall we treat beyond the prostate? So far, we have ongoing our trial. It's called PULSE. We are giving an extended field radiotherapy, including prostate, pelvis, and parotid in M1A disease. Only the patients have a parotid nodes. Results will be interesting. Also, 2 years ago, a small paper was published, retrospective data on 100 patients, where they treated pelvis in addition to prostate in metastatic prostate cancer patients, and there was a positive trend in terms of overall survival and the progression-free survival, but yet it is not a clinical practice. We may discuss to individualize patients whether we can treat just the prostate only with the SBRT or SABR in a metastatic disease. So far, we have a UK ongoing trial. It is a Stampede 2 S, in which the patients are being treated with ADT, with any ARPIs, prostate SABR, and up to 5 eligible SABR lesions. SABR trial is looking for the addition of immunotherapy with prostate SBRT along with the abiraterone in the metastatic disease. Shall we treat all the lesions in the low volume settings? We don't have much data. Most of SBRT data is in the relapse cases, and Kevin will speak more on this. So in summary, the prostate-only radiotherapy, it improves the progression-free survival in low-volume disease, and overall survival depends on what you have offered systemically. Prostate-only radiotherapy improves, it delays the castration resistance, it improves the local symptoms and prevents the future symptomatic burden. 55 in 20 is a better regime if you want to give. Radiotherapy volumes beyond the prostate, they are subjects for clinical trial territory. However, it is very important that we should discuss prostate-only radiotherapy to every low-volume metastatic hormone-sensitive prostate cancer patients. Reason is radiotherapy is way cheaper. then managing the local symptoms in the future as well. All right, so just after listing this, under what category would you place prostate-only radiotherapy? Would you call it radical, palliative, or strategic? Yeah, So it's this term, strategic radiotherapy, was just introduced, I believe, 1.5 years by Dr. Giuseppe. So it is essentially you give a treatment, either you want to delay the systemic treatment or you want to keep patient on existing systemic treatment for a longer time without any switch. All right, thank you so much.
Thank you, Dr. Mutahir, for a nice talk. Question will be later on, yeah. So our next speaker is Dr. Kevin Martel. He has come from Alberta Health Services Center, University of Calgary. His talk is on metastatic directed therapies in oligometastatic prostate cancers. I was glad to know that his first time here in Pakistan. Please.
Thanks, everyone, for having me here. I have one conflict of interest to disclose. I've had some speaker fees from Bear, ironically related to SBRT and PSMA PET type work. So we're going to talk about SBRT and prostate cancer and where it stands right now in oligometastatic disease. Basically, I wanted to do this through threefold. We're going to go through an overview of the trials, but I wanted to do it in the context of a case example from a few years ago. We'll go through some of the upcoming data as well. So this is the case I was alluding to. It's a little bit more complicated than you would originally think at face value. He's a 65-year-old male, presented with urinary retention, pretty healthy by Canadian standards, just hypertension, diabetes, and a prior appendectomy. As part of his workup for his urinary retention, he had a PSA done. It was 25.7. And he underwent a 3T MR of the prostate because of that. That showed diffuse disease in his gland, predominantly right-sided nodule extending into the left side, but also with extension into the right seminal vesicle. And if you have a look at the high B-value DWI imaging and the ADC map, you might notice that there's some restricted diffusion in the pelvic bones on the right side as well. So that's a right-sided bony metastasis. Underwent a biopsy, transrectal ultrasound guided. It showed up grade group 3 disease, which was 95% pattern 4. So if you got the radiologist or the pathologist on a different day, or if you got a different pathologist, they would have called it grade group 4 disease. It was 50% of tissue in 9 out of 15 cores, and there's a little score I use called the APP4, which is just the proportion of tissue biopsy that's pattern 4 disease. It seems to be a little bit more predictive of outcomes in disease outside the prostate. It's positive for cribriform pattern as well. It's a 52 cc gland, which might be important in the way we kind of work through this case. Again, PSA at 25.7, a CT and bone scan, just conventional imaging is pretty much standard everywhere in Canada. And it did show only the disease in the pubic ramus, ischium, and right acetabulum. PSMA PET was done, and it confirmed that this was just an oligometastasis. So that's kind of what we're looking at on the CT and bone scan. I didn't bother putting the PSMA PET up because it shows the exact same information, but you can see the sclerotic metastasis. So if I asked 100 colleagues, I would have gotten, back in 2020 when this patient presented, about 15 different approaches to this type of patient. You still have PR8, and there's urologists and there were radiation oncologists that were still just doing ADT continuous at that time. I think we all can agree that ARPI should be considered a standard of care now, at least. You can consider RT to the prostate through Stampede. Some people would have considered docetaxel based on much older types of approaches. Since charted, it's pretty much only been high volume. And then there's a slurry of other approaches, but some people are pretty aggressive in North America at least. I would argue that at this point in time, like today, we have ample evidence to at least do doublet therapy in these patients. You've got Stampede showing abiraterone, prednisone, and ADT as about a 50% relative improvement in overall survival at 5 years. And then you've got Latitude, kind of very similar. It's 50% relative. Titan and Arches looking at apalutamide, enzalutamide, and then Aranote for darolutamide. There's phase 3 evidence that we should treat the prostate. You just heard about it in Stampede, the original, and then, well, piece 1, I like Stampede better because it shows an overall survival benefit that fits with my own biases. And then the real question is, should we treat the bone met? And if you think about this, the prostate's 52 cc's, about half that prostate is cancer. So that's 26 cc's of cancer in the prostate. If you looked at this guy's bones and you may have measured it, it's probably about 60 cc's of disease in that single bone met. So if you're going only after the prostate, you're not really going after the bulk of this guy's disease. There is no trial that has been published that directly addresses this case, either phase 1, phase 2, or any phase. Stampede 2 will tell us what we should be approaching from a radiotherapy perspective with these patients. At this point in time, there's 3 phase 2 trials that are kind of adjacent and may add some enlightenment to a case like this. There's Extend, ARTO, and PCS9. Well, that shows up pretty nicely. So Extend was 87 patients. Their inclusion criteria were less than or equal to 5 METs, and they all had to have 2 months of ADT prior to being approached for enrollment, and then the randomization was continuing on with ADT for 6 months. Or doing that and adding an SBRT. This was a cohort of patients where they were trying to do an intermittent ADT type approach. They actually had approached 100 patients in this study, and 92 consented to the treatment, and then 5 who ended up being randomized to the 6 months of intermittent ADT alone arm declined to proceed on the treatment, so they wanted the SBRT and headed off trial. But a good portion of this cohort, about 25%, had no prior treatment to the primary, which would be a key point for our patient. There's 2 pieces of information I take from this study that I think are actually very useful. First of all, progression-free survival. If you look at the 24 months, you still only have 15 and 5 patients in each cohort, but you're basically going from 30% to 60%. That's a very strong signal. And then if you look at the prior primary treatments on the, oh, it doesn't show up, on the right side, kind of overlaps if you haven't had the prostate treated previously with being of no benefit. So maybe in this cohort of patients, the prostate should be considered as part of the treatment. If you're going after the oligomets, you probably should do the prostate too. Then there's ARTO, 157 patients. This was castrate-resistant prostate cancer and less than or equal to 3 METs. Abiraterone, prednisone, and ADT, plus or minus SBRT. Pretty matched cohorts between arms. And some of the interesting thing from this trial was their main outcome was biochemical response in the castrate-resistant patients. And essentially, when you added in SBRT to the abipred and ADT, you had about a 92% biochemical response rate. And for the abipred and ADT alone, you usually expect around 66. It was 68 in this cohort. There was a complete biochemical response rate of around 60% in these patients. So the PSA went down to undetectable in castrate-resistant disease. That's pretty phenomenal. Both of those showed adding in the SBRT was a significant factor on univariate and multivariate analysis. And this, again, progression-free survival, so this would include biochemical recurrence as part of the definition of progression. It's not just radiographic progression. But again, somewhere around 24 months, you're doubling that progression-free survival in a phase 2 study, and no difference in overall survival. The curves are starting to separate, but like this is not powered well enough to show a difference of maybe 5–10%. And then there's PCS9, 102 patients, again, castrate-resistant disease, less than or equal to 5 mets, and it's a little bit better cohort for modern times, but it's ADT and enzalutamide versus ADT, enzalutamide, and SBRT. Pretty even cohort between arms, but there were about 13% of patients who had no primary treatment to the prostate. And again, you see a pretty strong separation of the curves. And this is radiographic progression-free survival, which I would argue in a castrate-resistant patient should be the endpoint that you're looking at anyway. And at 3 years, you're almost doubling it. The second chart on the screens left there is subsequent treatment. So the cumulative incidence of subsequent treatments, which for a patient who is failing ADT plus an ARPI, their next treatment line in most of Canada and North America at least, it's chemotherapy with docetaxel. We don't have strong funding yet for lutetium. It's available in patients who've already had taxanes in my country at least. So we're at least delaying a pretty toxic treatment. This would be a good summary of the phase 2 data that's already available and published and completed trials. You can see at the top there, PCS9, we just talked about. There's an interesting one called Lunar, which was done by Kishan et al. And essentially what it looked at was, okay, if we have SBRT and we think it's okay, and in 2020 we had Oriole and Crop was starting to get some data coming in. So we had something to guide this. But Lunar looked at using SBRT or using 2 cycles of 6.8 gigabecquerels of lutetium-177. And it was like, okay, well, if we do this and we don't use ADT, can we improve people's progression-free survival? And those single 2 cycles of lutetium doubled it. So that's pretty good. You take care of the gross disease with SBRT and you can sweep up some of the micrometastatic stuff. There's also Radiosep, which single center, but still a phase 2. And it was recurrence after primary therapy. Basically what they looked at was 6 months of ADT and SBRT versus SBRT alone, and they were looking for progression-free survival. They found that adding in the ADT doubled the progression-free survival. So between those two, I think the lutetium or the ADT is probably necessary with SBRT if you want to get some durable response for these patients. There's SGO5, which is a kind of a single arm, but they had an experimental cohort, which was 14 patients with castrate-resistant prostate cancer. And their main thing was they had their standard cohort, which was just the 77 patients who had castrate-sensitive disease. Progression-free survival in those receiving ADT and SBRT was 24 months, so pretty reasonable. ARTO, Extend, we already talked about. And so there's a STOMP and Oriole, which are basically looking at surveillance versus SBRT, and the ADT-free survival or progression-free survival in both arms are probably mean the same thing, but it's essentially doubled. And then CROP, which is presented at ASTRO as an abstract only, looks at using the PR7 approach, intermittent ADT, which is, was a phase 3 that showed it works and it's non-inferior, at least to continuous ADT in non-metastatic but biochemically relapsed prostate cancer, at least on conventional imaging, not PSMA PET. And did SBRT to the Mets, the gross disease. And it was single arm, but cumulative incidence of radiographic progression at 5 years was 56%. Like, that's actually almost cut in half of what you would normally expect. So what about this guy? So my approach in 2020 was a little bit careful for this guy. So 2 things. 1, the guy's presenting in urinary retention. I know if I do aggressive radiation of the prostate, I can pretty much double his urinary symptom scores. He's going to guarantee to knock him off of a catheter. You know, PACE-B with Allison Tree's reanalysis shows that baseline urinary symptoms are the biggest predictor for complications after hypofractionated radiotherapy of the prostate and an ultra-hypofractionated regimen. And then you have this pretty copious amount of disease in the guy's pelvis that's in a pretty intrinsic bone with a high risk of fracturing. I ended up offering him the second radiotherapy option in Stampede, which was 36 and 6 once weekly, because patients really tolerate that. They love it. But again, your control rates are a little bit lower. And then I just did that to the bone med as well. And he did really well. Gave him luprolide and apalutamide, which would have been our standard at that time. To date, his PSA is still undetectable. It's castrate-level testosterone. He's still on the luprolide and APA. He's tolerating it really well. Like some patients that have had these treatments that want breaks, but he's just like, it doesn't matter. And he's probably not going to recover his testosterone anyway. Last CT and bone scan were pretty much 7 months ago, but they were negative. Full disclosure, this is the only AI-generated slide in this talk, but I asked it to make me a graphic of the phase 3 trials that are looking at SBRT in oligometastatic prostate cancer that we can expect in the next 5 years. And the top one that it put there was PR24, which is a Canadian study, so this is why you don't use large language models. That looks at high-dose rate brachytherapy or low-dose rate brachytherapy plus external beam radiation to the pelvis versus hypofractionated radiotherapy and ultra-hypofractionation, 40 and 5, SBRT to the prostate in non-metastatic disease. But, I don't know, it's a Canadian study, so I left it there. The one that I would pick would be Sabre Comet 3. It's going to have a lot of prostate cancer patients in it because people stopped offering it to breast patients after BR002. Ones that I'm looking forward to, it did okay otherwise. Sparkle and VA Starport are going to probably guide some of the treatment. And as I alluded to, Stampede 2 actually would have told us the answer if it was already released. Just for data purposes, though, I think probably the answer from Sabre Comet 3 is going to be available when the data accumulation closes in 2 years. Anyway, that's all I had for you. Any questions?
Thank you, Dr. Martin, for a nice talk. We'll have questions at the end of this session. So next talk is, I'll invite Dr. Ehsanur Rahman. He's a medical oncologist at Northampton Cancer Center, UK. His talk is on systemic therapy in the renal cell carcinoma, challenges in implementing the guidelines in the practice. Sorry.
इसको फुल स्क्रीन कर दो। Thank you very much. I feel honored to be here as an invited speaker, and today the topic of my lecture is systemic treatment, challenges in implementing guidelines in practice.
I will go through the guidelines quickly and more focus on what are the challenges in the real world situation when we are sitting in our clinic and see a patient, and what are those challenges as a clinician we face when we decide the treatment about our patient with kidney cancer. So I will be reviewing the systemic guidelines and identifying the challenges. If I could look at the data from the UK, 36 patients diagnosed per day, and we are losing 13 of them. Do you have any screening program or any preventive program? We don't have any screening program for the kidney cancer. And the kidney cancer is, when it's diagnosed, we already stage them with TNM classification. And there is also inclusion of Lipovic score, which comprises of T stage, N, and grade. Now we categorize it as a low, intermediate, or high risk patient. We use different guidelines in our, for the treatment decision, mainly NCCN. I also go for EAU guidelines, and also our local St. Luke's guideline, which we use in the UK for having some treatment decisions in clinic pattern. There are a lot of molecules which are tried in an adjuvant setting in a kidney cancer, like sunitinib, pazopanib, axitinib, but none of them shows promising results in terms of overall survival or disease-free survival until we get a pembrolizumab in Keynote 564, in which we give adjuvant pembrolizumab for 1 year in a patient who are T2 or above, or have got intermediate high risk node positive. It can also be offered to a patient who have metastaticectomy for a single lesion within 1 year after the nephrectomy. And we can see that we have around 8 to 9% of disease-free survival benefit and also 5% overall survival benefit. Now, when we are treating the patient with the immunotherapy, we do have the toxicity. And in my clinical experience, the common toxicity with the pembrolizumab, which I have seen in my patient, is rash, pneumonitis, and immune-related arthritis. And some of my patients in which I have to stop the treatment due to the significant toxicity due to the immune-related arthritis or a cellulitis. We still don't know the length of the treatment, although we are sticking to the guideline of a 1 year of adjuvant pembrolizumab after nephrectomy, but we don't know if the 6 month is equal or better just to limit the toxicity, or can we extend to the 2 years. So we don't know, but we are stick to our current guideline. This is a gap which we need to see in the future. Metastatic renal cancer has a lot of target actionable molecules we have at the moment, including TKI and also the immune therapy. Renal cell carcinoma is a highly immunogenic cells, 24% express PD-L1, and more than 50% tumor-infiltrated lymphocytes are present. We can see the treatment evolution from 2005 to 2022, where we previously using only sunitinib, and with the course of time, we have a lot of targeted molecules and immunotherapy combination available now. Now, it is very important to understand the risk factor or categorize them as favorable risk, intermediate risk, and high risk, which can determine our treatment decision. So what has changed at the moment from a very limited option of TKI, which is sunitinib previously? We have a lot of combination therapies. We have IO-TKI combination, we have IO-IO combination, and we have new TKI molecule or multikinase inhibitor. Some guidelines which are designed on the favorable, intermediate, and poor risks. There are different combinations. It is said that always go for a combination for the first-line treatment, which is better as a single agent, but there is individual consideration when you are trying to decide the treatment for a metastatic renal cell carcinoma. The key studies which have Checkmate 214, for Keynote 42, and looking at all these trials, looking at different combination in a first-line metastatic setting. So at the moment, what I prefer, if I have a patient with good performance status, no considerable comorbidity, I would like to go with the IO-TKI combination, unless I am restricted by any other comorbidities in which I can use TKI. These are different, this is a summary of the different trials which are done for these first-line treatment, and we can see the progression-free survival around from 8 to 9 months in this setting. When we are treating the patient first-line with a combination of immunotherapy and TKI, there is a challenge when it comes to the toxicity. And we should know, or we can see what drug or which drug is causing the current toxicity. So the immune-related toxicities are likely the inflammation or itis in any part of the body, which can be pneumonitis, myocarditis, encephalitis, or affect the glands, mainly the thyroid and adrenal glands. VEGF toxicity, mainly it's PPE, cytopenias, and diarrhea. But there is some overlapping toxicity like rash, stomatitis. It is sad when you are giving a combination chemotherapy, a treatment with TKI and IO, when you have a grade 3 and grade 4 toxicity, you stop the treatment until it's resolved to grade 2 or grade 1, less than grade 2. Now, how you restart your treatment again is again a challenge. If you think that your patient has mostly the immunotherapy-related side effects, hold immunotherapy and continue with the TKI, and vice versa also. Now, most of the treatments which are recommended and most common histology in kidney cancer is a clear cell carcinoma. But we do have a non-clear cell like a papillary chromophobe. So again, for the papillary, we will use TKI. From the chromophobe, we again using a TKI and sarcomatoid variant. We can use the combination treatment or IO treatment for them. Now, what we can consider as a choice of possible sequence, again, we don't know. But as a first line, what I have said, my preference in a good performance status patient with a metastatic renal cell carcinoma is a combination treatment unless it is contraindicated. In the second line, if you have used a first line TKI and IO combination, I will give you an example that if I have a patient in which I have used the first line combination because we are guided or we are restricted by Cancer Drug Fund in the UK, and we have only limited combination in the first line. Mostly it is IO combination, which is ipilimumab, nivolumab, or we use cabozantinib, nivolumab, or we use pembrolizumab, lenvatinib. So if you started with your patient first line with the IO-TKI combination, if the patient progress, my preference usually is to go for either tivozanib or cabozantinib because it's my personal experience that I have more confidence in those TKI molecule. So putting all together in a first line, these trials show superiority of progression-free survival on all the combination over sunitinib. Nivo, Ipio, and Pembro associated with the improved overall survival benefit. All the combinations can be tolerated. But again, in my personal experience, I think Cabo-Nivo is better tolerated combination as compared to lenvatinib and pembrolizumab. The limited toxicity in lenvatinib, which I have seen because the dose of lenvatinib is 20 milligram, is the hypertension, PPE, and the diarrhea, in which most of the patient we have to reduce the dose and they tolerate 40 milligram very well. Now, when we have the background of those guidelines and treatment algorithms, but sometimes there are challenges in the real world. Okay, what we do when we see a challenge which is patient-related, like elderly patient, frail patient, the patient who has autoimmune disease, poor performance status, and commonly, I think in Pakistan, a financial issue. These factors affect or influence our decision. Now, if I ask you, if a young patient who was verified PS1 3 to 4 weeks ago and has sudden loss of power in the lower limb and diagnosed with MSCC and the biopsy shows clear cell carcinoma, what will be his performance status? If we look at the performance status, whatever it is, more than 50% or something, WHO, you categorize it either 2 or 3. Then compare this patient to another patient who have a progressive decline in few months with a metastatic disease, and his performance status is 3. Would you treat or take a decision to treat those 2 patients equally? I will not. I will see how he was few weeks ago. He was up and about, no comorbidity, and this is a sudden loss of power in his legs due to a metastatic disease in the ribs. I will give him a chance if it's young, fit, otherwise no comorbidity, to give him a combination treatment. And also the immune-related toxicity is very important that we recognize them early. So if the patient presented with cough, dyspnea, high CRP, and the temperature, and X-ray shows some haziness, what will be our clinical diagnosis? Number 1, infection. But or pneumonia. If the patient is on immunotherapy, you should not forget about immune-related pneumonitis, which can present in the same way with a high CRP, shortness of breath. And then you shouldn't be taking a chance. You will start antibiotic, but the early involvement of respiratory team is a key. Although most of our guidelines are that treat him 0.5, 1 milligram per kg, or even 2 to 4 milligram per kg prednisolone if you are suspecting immune-related pneumonitis when your patient is deteriorating. But respiratory guidelines are different. They give 500 to 1 gram of methylprednisolone. So do involve the respiratory team quickly and do all the tests for them, the respiratory viruses, and in Pakistan also the quantiferon or TB. Now there are also physician-related challenges, less experience in treating the patient with immunotherapy, less experience having with the relate or exposure to the immune-related toxicity, and some physicians have their own experience. Like I have my own experience, I will prefer Cabonivo over lenvatinib, pembrolizumab due to the toxicity profile. But if you see the cabozantinib, there are more VTAs, either PE or MI, which I have seen in my patient as compared to lenvatinib. But overall toxicity is better. Now, there are health system barriers. As I told you that in UK, we have only 3 first-line TKI, IO combination. We are restricted with the cancer drug fund. But in Pakistan, I think you can use any of the combination as per NCCN guideline or the ESMO guidelines. It is very important that we recognize the biomarkers in renal cell carcinoma, which can tell us about the treatment tailored to the biomarker, but we don't do PD-L1 for the renal cell carcinoma patient. Therapy sequences is challenging. If we see the guideline, after the first line, you have all the options of TKI. If you haven't used them, there is a 3 or 4 options for the TKI. But again, my individual experience, I prefer in second line cabozantinib or tivozanib with very good tolerance, and you can play with the doses very smartly in this patient. The special population, non-clear cell, the patient with the brain metastasis, renal impairment, this is your individualized decision, and I will recommend stick with the guidelines, and your experience will guide you which treatment combination or single one is better for your patient. Role of multidisciplinary teams, it is very important in the era of immunotherapy. I suggest that you make your own teams. because these patients present, when they present with the immune-related toxicity, you have to involve the respiratory team, neurologists, cardiologists, rheumatologists. So if you have a good liaison, your relations, or if you have made this immunotherapy task force in your institutions comprised of these different specialty experts who have interest in the immune-related toxicity, like we have oncology and also the dermatology, so that will be sharing, because they will be learning from you, and this is something new for you. Don't forget, this is your patient, and as an oncologist, you are the lead or responsible for this patient to make the decision and guiding other specialty, although you are getting some experience or expert advice from them. Role of real-world evidence, yes, it complements our treatment decision when we have a real-world evidence with the randomized clinical trial. Case-based approach that every patient is individuals. There, yes, I don't think that there are national guidelines in Pakistan. We usually follow NCCN, ESMO, depending our inclination towards. But I think there may be some institutional guidelines which are very important if you work on those guidelines, and I can help you in making those guidelines for your institution. And also the database tumor registries help us about the treatment decision pattern of the disease and the outcomes. So key take-home messages: IO-based combinations are standard. Real-world challenges, as I explained, is significant, and always don't consider or focus only if you are oncologist treating different sites. Take a patient as a human being, which is called holistic approach, and take the individual patient characteristic comorbidity-based decision in your clinical practice for your patient. Thank you very much.
Thank you, Dr. Ehsan. I remember my days of radiation when there was a clear-cut role of radiations in RCCs, especially in the post-operative settings, especially in the positive margins. But there was a time when the evidence says that there is no survival advantage. Rather, there was increased toxicity of radiation in post-operative settings in RCC. So the radiations were out of the practice. Now, again, there is evolving data that has shown the role of SBRT in RCC. And it has even taken the place of surgery in early RCCs. And my next speaker, Dr. Muhammad Ali, is one of the author of these trials. He's radiation oncologist in Peter MacCallum Cancer Hospital, Australia. And his next talk is on metastatic directed therapies for oligometastatic and oligoprogressive stage 4 RCC.
Thank you, Osif, and thanks to the organizing committee. So we are running almost 30 minutes out of time, so I will try to skip few of my slides to maybe get extra 5 minutes. So I would be talking about role of SAVOR for metastatic renal cell carcinoma. So there are no disclosures. So this slide was shown by Dr. Ehsan already. So in first line metastatic setting, the combination treatment is the key. And in patients who had failed the first line, then we have second line systemic treatment. And it depends on what was given as a first line. It can be single agent or it can be combination of treatment. So if we look at the role of radiation for metastatic renal cell carcinoma, so we have in different perspective of metastatic disease, we have looked at different scenarios, but today we will be talking about oligometastatic and oligoprogressive disease. Historically, radiation is being used for last many years, particularly for intracranial disease. It's in practice for more than 4 decades. And if we look at this meta-analysis, the local control was more than 90%. So it has always shown a quite significant local control benefit, but it was never tested in metastatic disease. But now we have multiple phase 2 trial. We don't have any phase 3 data, but quite good number of phase 2 trial has looked at the role of radiation for oligometastatic and oligoprogressive. So first we will look at the oligometastatic disease. So the question is, do all the patients who present with metastatic renal cell carcinoma, they need the systemic treatment? So one trial from Brian Rainey, he's a very well-known author for immune treatment and targeted agents for metastatic disease. So he did a phase 2 prospective trial of 48 patients. The patients diagnosed with 1 to 5 lesions of metastatic disease, biopsy confirmed. So the patients were not symptomatic, or the disease was not threatened to become symptomatic. So he just continued to follow them up. And what they reported that by just following them up, they can delay the need for systemic treatment for almost 15 months. And another interesting factor in this trial, 43 patients progressed. And if we look at almost 2/3 of the patients progressed at the initial site of disease. So that's where the role of radiation or surgery come into play. Like, how about doing radiation to the metastatic disease, and maybe we can extend the duration of systemic treatment-free interval for a quite long time. So the largest data we have from MD Anderson, led by Dr. Chad Tang, 121 patients, and in this one, mostly low to intermediate risk patients, and all the patients, majority of the patients had 1 or 2 lesions, though in this trial up till 5 lesions were allowed, but only 10% of the patients had 3 to 5 sites of disease. There was a quite variation in radiation dose. The most common schedules were 40 to 50 gray in 5 fractions, but in some situations, particularly the ultracentral or mediastinal nodes, where it was not given, they have considered 50 to 70 gray in 15 fraction as well. And another important thing in this trial, in patients who had radiation and had a quite good interval from progression, the subsequent role of radiation was kept in, and 71 patients had second cycle of radiation, and then 13 patients, the patients were allowed for 4th or 5th line of radiation as well. So they reported the analysis with median survival of 36.3 months, as we have quite ample data that grade 3 toxicity only in 7 patients, and 1 patient had grade 4 hyperglycemia, and he had received radiation to the metastatic pancreatic tumor. But the important thing, the median time free from systemic treatment, 34 months, and progression-free survival of almost 18 months. If we compared it with the Brian Rainey study, which was 48 patients, so their systemic therapy-free survival was 14 months, and their progression-free survival was 8 months. So just by giving radiation, we can give patient an almost double the amount of time without systemic treatment, and they can have a good quality of life without any significant treatment-related side effects. But it's not for all the patients. What they have found, lower the number of sites of disease, more the benefit. In patients with 4 to 5 mets, the benefit is quite minimal. And another thing they found, the circulating tumor DNA, the patients who had negative circulating tumor DNA at baseline, they are the one who had a more long progression-free survival compared to the patients who had positive circulating tumor DNA. Dr. Hassan mentioned about Keynote 564 trial, which was the adjuvant pembrolizumab. And in this trial, they allowed patients with M1, oligometastatic, and they can have surgery or radiation, and they were given 1 year of adjuvant pembrolizumab. So if we look at these forest plot, we can see the hazard ratio 0.40 in M1 disease. So it means 60% relative benefit. And the benefit is more in this group compared to the M0 group, where the hazard ratio is 0.75. So one trial from our center, we have enrolled 30 patients with 1 to 5 metastatic disease, slightly high-risk population compared to the MD Anderson trial. Our median number of lesions were 3 compared to 1 in the MD Anderson trial. So all the patients had 20 in 1, and in certain situations, the patients who are not eligible for SABR, the mediastinal, or even the ultracentral, we give just palliative 30 in 10, and the patients had 6 months of adjuvant pembrolizumab. And what we found, the 2-year local control 92%, and almost 52% of the patients remained free of progression, and they were not on any other systemic treatment after completing. And the toxicity in this trial, grade 3-4 toxicity, was quite minimal. So in certain population with high risk, we can combine adjuvant pembrolizumab. We call it like a pseudo-adjuvant pembrolizumab of 6 months to 1 year, and we can give patient a quite longer interval from systemic treatment. Phase 3 trials, we always need it. Unfortunately, this was the one phase 3 trial from USA. We tried to open it at our center as well, but it stopped because of the poor accrual. And it's mainly the medical oncology team. They were hesitant to enroll patients onto systemic treatment, and they would prefer off-trial stereotactic radiation. So unfortunately, at this time, there is no phase 3 trial ongoing for looking at systemic treatment versus radiation for oligometastatic setting. So this is one of my case. I treated 83-year-old lady who presented with stage 3A clear cell carcinoma. At that time, she had surgery and adjuvant pembrolizumab. We don't have data till then. So, and then after 6 months, she had painful metastatic disease at rib. Biopsy confirmed clear cell. She had 20 grain single fraction. And then subsequent, over 2 years, she had left and right adrenal met, treated with 26 grain single fraction, and at 4 years, she remained free of disease. But it's not, important thing is selecting a good patients. It's not for all the patients, but by trying, you're not losing anything. Whether it will result in compromise overall survival, unfortunately, I don't think we will ever have an answer to it. But this is one thing which can be considered for patients with less than 5 sites of disease, but make sure that we are being safe in this location. Coming to the oligoprogressive. So at this site, the oligoprogressive means you have started the systemic treatment for metastatic, and then the patient had progressive disease up till 5 sites. Current standard of care is changing the systemic treatment and having a second-line treatment. But the question, can we target those resistant clones with radiation or with surgery and continue the same systemic treatment? Again, multiple trial studies, but mostly limited by small number of patients and being retrospective. We have only 2 prospective trials, one from Canada, 37 patients, and one from USA of 20. Most of these patient studies both of these studies have enrolled patients with 1 to 3. And the important thing, there is a difference in the era when it was started. The Canadian study started in 2013. At that time, we have tyrosine kinase inhibitors. So that's why we can see in that study all the patients had tyrosine kinase, while the USA study started in 2018. So that's why we have more patients receiving immune checkpoint inhibitor. Both studies reported in European Urology within a space of 4 weeks, almost identical median follow-up of 1 year. And we can see the 1-year local control of 93 and 100%. But the most important thing, which was consistent across both studies, by giving stereotactic radiation, we can delay the need for switch of systemic treatment for almost a year. So by changing the systemic treatment, we are exposing patients to more financial burden and also exposing them to new side effects, and sometimes it can be quite challenging. So with the stereotactic radiation, well tolerated, only 1 patient had grade 3 toxicity. And another important thing, 16 patients in the USA study have already failed second line of systemic treatment, and they were on 3rd or 4th line. If we look at all the data for 2nd, 3rd, or 4th line of systemic treatment, the median progression-free survival is 6 months to 1 year. And in this trial, if we look at it, the patients after giving radiation, the progression-free survival is 24 months. And almost 85% of the patients after 1 year remain on the same line of systemic treatment. So subsequent radiation, by targeting the progressive disease, we can extend the ongoing response. Again, another case treated by us at Peter Max. So 51-year-old gentleman diagnosed with quite extensive metastatic disease. Like you can see, primary in the left kidney with extensive paraaortic lymph nodes. Had a very good response to EP-Nivo with almost disappearance of the nodes. And then after 10 months, he had celiac lymph node enlarged, treated with 24 grain single fraction. And then the same patient after 10 months, 12 months had another progression in the lower para-aortic. And we treated with another 24-grain single fraction. And at 2 years from starting EP-Nivo, the patient still continues on maintenance Nivo. So in certain situations, we can just prolong the ongoing response. The patient doesn't have any toxicity. So by switching the medication, we are putting the patient at risk of exposing new side effects. So again, we can try to gain the maximum benefit of ongoing response from the previous medication. Unlike oligometastatic space, we have quite comprehensive trials going on, mostly phase 2 trial, but there is one from MD Anderson, which is Extend trial, which is looking at phase 3 randomized switching systemic treatment versus same treatment with the adding radiation. So hopefully we will have some answers in phase 3 trial, whether there is any impact of overall survival by SABR and continue on the same medications. Important thing, do we have any optimal dose? So there is only one study to date which have been reported, 105 metastatic sites treated with single versus multiple fraction. So the study demonstrated there is a trend towards improved overall survival in favor of single fraction. But if we look at the table on the left, there was certain patients who had 20 in 5 or 22 in 5, which is a very, very palliative dose. So the radiobiologically, the effectiveness of the multifraction was quite significantly lower compared to the single fraction. So that's why we don't know that whether single fraction is better or multifraction. At Peter Mac, what we do, most of our fractionation is 1 or 3 fraction. In certain situations, in central tumor, we go with 15-5, or liver, where we can go 5 fractions. But if we look at the oligometastatic trial, if you are not having the capability to do stereotactic radiation, think about radiobiologically higher dose. And the most effective safe dose for me is 50 to 60 grain, 15 to 20 fractions, which can give you a good control. You will be losing some local control, but it will be still 80 to 90% local control, but it will be causing less chances of having grade 3 or 4 side effects. Another important is sequence of systemic treatment and SABR. We have quite good safety data, and I think it's particularly safe. At Peter Mac, we don't have any lengthy interruptions. With immune checkpoint inhibitors, we just incorporate radiation in between cycles. We never pause it. For tyrosine kinase inhibitors, most of them have a short half-life, so you can just hold it 2 days prior and then restart 2 days after. Only targeted agent where we need to be careful, which is bevacizumab, but bevacizumab has no role in metastatic RCC. But anyone who is treating stereotactic and the patient, particularly in colorectal tumors, where the patients are having bevacizumab, be careful about when treating central lung tumor or any structure like para-aortic lymph nodes or any peritoneal. There are quite high risk of bleeding or perforation. So if we look at the current NCCN guidelines, it is recommended for oligometastatic or oligoprogressive clear or non-clear cell. But again, patient selection is key. So this is a good review article which we wrote a few years back. So it has covered the stereotactic radiation for different indications, including from primary to metastatic disease. And it summarizes the literature and also gives some good recommendations when to choose and when not to choose. So in summary, I would say some selective patients with oligometastatic, by just watchful waiting, we can delay systemic treatment for 15 months. By giving radiation, we can double it up to more than 30 months. And in certain situations, particularly after Keynote 564, the patients with intermediate to poor risk based on IMDCC, it is reasonable to offer stereotactic radiation or surgery and having 6 months to 1 year of pembrolizumab. For selective patients with oligoprogressive RCC, we can switch the SABR, we can give the SABR and delay the need for switch. And also we know that it's a very well-tolerated treatment with grade 3, 4 toxicity is less than 5, and normally the grade 5 toxicity is almost negligible. Thank you very much, and this is a good message to read. Thank you.
Thank you, Dr. Ali. Excellent talk. Sorry, we're running a bit behind, so in the interest of time, we will not be taking any questions at the moment. We'll move on to the next very interesting session. I hope you guys will really enjoy it, where we'll talk about the management of muscle-invasive bladder cancer. We will have two excellent speakers. We know the bladder cancer management can be very tricky, especially with from patient's perspective when you're looking at organ preservation. We are in the era where surgery is considered gold standard, and we have modern tech with radiotherapy now challenging it. So to get on with it, I'll introduce our both speakers. We'll have Dr. Atif Mancha, if you can invite him. Yeah. So I think you all know Dr. Atif Mancha. So he is a consultant radiation oncologist and head of department at Dow Hospital, and he's got significant experience with the MR Linac. And then we'll have our next speaker after that with surgical colleagues. Thank you.
Thank you, Dr. Tanzil. Bismillahirrahmanirrahim and Assalamu alaikum to everyone, respected chairpersons and esteemed colleagues. A very good afternoon. A radical cystectomy has been long considered as the standard treatment for muscle-invasive bladder cancer and has undoubtedly cured many patients. However, oncology is a dynamic field and our standards must evolve with evidence. The question today is not whether cystectomy works, but whether every patient must undergo bladder removal to achieve cure. I will present data showing that modern chemoradiation provides comparable survival with organ preservation and quality of life in patients with bladder cancers. Organ preservation is a well-established principle across oncology. We routinely practice preserve organs in breast, laryngeal cancers, esophageal cancers, prostate, rectum, anal canal, without compromising a cure. Bladder cancer should also be viewed through the same evidence-based and patient-centered approach. Radical cystectomy has a permanent impact on patients' urinary, sexual, and social life. Even in experts' hands, these quality of life changes are significant. When survival outcomes are comparable, quality of life becomes a decisive factor in treatment selection. Over the last few decades, surgery has been considered as a gold standard treatment for muscle-invasive bladder cancer, but one size does not fit all. There have been major advancements in radiotherapy, precision imaging, and chemotherapy and supportive care. These improvements have transformed outcomes of bladder preservation strategies. Therefore, historical concerns about radiation therapy are no more valid today. Gold standard should not be static or dogmatic. A gold standard must be defined by randomized controlled trial, contemporary evidence, and patient values. When two approaches provide similar survival, less morbid, options must be discussed. Unfortunately, there are no randomized controlled trials with head-to-head comparison of radiation and surgery. The only trials pair selective bladder preservation against radical excision was conducted to address this question, but unfortunately this trial failed. This trial did not fail due to the oncological inferiority of the radiation therapy, but it failed due to the patient's own preferences. It highlights that how strongly the patients value bladder preservation. Randomized trials comparing surgery and bladder preservation are challenging due to patients' refusal and patients' crossovers. This limitation is very well recognized. In such settings, consistent data and high-quality match analysis become particularly important. TURBT, a successful bladder preservation begins with TURBT. Complete macroscopic resection of tumors strongly correlates with the outcome data. This emphasizes the critical role of surgeons with trimodality approach. Bladder preservation is not radiation alone. It is a trimodality which includes chemotherapy and maximal TURBT and early salvage if required. This ensures oncological safety while allowing bladder preservation in responders. TMT, a trimodality treatment, requires a strong multidisciplinary team. Surgeons, radiation oncologists, medical oncologists work in close collaboration. This is a collaborative care. It is not a compromised care. A very well-structured, MDT-driven oncological strategy, not a compromised care. I want to emphasize clearly, trimodality is a structured treatment. Complete combined modality achieves high complete response rates. Multiple series have shown that overall survival rates are comparable to radical cystectomy. This forms the foundation of curative strategy. Over the years, RTOG has conducted many prospective trials, and they have refined the patient selection criteria, radiation therapy techniques, and chemotherapy regimens. With each iteration, outcomes have improved. Long-term data have shown that combined modality therapy has become a safe, tested, and efficacious alternative to radical cystectomy in patients with muscle-invasive bladder cancer. Survival outcomes, this pooled analysis of more than 13,000 patients from 31 prospective and retrospective studies with comparable median ages and comparable other characteristics, the survival are almost equivalent. This contemporary matched analysis eligible for both, patients were eligible for both surgery as well as a combined treatment. All patients had favorable features, but the survival outcomes were comparable in both the arms. So the components of trimodality treatment are maximal TURBT, chemotherapy, and radiation. The success of the treatment depends on the strict adherence to its components. Maximal TURBT, chemotherapy, and radiation are essentials. Any compromise in any of these may compromise the outcomes. There is sufficient data to show that maximal TURBT has an impact on the overall survival. The patients who have incomplete TURBT or subtotal TURBT, they have survival disadvantage. Chemotherapy has been used as a radiosensitizer during radiation therapy, and we have good phase 3 data to show that the addition of chemotherapy to radiation therapy improves survival from 35% to 48%. Different radiation therapy regimens have been used. Modern radiation therapy techniques have further improved preservation outcomes, advances in planning, image guidance, motion management, and as well as dose escalation and hyperfractionation. And individual patient data of trials BC2001 and Beacon have showed that hyperfractionation is as effective as the standard regimen, and it is quite convenient for the patients as well. The overall treatment time is reduced. The improved patient convenience and resource utilization without compromising outcomes. This further strengthens the case for modern radiation in bladder preservation. Now the guidelines, based on this robust data, the guidelines have endorsed the treatment, trimodality treatment. It recommends it as a valid alternative to surgery in patients. These are the nice guidelines, and they endorse that all the patients of bladder cancer, they should be discussed in the MDT, and all the patients must see both the surgeons and the radiation oncologist, and it is up to the patients to have their own choices. So take-home message is radical surgery, although remains excellent curative option, however, it is not the only path to cure. Modern chemoradiation provides comparable survival with bladder preservation and improved quality of life. Treatment decisions should be individualized and patient-centered. MDT approach can preserve bladder in 80% of cases with better quality of life. Patient must be counseled for salvage cystectomy if required. Active follow-up is required for the patient who undergo TMT for early detection of recurrence, and salvage cystectomy is always an option. I would like to acknowledge my colleagues, my doctors, medical physicists, and RTTs. A successful bladder preservation is not achievable without a teamwork. And thank you for your attention. Thank you.
Thank you, Dr. Atif. Excellent presentation. I'm sure our surgical colleagues will have to say a few things to convince us radiation oncologists to kind of favor surgery more. So hopefully it will be interesting discussion now. I'll call upon Dr. Wajahat Aziz, a very experienced urologist with quite a lot of work done in bladder cancer. So it's all yours, sir.
Assalamu alaikum. I am Wajahat Aziz, and I would not claim to be an expert on the topic, but I am in a very good position to talk about the practicality of it because of these three reasons. I trained with the experts. Dr. Hamad Athar is probably the foremost authority on bladder cancer, at least in Pakistan. We at Aga Khan University, we are a high-volume center for radical cystectomy, and there is exactly a definition for high-volume center. It has been calculated like if you do like 30 to 35 radical cystectomies per year, that defines you as a high-volume center. Because beyond that, your results are similar to even higher volume centers. And we have this ongoing activity, a weekly activity, the Uro-Oncology Tumor Board, which we do with our radiation oncology colleagues. And the most important thing, and most of the things which I'm talking about, I have learned from it. And an important aspect of this is that we know more, it's no more like we versus us. Now, Dr. Nasir here and Bilal, they are just like colleagues to me. And this is sort of sounds like a conflict of interest. Like if you ask a surgeon that you need the surgery, he would say that probably you need a surgery. But, well, the same can be we can tell about the radiation oncology colleagues that if you have a radiation gun, you start doing radiation for everybody. And then we have Dr. Farhad Abbas here. When all else fails and we don't know what to do with a patient, we just refer it to him. Okay, so first of all, what we are not debating. So in words of one of our Professor Shamim Khan, he said, like, if you start doing a radical cystectomy, say, for example, for all non-muscle invasive bladder cancers, you would have excellent results. But that's not the point. And nobody can debate that no patient needs a radical cystectomy. You all know the limitations of radiation and trimodal therapy. So what we are talking about then? There are essentially three arguments. The biological one is what I have been taught since my residency days, that bladder cancer is a field change disease. And what does it essentially means? That the so-called histologically normal tissue, even that can have epigenetic alterations. And in our population, especially where most of the patients are either smokers or this with gutka and tobacco abuse, this is usually the situation. And some idea can be gained from the appearance of the tumor. You have these two types of the tumors and the third one, and from the appearance, you can get some idea that this is going to be a more diffuse disease. And sometimes you see a situation just like a linitis plastica. And biologically, there are ways to define that type of tumor. Like, say, for example, if a patient have CIS or positive cytology, and in current era, people have tried to find certain tumor markers which can define this type of tumor. And this is probably the type of tumor which is not appropriate for trimodality treatment. And then the second problem is the precision of our current treatment. What we really want, that there is a radiation which only hits the cancer cells and preserve the rest. So we essentially want a precision site like this. But we all know the situation is more like this. So there is nothing known as no collateral damage. It always happens. It happens with the surgery, it happens with the radiation. We are moving towards more and more precision, but despite all the advances of military and US and all military, even then you can't claim to have zero collateral damage. The evidence base, my colleague Mansha explained that very well, but I would emphasize one point. The real life results are different from experimental and observational study. And that is not something we all know that. And there is reasons for that, because when you design a trial, you select the patient who is most appropriate for that therapy, one, and who is the more likely to tolerate that therapy. But when we implement those results on our patients, we tend to sort of forget about that. So I would give that for a classic T2 bladder cancer, which is very focused, no CIS, single lesion, probably best person for the trimodal therapy. But if it is not the case, and for some reason or other, patient cannot receive the standardized protocol, and there can be several reasons for it. The reasons can be patient-related or our own protocol-related. Many of us do not have a very well-defined existing protocol for trimodality treatment. So that is something we need to define very accurately. And of course, the results, when you see the randomized controlled trials, they are different. And when you see the studies which have followed the patient for 10 years or 15 years, especially the bladder intact survival, because many of those patients, at least 50% of those patients down the line need a salvage cystectomy. Okay. And salvage cystectomy in that case, oh man, this is so troublesome. We as surgeons do not like it. So it is, the bladder sometimes is difficult to take out, sometimes it ruptures when you are taking it out, or you enter the bowel. So it's really a shitty job. No one wants to do that. Then the practical issues. From the patient perspective, it's like choosing the lesser evil. So Kevin, the image here is AI generated, but the story I'm going to tell is from Persian folklore. And most of the senior colleagues might have heard it, but I have now recently found out the junior people do not even know the story. It goes like that a person was sentenced to either receiving 100 lashes or 100 onions. So he started off with the onions. Bring me the onions, and probably I would go out and I would deal with the chemotherapy and few doses of it. And down the line, after 10 or 15 onions, he is like, no, bring the lashes. So I would deal with that. And after 10 or 20 lashes, you are like, no. Bring back the onions, those were better. So at the end of the story, he ends up receiving 100 lashes and 100 onions. So at times it is a situation. The patient ends up receiving both the surgery and radiation, which is the worst situation you can have. And on another practical aspect is radical cystectomy is like doing an amputation. And since my internship days, I have seen many patients with these diabetic foots who have these horrible amputations. And radical cystectomy is essentially such a procedure. It is morbid. There are ways to avoid this morbidity. There are ways to avoid this stoma even. You can make, if a patient is an appropriate candidate, a neobladder. Yes, and with minimally invasive techniques, the argument from radiation people is that they have become very good with their precision radiation, and rightly so. So surgeons have also evolved. We are later in evolution, but we do have evolved. with robotic surgery and even with the traditional open surgery, there are techniques to minimize the morbidity. But I have seen enough people dying of a very horrible protracted course and death trying to salvage their limbs, or for that matter, their bladder. So at times, it has to be done. And I can assure you one thing. If we become that precise in the current era of precision visit, the situation is we are like, if we can be very precise with our therapy and we can be very precise with our patient selection, with all the evidence coming up, probably we can avoid radical cystectomy. And yes, and we would be the happiest people if that happens. And I know Dr. Farhad Abbas for sure, he would be happy to play golf rather than taking out the bladders. But we are still not there. That precision, we are trying to approach that, but we are still not there. And when we have to take into account all these things, the data from radiology, the data from tumor markers, the data from genetics, you become less sure rather than more sure at times. Secondly, are we as surgeons, we as radiation oncologists and our patients, are we ready to accept the failure? So if a patient is going for a trimodality treatment, the discussion should not be like that this would save your bladder. It should be more like this is an attempt to save your bladder. And if it doesn't save, be it, so be it. That's why we as surgeons exist. So to summarize, radical cystectomy for more than T2 disease, it is still the gold standard. If a patient who has a T2 disease, but there are factors which make it sort of not appropriate for bladder preservation, consider a radical cystectomy straightforward. There are additional advantages of radical cystectomy, like it eliminates the problem of field change disease, it avoids the radiation toxicity, and it does happen. And there are, of course, the pathological benefits. The last point, that it is less dependent on patient compliance, probably not fully true, because even if you do a radical cystectomy, the results are not 100%. It's roughly in the range of 60 to 70%. The 30 to 40% of the patient would have some sort of recurrence. On the positive side, because traditionally we are doing more aggressive, we tend to do more aggressive treatments, we have lesser recurrences as compared to in the literature. So I would end here and thank my radiation colleague people for invitation. Thank you.
Excellent talk. I'm sure there will be a lot of questions. All I would say from patients' perspective, I think we need to keep them at the center of all these discussions. And probably what the crux of these two discussions is that having a well-functioning tumor board meeting will prevent radical cystectomies and get the right patient, the right treatment. Any questions to start with? I know we didn't have time for questions earlier. Any questions if somebody wants to ask about any of the topics? Yes, please. Do you want to come to the mic, if that's okay?
Yeah, thank you. If I want to add something to this debate as a medical oncologist,
of course.
First thing is that there is a proven benefit of neoadjuvant chemotherapy, even if you are going for a surgery or chemoradiotherapy, and also the survival advantage. Second thing is, in my opinion, in my observation, sitting in MDT, it is not to prove one treatment is superior with a surgery to a chemoradiotherapy. It is an individual decision, and as a clinician, we have a responsibility to tell the patient honestly and let him decide, rather than we are taking decision on his or her behalf. Other thing is that in the MDT, as a clinician, when I want to intervene or want to make a decision on the patient behalf, is based on a scientific evidence. Like if the patient have pure squamous cell carcinoma, I would say, okay, not for neoadjuvant chemotherapy, it's not chemosensitive, go for surgery, or any other variant histology. But in a MDT, most of time, we have a decision, neoadjuvant chemotherapy followed by chemo, radio, or surgery. Let patients see both specialty and then decide about the treatment. Thank you.
Absolutely. I think very valid points, because as we said, at the end of the day, these both are very effective options with pros and cons. There will, of course, be some patients where one modality will favor the other. Yes, Dr. Irfan, please go ahead.
Yeah, thank you very much. Excellent presentations. I've nearly forgotten what was my question from the prostate time.
We'll give you a bit of time to think. Lunch is nearly there, so I'm sure.
So I think my question really is to Mutahir, and the subsequent question is to Dr. Kevin. So question to Mutahir is that it is like, we all know that STAMPEDE trial established the role of radiotherapy to the prostate in M1 disease. But what I wanted to know is that your feeling about 55 in 20 versus 36 in 6, especially in the resource-limiting countries. It appeared from your talk that you are suggesting that 55 in 20 or a prolonged fractionation is better than the shorter fractionation program, which of course has huge implication not only for the patient and for the resource-limited country. When we go back and we know that in STAMPEDE it was not a randomized allocation between these two radiotherapy schedules, people were allowed to pick which one they want to pick. And maybe people picked 36 and 6 for those gentler patients who had some one reason or the other. And still, there is an overlap of confidence interval. Still, there is no, in my opinion, any statistical significance for inferiority or superiority. Do you think that both are very equally applicable options, and in resource-limited country, we should be proposing lesser number of fractions other than a prolonged period of course of a metastatic disease?
You want to come on stage with that?
Thank you, Irfan. If you see in a STAMPEDE, almost 2,000 patients were accrued. And this subset analysis on the fractionations was done just on the 300 patients. And that's one of the reasons, actually, most of the clinical oncologists or UK practice is still with it. Mostly it is 36 in 6. But because the subset analysis was favoring the 55 in 20, which we usually reserve for the patients who has achieved an excellent response outside the pelvis. But I agree that for the resource-drained countries, 36 in 6 is still a valid option.
Which unfortunately includes UK NHS as well. So this question to Kevin is that, we have here two situations, 55 in 20 and 36 in 6. And you used your patient 36 in 6, which I completely agree. Gentler, patient did very well and liked it. My question to you is that, yes, STAMPEDE said 55 in 20 at the start when it was designed, based on what all of the investigators, which including myself, thought that this should be the gentler kind of radical type of radiation, which we now call palliative, by the way, that radical, palliative, and strategic, which Mutahir showed, we call it palliative now, which is a radical palliation. But subsequently, majority of the people who are giving 20 fractions, including myself, if we are opting for 20 fractions, we are giving 60 in 20. With the modern radiation, there is no difference in side effects, and we just give 16-20 to those guys. But I will be interested to hear your opinion that in your practice, if you were going to give somebody 20 fractions, would you stick to still 55 in 20? And if you were going to do 60 in 20, then the subsequent patient who you're going to give 36 in 6 once every week, which is quite a gentle thing, would you try to intensify a little bit, either giving it twice a week or giving it 36.25 in 5 or something like that?
Does it work now?
Yeah.
That's a fantastic point you make. Right now, if I have a younger patient and I want to be aggressive going after the prostate, I actually do 3625 in 5 to the prostate once weekly, and that's based on a study called Patriot. I know it's just phase 2 data, but it showed that once weekly actually was much easier and more tolerable than every second day fractionation. It was 40 and 5 to the prostate, 3625 and 5 to the surrounding. And then the 55 and 20 versus 60 and 20, I'll usually just go for 60 and 20. The caveat is older patients, more symptoms. And these conversations I have with patients, oftentimes they take like an hour because I'm going through 3 or 4 different approaches we could have. And ultimately the patient decides.
Would you go far enough to say for the resource-limited country where the machines are overloaded with so many patients, if they have a patient who has got M1 disease and they are going to there is no contraindication between either of these approaches, would you favor weekly 5 fractions for 36.25 or 40 in 5, whatever, as a weekly fraction to offload those machines then without any difference?
Yeah, I think it's perfectly reasonable.
Great, thank you so much. I think we'll conclude the session. Thanks, everybody. Just a couple of announcements. You will have a QR code on the screen now. Please give your feedback. It's very valuable, and I'm sure the organizing committee will really appreciate that. For international faculty, we will have lunch in Ambassador 3. You can use the front door to head there. Everybody else, please head to GBR. And just one last thing to add regarding the poster presentations. It's between 5 to 6 p.m. Later today. So it will be great if you all can join. Thank you. Thank you, everybody.
Assalamu alaikum. Please be seated. Good afternoon, everyone. I welcome all the guests, my speaker, panelists, friends, and colleagues. It is my absolute pleasure to start the session 12 on breast cancer, a topic that continues to evolve and remains relevant both regionally and globally. This session has been carefully curated to cover the full spectrum of modern breast cancer care, from genetic risk assessment and early paradigm shifts to novel systemic therapies and precision radiation decision-making. I am Dr. Fatma Shaukat, consultant radiation oncologist working at Cyberknife and Tomotherapy Center of JPMC. Will be moderating this session under the chairmanship of Dr. Mazhar Ali Shah, a consultant radiation oncologist from Shaukat Khanam. Sir, please welcome on the stage. So before we begin, I would like to invite our panelists. Our first panelist, Dr. Nadeem Parvez. He's a consultant radiation oncologist working at GICC Abu Dhabi, UAE. He's also a general secretary of AMSTRO. Second, we have Dr. Sameed Hussain, radiation oncologist at CMH Lahore. He's not here. He'll be joining soon. Okay. So our third panelist is Dr. Mansoor Rafi, the radiation oncologist from SIUT, Karachi. Our fourth panelist is Professor Dr. Zahid Mahmood. He's a renowned oncologist based from Quetta, recognized for his clinical expertise and dedication to cancer care. He has built a strong reputation through his professional practice and patient-centered approach. Do we have him here? Okay. So moving on to our first talk, it is my pleasure to invite Dr. Mohammad Usman Rashid, a senior research scientist and head of basic sciences research at Shaukat Khanam Memorial Hospital, Lahore. Dr. Usman is a pioneer in cancer genetics in Pakistan, founder of country's first genetic laboratory, and has authored over 100 high-impact publications. Dr. Usman will be sharing his work on multi-gene panel testing on Pakistani familial breast cancer patient. Please, Dr. Usman, the floor is yours.
Assalamu alaikum. Thank you, Dr. Fatma, for the kind invitation. So, good afternoon, everyone. It gives me immense pleasure to be here in Karachi, and I'm thankful to the organizer, especially Dr. Azhar, for the kind invitation. So, breast cancer is a clinically, biologically, and epidemiologically heterogeneous disease. It ranks first both in industrialized and in developing world. So, identifying individuals with an increased risk of breast cancer is an important aspect of modern oncologic practice. Historically, sequential single gene testing was offered to at-risk individuals, but with the advent of NGS, multi-gene panel testing has replaced sequential single gene testing. But one of the challenges faced by clinicians is the identification of right candidates of genetic testing and which clinically actionable genes are specific to that population. So identification of a Pakistani-specific clinically actionable genes are important to provide a valuable and economical genetic testing strategy into clinical practice. Globally, more than 2.3 million new breast cancer cases are being diagnosed each year, and about 0.67 million of these women die from this disease. High incidence rate is reported in North America, Western Northern Europe, Australia, and New Zealand. But you will appreciate that a disproportionate number of deaths are reported in low-middle income countries. So breast cancer is a growing challenge in Pakistan. Pakistan is the fourth largest population in Asia and the fifth one in the world. And there is a lack of breast cancer awareness. It takes at least 15 months for a woman to present to the clinic. And for that reason, majority of Pakistani females are presenting at an advanced stage.
It is estimated that 1 out of 9 Pakistani females will be diagnosed with breast cancer during their lifetime. So among the female cancers, breast cancer accounts for about 1/3 of all female malignancies. About 30,000 new breast cancer cases are being diagnosed each year and 16,000 deaths are reported. And Pakistan has one of the highest mortality among Asian women. And contrary to the Western world, majority of Pakistani females are presenting at an advanced stage, at an age younger than 50. And one subtype of emerging interest is triple negative. So Pakistani woman has increased prevalence of triple negative phenotype as compared to the West. About 15 to 20% of all breast cancer cases are familial, and there are two groups, high penetrance or high risk genes and moderate risk genes account for about 20% each for familial breast cancer and about 18% for low risk genes. These high and moderate penetrance genes, the frequency is very rare. They are very rare, but the risk is high to develop breast cancer, whereas low risk genes are very common. So you can appreciate it is very important to identify potential risk factors specific to a population so that early detection and prevention strategies could be offered to that population. And management guidelines only exist for specific genes. There are about 20,000 genes in our body. So do we need to screen all genes? No. Just to focus on those genes which are more prevalent and associated with this disease in Pakistani population. And the major factors involved in the identification of likely pathogenic variants are personal and family history of breast cancer, clinico-pathological features, and geographical and ethnic origin of patients. So there are several guidelines available for screening, like American Society of Breast Surgeons recommend that all patients should be screened for BRCA1 and 2 and other genes. But there is no specific guidelines for Pakistani population. Therefore, it is important to identify a Pakistani-specific and clinical relevant multi-gene panel for this population. So what is multi-gene testing? This is the sequencing of multiple genes, up to 200 or more. And when to consider multi-gene panel testing? When there are more than one gene known to be associated with a specific disease, phenotype-directed testing, or for individuals who are tested negative for a syndrome, but their personal and family history suggests there is something going on. What are the benefits? It's cost-effective, short turnaround time, and there are increased detection rate. Contrary to the sequential single-gene testing, which was laborious and time-taking, so within a week you get the results. And based on this knowledge, clinicians could tailor the treatment strategies. What are the limitations? Which genes should be included? And it also depends on the lab expertise because complex workflow is involved. And if there are more than one gene's pathogenic variants identified, so how to offer what are the best options available? And based on available data, so you may find variant of unknown significance. So how to counsel that individual? And what about the cascade testing? If a mother is tested positive, so her daughter or at-risk first-degree relatives should also be tested. So ideally, genetic testing should be offered by a professional genetic experts for pre- and post-test counseling. So what do we know about this in the West? It's well established in the developed world, but the gene number vary from academic versus commercial labs. And according to PSCO guidelines, there are 14 genes, which are 7 of them are strongly recommended, and other 7 are less recommended. By recent German breast cancer study, so these genes were validated, but in a larger study, including more than 100,000 breast cancer women, so additional genes other than these 14 contributed very minimal. So what do we know about multi-gene testing in Asia? Asians comprise 60% population of the world, and there are more than 2,000 ethnic groups. But genetic testing is underused because of financial reasons. And due to under-testing, interpretation of identified variants leads to variant of unknown significance, because all variants needs to be updated in the database. If there is nothing known, then whatever you will identify, mostly it would be variant of unknown significance. Why? Because more than 86% of genetic studies have been conducted among Europeans and North American. So that knowledge could not be just implemented to the patients from a different genetic background, like Pakistani women. So there are several high-risk studies have been conducted in Asia on samples ranging from 100 to 400 samples, genes ranging from 20 to 115, with a frequency ranging to 7 to 30%. But beyond 14 gene panel, there is a marginal contribution. So what do we know about Pakistan? Over a period of last 25 years, we have performed sequential single gene testing, and what we found, that pathogenic mutations in these 7 genes account for about 40% of familial breast cancers. Is there any information about multi-gene testing in Pakistan? So there are no large-scale nation-led NGS-based testing on familial breast cancer. Data is very limited. And to date, only 2 studies have been performed, but they just sent the sample abroad. Both studies were from Karachi, including 84 sporadic samples, and the frequency was about 12%. Another study from Karachi on high-risk patients, not only breast cancer, but from different syndromes, and the frequency was about 22%. Both studies relied on foreign testing. And there are no national guidelines for genetic testing in familial breast cancers from Pakistan. So which gene should be included? So therefore, this is very important to conduct such kind of study. So we conducted this study to investigate the diagnostic yield of this 14 gene panel on Pakistani familial breast cancers who were previously tested negative for pathogenic variants in these genes. Red ones are those which have been comprehensively screened and found negative. So 263 histologically confirmed breast cancer patients were identified, and they were stratified into 3 different risk groups: families with 2 breast cancers, they had 80, families with 3 breast cancers, 130, and families with 2 breast and ovarian cancer. This included 53 patients. Among these, 103 were excluded because majority were BRCA1 or BRCA2, and the remaining 160 were screened for these 14 genes. This is the workflow, and all mutations were identified. What we found, that likely pathogenic variant were identified in 29 out of 160 patients with a frequency of 18.1. And here you see the distribution of mutations. The most common was among BRCA1 with a frequency of 8.8. Second most common gene was BRCA2, 3.8. And there is marginal contribution of other 5 genes. So in total, clinically actionable genes for this population are these 7 genes. So these are the germline variants identified, pathogenic, likely pathogenic. These 3 were recurrent ones. And here you see the characteristics of families harboring these mutations based on genes. Among these, primarily they are identified in breast cancer families, but for BRCA1, 5 families, and for BRCA2, 1 family also have the history of breast as well as ovarian cancer. So here you see the frequency of pathogenic, likely pathogenic variants among families with 2 breast cancers. The frequency was about 11%, families with 3 breast cancers, 20%, and families with breast and ovarian cancer, 25%. So you see that with the increase in the number of cases or the phenotype, the prevalence increases. When we stratified into triple negative versus non-triple negative, so triple negative were identified only in BRCA1, PALB2, and RAD51C. And BRCA1 and 2 accounted for about 70% of all identified mutations. So when we combined this data with our previous data, so the cumulative prevalence was found to be 50%. 132 out of 263 patients harbored mutation, and there was a predominance of BRCA1 and 2, which was 93.2%. And the recurrent mutation accounted for about 60%. So here you see the clinical pathological features for pathogenic, likely pathogenic variants presented at an earlier age, 35.9, whereas non-carrier presented at a later age, 44.8, and they were more prone to have bilateral breast cancer, ductal histology, and higher tumor grade or triple negative phenotype. So what to do for such patients? So there are recent NCCN guidelines. So all these genes confer substantial risk to develop breast and ovarian, and also several cancers. Among these, the most common are pancreas, prostate, and melanoma. And for TP53, this is a multi-organ cancer susceptibility gene. A variety of cancers are at risk. So what are the recommendations? So annual mammogram starting from age 40, and they have specified gene-wise, so you can see over here. But there are also clinical drugs available, PARP inhibitors for BRCA1 carriers, BRCA2 carriers, and PALB2 carriers. We have also identified variant of unknown significance. ATM was the most common. These are unclassified, so we cannot offer any kind of strategy for such individuals. So what are the strengths and limitations of this study? So this is a single center study, and the first nation-led study performed within Pakistan, thereby helping to establish local capacity for high quality and in-country genetic testing and research. And there was the ethnic diversity. Patients from different ethnic origin were included, and all patients identified with NGS were confirmed by Sanger sequencing. Limitations were also observed. Copy number variants were not detected by NGS, and large genomic rearrangements beyond BRCA1 and 2 were not screened. So what are the clinical implications? So this is the first study, as I have explained, and likely pathogenic variant in 7 clinical actionable genes account for about 50% of all mutations. And it provides a first population-specific genetic profile and proposes a cost-effective first-year genetic testing strategy. And it could inform national guidelines. The number of genes, if you increase, the cost would also increase. If you reduce the number of genes, the cost would also reduce. So based on that, clinical national guidelines could be offered, and there is no more need to send samples abroad. And it could improve the access to precision oncology for high-risk breast cancer families in Pakistan. So this is a summary in which these are the distribution of genes with pathogenic variants and also variant of unknown significance. Overall, these 7 genes have a detection rate of 50%, and there's a predominance of BRCA1 and 2, which is 93%. And this study provides a population-specific genetic profile and implement a cost-effective first-year genetic testing targeting these 7 genes in Pakistani familial breast cancer patients. And this is the paper, if you would like to have. It's available online, published a couple of months before. At the end, I'm thankful to, it's a collaborative effort in which departments from our hospital, like oncologists, medical oncologists, clinical oncologists, Dr. Mazhar Ali Shah is sitting here, are involved. Breast surgical oncologists like Dr. Amir, Dr. Amna, and study coordinators, and my team from basic sciences, and pathologists like Asif Loya. And obviously, this was not possible without the support of our management, Dr. Faisal and Dr. Asim. And also my collaborators from across the globe. Thank you very much.
Thank you. Thank you, Dr. Usman, for the thought-provoking presentation. And now we move on to the second talk. So early breast cancer management is evolving rapidly with increasing emphasis on personalization, de-escalation where appropriate, and evidence-driven intensification when needed. To discuss this important topic, I invite Dr. Hira Asim, consultant clinical oncologist at Shifa International Hospital, Islamabad. Dr. Hira, over to you.
first पे जाएं. Thank you. Assalamu alaikum, everyone. Thanks to the organizers for inviting me for this talk. So I'm talking about adjuvant systemic treatments in HR-positive, HER2-negative early breast cancer. Here are my disclosures. So when I see HR-positive, HER2-negative early breast cancer patient entering into my clinic, I tell them that this is a good news. So we are relieved that at least they haven't got triple-negative breast cancer or HER2-positive breast cancer. However, to be honest, I feel that we underestimate the risk of recurrence in these patients. So these patients, they are also at a considerable risk of recurrence. So 50% of the recurrences, they are seen early within 5 years of diagnosis, and the risk of recurrence remains beyond 20 years. So you can see on the graph on the right side that there is a tail to the curve, which means that these patients had a risk of recurrence for a long time. So the risk of recurrence is considerable, irrespective of the risk factors that we know, irrespective of the nodal status. If we see the bottom graph on the right side, patients who have N0 disease, they have at least 22% risk of recurrence at 20 years, while those patients who have more than 3 positive lymph nodes have at least 50% risk of recurrence. So majority of these invasive events that occur, they are distant metastasis, and these patients, they are incurable. So this is data from control arms of CDK4/6 inhibitor adjuvant phase 3 trials in HR-positive, HER2-negative stage 2 and 3 breast cancer, showing that the risk remains regardless of the nodal status. Up to 11% of the patients with N0 disease, up to 13% of the patients with N1 disease, and up to 24% of the patients with N2 or N3 disease, they experience invasive disease event within 3 years of diagnosis and within 3 years of receiving the standard adjuvant treatment. It was seen that in NATALY trial, 1 in 8 patients, they are expected to have an invasive disease event by 3 years of diagnosis. So similarly, the long-term recurrence risk is also significant. Patients who have ER-positive early breast cancer and have stage 2 disease, they have at least 30 to 40% risk of recurrence. And those patients who have stage 3 disease, they have 50 to 60% risk of recurrence within 20 years, even with standard of care endocrine therapy. And the approved targeted treatments that we have, they cover a majority, only a minority of patients, like olaparib in triple-negative BRCA mutated patients, and abemaciclib in very, very high-risk node-positive patients. So the majority of the patients, they are at risk without any effective option to add on to endocrine therapy. So what are the clinical pathological features that should be considered in defining high risk? So patients who are not considered high risk, they are still at a risk of late recurrence. So for example, if you look at the graph on the left side, if we look at small tumors like T1 tumors, so these small tumors, if these patients have N0 disease, the risk of recurrence at 20 years is around 18%, while it is more than 40% if they have more than 3 positive lymph nodes. And the patients with small T2 tumors, they also have considerable risk of recurrence. It is 29% at 20 years if they are node negative, and 60% at 20 years if they have 3 or more positive lymph nodes. This is a pooled analysis suggesting an incremental increase in the risk of recurrence with passing time. So the 3-year pooled invasive recurrence risk for stage 1 to 3 patients with standard treatment is 7% at 3 years, while it increases to 12% at 5 years. And in 4 CDK4/6 inhibitor trials, this 3-year pooled risk in stage 2 and 3 patient is around 15%. So the short-term recurrence risk is also considerable, and it accumulates over time. So these are the clinical pathological features we all know which poses a patient to high risk of recurrence, like tumor size, tumor grade, and nodal burden is a strong prognostic risk factor. Similarly, genomic profiling if the score is higher, those patients that are at higher risk of recurrence. However, we should know that patients who are N0 or N1, ER-positive early breast cancer, they don't have similar risk of recurrence. For N1 patients, additional risk factors like grade 3 or T3 tumor size, it doubles the increase in the risk of recurrence or death. And for N0 patient, additional biological features treble the risk of recurrence, like grade 3 and grade 2 with high risk, high Ki67 of 20% or high genomic test score. So this is a very important study that provides a real-world evidence of risk of recurrence in early-stage breast cancer. This was presented in San Antonio in 2024. It divides the patient with N0 into low risk and high risk, depending on the high-risk features like tumor size, grade, and Ki67. Similarly, patients with N1 disease, they were classified into low risk and high risk. High risk if they have tumor size of more than 5% and grade 3 disease. So this study showed that high-risk N1 patients had worse outcome versus N1 non-high-risk patients. There was 2.2-fold high risk of recurrence and 15% difference in the risk of recurrence at 5 years between N1 high-risk and N1 non-high-risk patients. And the risk of recurrence in N1 high-risk group was 2 to 3-fold higher than any of the N1 subgroup, regardless of the nodal status and the risk status. The 5-year risk of recurrence is similar among N1 low-risk, N0 high-risk, N0 low-risk, and in all cases, lower than N1 high-risk group. So N0 high-risk, N0 low-risk, and N1 low-risk has a recurrence risk of around 7 to 9%, while N1 high risk had a recurrence risk of around 26%. So there is a considerable risk of relapse. It is highest in the early years, in the first 2 years, and the risk remains over the following years. So we need an excellent protection in the initial years, and we also need a continued protection in the subsequent years. So this data also provides a real-world evidence of risk of recurrence in patients with N1 and N0 with high-risk features. So this is Flatiron database, including more than 15,000 patients, and it shows that N0 high-risk patients and N1 group have similar recurrence risk, and patients with N0 high-risk, they have worse recurrence risk than patients with N0 non-high-risk disease. At 7 years, the recurrence risk was 2.9 times greater. And N0 high risk was defined in NATALEE trial as with tumor of more than equal to T2 or T1 with either grade 3 or grade 2 with either high Ki67 of more than 20% or recurrence score of more than equal to 26. So ribociclib provide a unique mechanism of action, and the duration of therapy is also critical in preventing early and late recurrences. It brings high free drug concentration, providing more time for on-target CDK4/6 inhibition and subsequent senescence and priming of the immune system, leading to reduction of the micrometastasis and prevention of recurrence. So let's talk about NATALEE trial. Its 5-year analysis was presented recently at ESMO 2025, depicting its long-term efficacy and safety of ribociclib in early breast cancer. NATALEE trial is a large, open-label, multi-center, phase 3 randomized trial. It included a broad group of patients with stage 2 and stage 3 HR-positive, HER2-negative early breast cancer. It included patients who had previous endocrine therapy up to 12 months. It included patients who were N0, but with high-risk features like grade 2 and evidence of high risk, Ki67 of more than 20%, Oncotype DX score of more than equal to 26, and grade 3 disease. All N1 patients were included, and all N2 and 3 or stage 3 patients were included. So it randomized patients to receive ribociclib 400 milligram per day, 3 weeks on, 1 week off, for 3 years, plus a non-steroidal aromatase inhibitor, letrozole or anastrozole for more than equal to 5 years, Patients, premenopausal women and men also received LH-RH analogs. Patients were randomized to receive ribociclib plus non-steroidal aromatase inhibitor or aromatase inhibitor, non-steroidal aromatase inhibitor alone for more than equal to 5 years, along with HRH analogs in men and premenopausal women. The primary endpoint was invasive disease-free survival, recurrence. Secondary endpoint was recurrence-free survival, distant disease-free survival, and overall survival. And the exploratory endpoints was distant recurrence-free survival. Its primary analysis, final invasive disease-free survival, and 4-year exploratory data has already been presented and studied. Here we are discussing about 5-year pre-specified analysis. So at a median of 55.4 months of follow-up, ribociclib continues to demonstrate a durable IDFS benefit in intention to treat population with a delta of 4.5 and hazard ratio of 0.716 and p-value of less than 0.0001. The benefit was consistent in all pre-specified subgroups, including pre- and postmenopausal women, whether they have received previous chemotherapy or not, whether they have received endocrine therapy or not, stage, irrespective of the stage, irrespective of the nodal status, and irrespective of the Ki-67. So IDFS benefit was seen both in node-positive and node-negative patients. With a median of 2 years of ribociclib continues to demonstrate persistent benefit in high-risk N0 and node-positive disease. There was a 40% reduction in the risk of developing an IDFS event in node-negative disease, and there was a 26.3% reduction in the risk of developing an IDFS event in node-positive disease. More invasive disease-free survival events were distant recurrences, which were common in non-steroidal aromatase inhibitor arm. So the combination arm patients had less distant recurrences, including bone, liver, and lung recurrences. Ribociclib, a non-steroidal aromatase inhibitor, demonstrated continued benefit in distant disease-free survival and distant recurrence-free survival with a delta of 4.3 and 4, respectively. As overall data matures, there is a positive trend favoring the combination arm with a delta of 1.6 and hazard ratio of 0.80. There is 20% reduction in the risk of death in the combination arm compared to aromatase inhibitor alone arm. Neutropenia was the most common adverse event seen in the combination arm. Most grade 3 adverse events were asymptomatic. There were lab findings that were easily identifiable, manageable, and reversible. In addition to neutropenia, liver-related adverse events and QT prolongation was also seen in the combination arm. 22.8% of the patients had ribociclib dose reduction due to adverse event, while 19.7% of the patients discontinued ribociclib due to adverse events. With all patients off ribociclib treatment for a median of 2 years, no new safety signals were identified. With 12.9 months of additional follow-up, since the prior 4-year exploratory analysis, 5 new deaths due to adverse events occurred. These deaths were not related to the study treatment. The proportion of the patient who developed secondary primary malignancies was also similar in the two groups. So ribociclib, a non-steroidal aromatase inhibitor, demonstrated persistent IDFS, distant disease-free survival, distant recurrence-free survival benefit over non-steroidal aromatase inhibitor alone. And the overall survival results shows improving trend. So in conclusion, with a median follow-up of 55 months, NATALY represents one of the most comprehensive and prolonged evaluation of adjuvant CDK4/6 inhibitors in early-stage breast cancer. And the increasing absolute IDFS improvement from 2.7 at 3 years to 4.5% at 5 years reinforces the sustained benefit. And the positive overall survival trend also reflects a growing survival advantage that may reach statistical significance with further follow-up. Thank you very much.
Thank you, Dr. Hira, for sharing your valuable insight on optimizing early breast cancer. Moving on to our third talk, So triple-negative breast cancer is a challenging subtype. However, the emergence of antibody-drug conjugate, that is ADC, has significantly improved the therapeutic expectations and outcomes. It is my privilege to introduce Dr. Sundar Siaya, consultant clinical oncologist at Queen Elizabeth Hospital, Birmingham, UK. Please welcome Dr. Sundar Siaya.
Assalamu alaikum, everyone. Thank you again for inviting me over. And I don't know whether to thank you or not to giving me this difficult task of telling you about triple-negative breast cancer. I think I'm a little bit excited about triple-negative breast cancer now because it's not as doom and gloom as it used to be. So these are my disclosures. Talking about triple-negative breast cancer, it is not all one entity. We just have to remind ourselves that histologically, it is a heterogeneous group of cancers. You've got your basal phenotypes, which particularly do badly, and then you have got your BRCA-mutated patients as well. You've got a very small subtype of then medullary cancers. You've got adenoid cystics and metaplastic cancers, which thankfully we don't see very often. They are quite difficult to manage. And there comes your role of networking and talking to colleagues to see which treatments work better for these ones. I just wanted to remind you about this graph. This essentially shows a 5-year survival period in real-world population. And I wanted to draw your attention to this tail here. And I want you to, I don't know if you can, I don't have a pointer. Just wanted to show you. Yeah, here. So what I wanted to show you was if you try and then just keep this graph in mind and see that over sort of 5 years, how you have a sudden drop and then you've got this tail. So, your survival is pretty bad. It's about 20%. And for your first-line metastatic breast cancer patients, more than half don't even get there. So, you've only got 20% of patients left after first-line chemotherapy, and even in those 20%, not all will be fit to have your second-line treatment, unlike your hormone receptor-positive, HER2-negative receptor breast cancers. So early 2025, this was kind of your treatment algorithm. So, when your triple-negative breast cancer patient walks in, you are wanting to do PD-L1 testing. If they are young patients or if they've got family history, you want to do genetic testing as well. You want to find out whether they are BRCA mutated or not. And then based on that, you either offer them chemotherapy, immunotherapy in the first-line setting, or you offer them platinum doublets if PD-L1 negative, or if they are BRCA mutated, you offer them PARP inhibitors. I'm sorry about this busy graph, but essentially what I wanted to show here is how the treatment pattern has evolved over the last 2 decades. And again, what I want to show here is essentially, if you look here in the third-line setting, you can see this yellow bar is the antibody-drug conjugates, which it was just about 4%. But here, which is 2021 onwards, you can see that this has taken the center stage, and you've got more than 30% of the patients being offered that. So that's where the new excitement for us is. I'm just gonna, for our new trainees and for our fellows, I'm just gonna go back to the basics. Where is it that these new drugs work? So we have got trophoblastic cell surface antigens. These are epithelial receptors. They are overexpressed in quite a lot of cancers, especially the breast, lung, and GU cancers. They are not there in the normal cells. Unfortunately, they are associated with poor prognosis, and this is where we actually exploit our treatment pathways. They do play a significant role in proliferation, in oncogenic transcription, and cell cyclin expression, so they work at the cellular level. So what are these antibody-drug conjugates? So essentially, you have got an antibody which is humanized, and then what you do is you hydrolyze, you link your SN38, which essentially is a more potent compound even than irinotecan. And the advantage of this is that you can actually attach a very high payload. So this novel drug, sacituzumab govitecan, has got an antibody-to-drug ratio of 7.6 to 1, which is very high. And the most important thing here is that no internalization is required, and there is a significant bystander effect. So you don't actually need the drug to actually go into the cancer cells. Even it is very close to the cancer cells, it will still hydrolyze and it will still release the payload, and you will get quite significant cell kill. The other important drug is datopotamab deruxtecan, very similar antibody-drug conjugate. However, the drug-to-antibody ratio is slightly lower at 4:1. So the landmark trial was Bardia in 2021. Essentially, they tested it in the third-line setting. I'm going to go through a little bit in detail with all the graphs, but essentially these were triple-negative breast cancer patients who had already been through 2 lines of chemotherapy treatments. There was about 500 patients, and they were allocated sacituzumab govitecan SG, I'm going to call it for the purpose of the talk, versus physician's treatment of choice. And I'm going to show you the graphs in a little bit more detail, but essentially you can see the waterfall plot is already quite significant. You can see how much the patient had already been responding as compared to the physician of choice treatment. So as we stand today, we've got 2 approved ADCs in the HER2-negative metastatic breast cancer. One is from DESTINY-Breast04 trial, the other is from the ASCENT trial. They tested TDXD versus treatment physician of choice versus SG treatment physician of choice. They were all HER2 IHC 1+ or 2+, whereas the ASCENT trial also included HER2 0, IHC 0 patients. ASCENT trial had any line of treatments, whereas DESTINY-Breast04 had 1 or 2 lines of treatment. And essentially, there was significant improvement in median progression-free survival and overall survival. But the most important thing here is your overall response rates. So you can already see that your overall response rate is nearly 50% in the DESTINY-Breast04 and 35% in ASCENT trial. So I'm just going to talk about ASCENT trial in a little bit more detail because this is the landmark trial. So essentially, you had 2 arms comparing SG versus physicians of choice, and this is your usual routine sort of, capecitabine, your ribulin, your gemcitabine, or vinorelbine. And what it did was there was significant separation, there was clear separation of curve with your hazard ratio of 0.39. With median progression-free survival of 5.6 months versus 1.7 months, and your median overall survival was nearly doubled, 6.7 months versus 12.1 months. And again, I'm going to remind yourselves, just keep going back to that graph that, you have got very clear separation of curves even at 30 months. Now, this is unheard of, particularly, for breast cancer oncologists. If we see this, we get extremely excited. ASCENT-04 was first-line PD-L1 positive metastatic triple-negative breast cancers. And again, important thing to remind ourselves here is that 5% of the patients would already have had exposure to PD-L1 therapy, and 48% were actually recurrent disease. This also showed median progression-free survival of 11.2 months versus 7.8 months. There are no new safety signals when you combine immunotherapy with these antibody-drug conjugates at the moment. We are now getting very comfortable in managing immunotherapy toxicity, so hopefully that should be okay, but you have to keep in mind the toxicity of the pneumonitis, and with SG you do see every now and again this interstitial lung disease type pattern as well, and there are special management guidelines for that. It is not yet FDA approved, but we have to, watch the space for that. And then came Berlin. So very exciting. And, there was lots of talk about this first-line trials with ADC in metastatic triple-negative breast cancers. ASCENT-03 was presented, and essentially these were patients who were not candidates for PD-L1 inhibitors. They were more than 6 months since the treatment in the curative setting and had previously treated and stable CNS disease. Again, I think this was a very brave move. Not many, as you know, that patients with brain metastases are almost always excluded, from these trials. So I think this was quite a brave move. And again, I also wanted to congratulate the trialists for this crossover, this allowance of eligible patients to actually cross over to second-line SG provided through this study if they had progressed, again, is very important to applaud for, because this was a very brave move because it actually muddies the trial. This demonstrated statistically significant and clinically meaningful improvement in PFS versus chemo, with a 38% reduction in the risk of disease progression or death. And again, there is, such nice separation of curve. And just reminding ourselves back that, you were seeing that tail at 20%, and now you are seeing this tail at 50%. So, particularly when you are reading these trials, just try and go and compare with the other data. And you will see how, why we get so excited about all this. So this objective response rates we saw was very similar in both the treatment groups. However, the duration of response was substantially longer, which is what I'm just referring to. Then we had Dato-DXd, which was the TROPION-Breast02 trial. They also had no prior chemotherapy or targeted systemic therapy. These were locally recurrent, inoperable, or metastatic settings. Immunotherapy was not an option. So even though the ASCENT-03 trial allowed patients who were previously exposed to PD-L1, this is a kind of a PD-L1 naive trial. And their endpoints was dual primary overall survival and PFS, and then secondary endpoints were PFS, OR, objective response rate, and safety. This trial was also a positive trial, which showed, delta of 5.3 months, which was the median progression-free survival, and the hazard ratio was 0.57. So this was, again, statistically significant and clinically meaningful improvement with reducing the risk of progression or death by 43%. Again, very exciting to see. And again, this pretty much shows the same. I don't know why they keep such difficult names, but this was an Optitrop-Breast01 sacituzumab deruxtecan in second-line metastatic triple-negative breast cancer. Again, this is not yet FDA approved, but what I wanted to show you here is, can you see how far the curves have separated? Obviously, you do see that, they do narrow down, but here, when you look at the overall survival, there is continued, very clear separation of the curves here. And again, this was a positive trial as well. Just wanted to remind ourselves again that triple-negative breast cancer, when we say HER2 negative, it's not all HER2 negative. HER2 low subgroup type exists. It is therapeutic, but not a biological subtype, because HER2 is not actually an oncogenic driver. However, they do benefit from this new ADC payload release before internalization or membrane permeability. The incidence is quite significant in that the triple-negative breast cancer, you will have 34% of these patients to be HER2 low. And out of those, when you are looking at the hormone receptor positive, you will still find quite a significant proportion of HER2 low, ultra low. And on this side of the slide, I'm just showing that, you have got HER2 2+, 1+, and 0, where you've got no benefit from the trastuzumab therapy. But just pay attention to this side of the graph here. I'm not sure how clearly this is projecting, but this basically shows you the importance of rebiopsying. Please do always rebiopsy if you can, because here you can see your HER2 low, how it becomes a HER2 0. And similarly, your HER2 1+ becomes a HER2 low. So there is, cross. It is very histopathology dependent as well. There is not much consensus. It's always very difficult to get histopathologists to agree on, when they're grading these HER2 ultra low. And then again, that is one area of, significant ongoing research. at the moment, but these are very important considerations when you're actually seeing these patients in the clinics. So just wanted to briefly touch upon TDXD in a HER2 low metastatic breast cancer setting. And here you can see that when you are giving these patients in hormone receptor positive but resistant patients to the hormones, you can see significant separation of the curves in the progression-free survival and the overall survival. And you can see similar response in triple-negative breast cancers with objective response rates to be 52.6. See, nearly over 50% response rates in both the settings. Looking at the antibody-drug conjugates, when you combine them with immunotherapy, we have got a couple of trials, and again, this trial here has shown us the objective response rate to nearly 80%. You can see the waterfall plot, and the median progression-free survival is 13.8 months here. With the Durva, Day2DDXD plus Durva in the first-line setting, and with SG and Atezo in the first-line metastatic triple-negative breast cancer. So, you know, this combination of treatments is the way forward. So, as we stand today, post-ESMO, the whole treatment paradigm has now shifted. So where we were talking about this in the second-line therapy is now actually gone here. So you will still follow the same pattern of, you know, PD-L1 testing and BRCA testing, but, you know, I'd be more inclined now to offer SG early on, TDXD early on. And you may already be aware that even in the adjuvant setting, you know, TDXD has taken the center stage. So these are very expensive drugs, obviously. But when you see these advantages, you know, it is very important. So just to conclude, obviously, adjuvant, the antibody-drug conjugates are the new kids on the block. Please do talk to each other, particularly when managing these patients, because the toxicity is real. You may have to involve your respiratory physicians quite early on, because the management of chest toxicity takes importance here. There are novel ADCs, payloads, so, you know, the coming couple of years will keep us busy. And the ADCs are now coming in the neoadjuvant and the adjuvant setting as well. Thank you.
Thank you, Dr. Sundars, for highlighting the evolving role of ADC in triple-negative breast cancer. So after the detailed representation of multiple chemotherapeutic and targeted agents, we now finally have a radiation oncology talk with us. The topic of presentation is escalation and de-escalation in the management of breast cancer, a radiation oncologist perspective. To present this topic, I would like to invite Dr. Hina Hashmi, consultant radiation oncologist and director at Atomic Energy Medical Center. Please welcome Dr. Hina Hashmi.
Bismillahirrahmanirrahim. Thank you, Dr. Fatma. It's a pleasure for me to be here among the eminent oncologists, physicians, clinicians, and surgeons. Today, I'll be talking over a very important issue, the escalation and de-escalation in the management of breast cancer. We all know that the journey of breast cancer management has significantly transformed in the last few decades from a universal approach to a patient-centered and multidisciplinary approach. The radiation oncology plays a pivotal role in the management of breast cancer, moving towards an era of unprecedented precision. The adoption of escalation and de-escalation strategies in breast cancer radiation is crucial for personalizing treatment, balancing cancer control with minimizing side effects by using advanced imaging the use of the biological markers to tailor radiation dose and volume, thus maximizing the quality of life and excellent survival rates. Broadly speaking, de-escalation is reducing the treatment burden without compromising the outcome. And the escalation is intensifying the treatment to reduce the recurrence risk. The local regional management of breast cancer focuses on controlling the disease by coordination between surgery, systemic therapy, and radiation oncology for optimal control. So multidisciplinary coordination is the key to optimal escalation and de-escalation. Now, generally speaking, the factors which influence the escalation or de-escalation include the patient's age, tumor size, nodal status, grade, margins, receptor subtypes, and the genomic risk scores, which analyze the genes, the expression of the genes that can predict the likelihood of benefit from a systemic therapy. Radiotherapy is the cornerstone of breast cancer management, and it reduces the local regional recurrence by 2/3 and improves the survival based on the early breast cancer trialist collaborative group meta-analysis. Now we are talking about the de-escalation strategies. De-escalation, reducing the radiation fraction without compromising the outcome based on the UK famous trials, START A and START B trials, where in early breast cancer, in START A, 41 gray in 13 fractions was compared with 50 gray in 25 fractions. And in START B, where 40 gray in 15 fractions was compared with the conventional fractionation. And the outcome was equivalent local control, even less toxicity with the hyperfractionation schedule, and excellent cosmetic outcome. Similar were the results with the Canadian trial, where 42.5 gray in 16 fractions were compared with the conventional fractionation. There was non-inferior local control and excellent cosmesis. So moderate hyperfractionation has become the standard of care in the management of breast cancer in all types, in BCS and post-mastectomy, regardless of the patient age and grade. And it can be safely given in the nodal boost, in tumor bed boost, in breast reconstruction, and in large size breast, of course with the advanced radiation techniques. And the current guidelines, NCCN, ASTRO, and ESMO have all endorsed the moderate hyperfractionation. Now, as we know that the breast size is sensitive to the fraction size, the breast tissue is sensitive to the fraction size, this has paved the path of the FAST and the fast-forward trial, which are the trials in which 28.5 gray in 5 fractions was compared with the conventional fractionation, and in fast-forward where 26 gray in 5 fractions were compared with the moderate hyperfractionation. And it is 10 years follow-up and 5 years respectively follow-up was being done. And the results were comparable both in the terms of control. Local control, there were non-inferior local control and similar toxicity. So ultra-hyperfractionation can be safely given in the patients with early stage disease, T1, T2, and not to N1. And it can be given in optimally selected patients in where nodal radiation or tumor bed boost is not indicated. And the NCCN guidelines have also endorsed the use of ultra-hyperfractionation in selectively appropriately selected patients. Now we come across the partial breast radiation, de-escalating the radiation in terms of volume, reducing the volume of the breast radiated based on the import load trial, where in low-risk early-stage patients, node-negative patients, when only the tumor bed was radiated, and the results were non-inferior local control. So partial breast radiation is acceptable with better cosmetic outcome, and there was no less late toxicity, no induration, and no fibrosis. However, in the other two trials, in RAPID trial and the other trial, the results were, the cosmetically acceptable results were not there. So now we come across the axillary de-escalation. We know the management of axilla has always been a matter of debate. So based on these trials, American College of Society of Oncology Group Z0011 trial, where in early stage CT1, T2, and clinically node-negative patients, sentinel lymph node biopsy only 1 to 2 positive patients in where breast conserving surgery plus whole breast radiation was being planned, sentinel lymph node biopsy versus axillary lymph node dissection. And the need for RT was being questioned. And the outcome was that there was no difference in overall survival or local regional control. In SABP trial, where can regional nodal irradiation be omitted after nodal PCR following the neoadjuvant chemotherapy? Yes, there was local recurrence without regional, there was local recurrence without the regional nodal radiation in selected patients. So this is a form of treatment response-driven radiation de-escalation. Also in the Taylor RT trial, can regional nodal irradiation be omitted in biologically low-risk patients, early breast cancers, ER positive, HER2 negative, 1 to 3 positive, with low genomic risk, oncotype DX is less than 21. It is an ongoing and maturing results are to be published. So this will reflect a biology-driven radiation de-escalation. Now we come across when there is omission of radiation based on the CALGB and the PRIME2 trial, where in the patients age greater than 70, T1 and not M0 patients, ER positive, lumpectomy with clear margins, there was, without RT, it was no difference in overall survival. However, there was slightly higher recurrences without radiation. Now we come across that adoption of the escalation strategies. Now why we escalate? In the case of high-risk pathological features, young age, aggressive subtypes, and residual disease after neoadjuvant therapy. Now escalation by addition of the tumor bed boost based on the aortic trial, comparing whole breast radiation alone versus comparing whole breast radiation alone versus addition of the boost. And the findings were that the boost significantly reduced the local relapse. 20-year data benefited in younger patients with high grade, and the age is less than 40. So another form of radiation escalation in the case of regional nodal irradiation in the aortic trial and NCIC MA20 trial, where addition of radiation to the internal memory and supraclavicular fossa nodes resulted in decrease in the regional recurrence and improves the disease-free survival in node-positive patients. Now we come across the post-mastectomy radiation based on the EBCTCG radiation meta-analysis, where the post-mastectomy radiation reduces the local regional recurrence, reduces the breast cancer mortality. So post-mastectomy radiation is recommended when there is risk of high local regional recurrence that is greater than 4 positive axillary nodes, tumor is T3 or T4 tumor, and positive closed margins. And in the form of escalation, re-radiation of the isolated breast cancer recurrence, in the case to improve the local control, of course, given by carefully dose-constrained advanced planning is critical. Now to summarize, the benefits of de-escalation are improved patient convenience and psychosocial well-being. It is cost-effective, low infrastructure burden on the radiation department. It reduced the long patient list and practically impactful in low-middle income country without compromising the patient outcome in appropriately selected patients. The benefits of escalation is to improve the local regional control and disease-free survival in high-risk patients, supported by advanced imaging and modern RT techniques. The field of radiation oncology continues to evolve, driven by ongoing research and technological advancements. By refining the omission criteria, the ongoing trials are dedicated to meticulously refining the criteria for safely omitting the radiation. And by advanced patient stratification, the breakthroughs in imaging and biomarker identification promise to better stratify the patients for escalation or de-escalation strategies, and also by the adoption of the novel modalities, which holds a significant potential to further reduce the treatment-related toxicity and improves the outcome. So the take-home message is that the breast radiotherapy should be risk-adapted and patient-centered. Personalization is the key. Multidisciplinary review should be done, and careful dose-trained analysis should be done, and informed patient consent should be taken. So I conclude by saying that by the adoption of being a radiation oncologist, we are committed to avoid over-treatment or under-treatment of the breast cancer patients without ever compromising the oncologic safety and ensuring the best long-term outcome in our patients. I thank you very much for your kind attention.
Thank you, Dr. Hina, for the insightful contribution. So before we proceed to the debate, and I would like to invite Dr. Sameer to lead the moderation, one of the panelists who is here with us is Dr. Zahid, and he's a clinical oncologist from Quetta. His clinical expertise and dedication in breast cancer, he has built a strong reputation through his professional practice and patient-centered approach. Please welcome Dr. Zahid Mahmood.
My name is Dr. Sameer Hussain. I'm a radiation oncologist from CMH Lahore. The debate today is regarding the Supremo trial. Does intermediate risk breast cancer patients still need this post-mastectomy radiotherapy? How many of you are familiar or you have gone through the Supremo trial paper? So quite few of our colleagues have gone through the paper. Whether we should apply this paper in our clinical settings or not is the question, and what is the debate? Why, if it is published, why not just go ahead and apply it into our clinical practice? So that's the debate. I'm just going to give you 3 slides about what the trial was. The trial targeted intermediate risk breast cancer patients who have 1 to 3 lymph nodes, T3 and not patients, T2 and not, or T2 and 1 patients. Exclusion criteria was clear. Exclusion criteria. Okay. Have I done something wrong? Okay. Yeah, I had done something wrong. So the surgical mandate was that all participants underwent simple mastectomy with specific auxiliary staging. Level 2 auxiliary clearance was mandated with minimum of 8 to 10 lymph nodes, and 85% patients received chemotherapy. The intervention arm was the radiotherapy arm. All these patients, either they received radiotherapy or they did not receive radiotherapy. I'm just going to show you this slide. The overall survival, no difference. 81.4% versus 81.9%. With that, I would invite Dr. Asma Salim, who is from DOE Center Karachi, and she is going to tell us what this trial is all about, and then we are going to have a debate on it. Thank you.
Assalamu alaikum, everyone. Next slide, next presentation start.
Debates.
This one. No, this is. Assalamu alaikum, everyone. I'm Dr. Asma Salim, working at Dow University Hospital Health Sciences. Thank you, PSCO, for giving me this opportunity. Today, I am debating in favor of selective use of post-operative radiotherapy after mastectomy, Supremo. This trial is published in New England Journal of Medicine with an impact factor of 78.5. What is this trial? So it's a phase 3 randomized clinical trial in which 125 sites from United Kingdom, 25 sites from continental Europe, and 1 site from Israel and Turkey participated. This is a very well-balanced study in both comparative arms, as you can see from these 2 slides. So, the objective of the study is very well addressed. Methodology and the results are very relevant, and a good median follow-up of somewhere around 9.6 years. Subgroup analysis was pre-planned in this study, which maintained the statistical integrity of the study. Wider biology of the patients also covered in this one. The primary endpoint was overall survival, which was pointed by Dr. Samid as well. So after a 10-year follow-up, there was no significant overall survival between the 2 groups, 81% with chest wall irradiation and 81.9% no chest wall irradiation. One of the secondary endpoint was chest wall recurrences. The NNT, the number need to treat, was approximately 72. Absolute difference in chest wall recurrence is biologically implausible to translate into meaningful survival benefit. As you can see from the Kaplan-Meier graph, the graphs are not separating. Locoregional recurrence was also not significant. Metastasis-free survival at 10 years was estimated to be 78% in the chest wall irradiation and 79% in the no radiation group. Disease-free survival was also the same. The 10-year survival was 76% and 75% respectively, with a good hazard ratio as well. Does nodal status affect the outcome? The answer is still no. No differential effect of radiation on overall survival according to the nodal status. So there was analysis of submolecular group as well. So they observed no differential effect of radiation on overall survival among patients. Patient with triple-negative breast cancer has increased hazards of chest wall recurrences relative to ER/PR positive and HER2-negative cancer, but this was not reduced by chest wall irradiation. So someone can say it's been 2 decades since this research has started. So even though 2 decades have passed, but in Pakistan, according access to modern technology like DIBH, VMAT is limited and still expensive. This leads to more radiation-induced side effects, and hence the relevance of this study over here. Among many objections, one is all lymph node positive in Supremos were underwent complete axillary lymph node dissection, not sentinel lymph node biopsy. So there's a trial, NSABP B51, in which there is 2 groups actually, one with radiation, one without radiation. So the group 1B, they have mastectomy patients and they did not receive any chest wall irradiation or regional nodal irradiation. So median follow-up in this study was 59 months, and estimated 5-year invasive breast cancer recurrence-free survival was 92% who received radiation and 91.8% who did not. Regarding the financial toxicity, Post-mastectomy radiotherapy economical implications are basically mostly on patients and their families, healthcare providers, especially those working in public sectors, and government as well. So continuing to recommend chest wall irradiation in contexts in which the evidence is marginal and the procedure is detrimental may divert limited resources from effective treatment. So we should allocate radiation resources to pay other patients where the treatment will be more effective. So Supremo leads to cosmesis benefit in patients with breast reconstruction and implant. So those who need breast reconstruction and implant can be, and the surgeon will be mind-free that they will not be getting any bad cosmesis or the side effects of radiation, because Supremo leads to no radiation. So in CAP, it's a high-quality study, which we can say because all the statistical analysis was done on par, and the study was, the whole study was divided, and the comparative arms were of good quality. So improvement in chemotherapy regimens. The hypothesis that survival benefit from local therapy increases more effective systemic therapy, but only to a threshold, beyond which the benefit declines. This study suggests that contemporary systemic therapy has breached this threshold, and therefore we are observing a decline from chest wall irradiation in this group. Since the recruitment of this trial, advancement in systemic therapy has increased the survival even more, which strengthens the rationale that omitting chest wall radiation for patients with intermediate risk group is good. I cannot emphasize more on the financial toxicity, especially in our region, the optimal utilization of the limited resources, because we need more linear accelerator to treat patients, and we have a lot of waiting as well, and benefit of cosmesis, those who need transplant or who wants transplant in this region. So I conclude my presentation over here. Thank you so much.
Thanks a lot, Dr. Asma Salim. Now we are going to invite Dr. Maria Mijaz, and we want to know why is she creating so much fuss. The debate is settled. It's New England Journal of Medicine, 78.5 impact factor. What's wrong with you? We want to know. Dr. Maria Mijaz.
Assalamu alaikum. I am Dr. Maria Mijaz, resident radiation oncology at CMH Lahore. Today I'll be presenting a clinical critique against the famous yet controversial Supremo trial and why it does not mandate a change in the current standard of care. Starting with the mismatch between the surgical protocols followed in the Supremo trial versus the current protocols, how the investigators lumped the low-risk and high-risk patients together, thus diluting the evidence, paradoxical results in triple-negative breast cancer, low statistical power of the trial, difference in regional nodal irradiation protocols followed in the trial versus the current standards, chemosaturation in most of the trial patients, premature timeout at 10 years for a 20-year disease, the trauma a patient undergoes with local chest wall recurrence, and how survival is more important than symmetry, and the delusion that radiation omission can lead to reduced financial toxicity where the truth might be otherwise. Starting with the news headline that stormed our news feeds in November 2025, radiotherapy after mastectomy can be avoided, study finds. A wonderful news for the patients who were already fearing radiation toxicity, and a huge topic of debate in the oncology community. My point is, we should always look beyond the headline and read beyond the abstract, as a negative result might be quite dangerous when it ignores many of the crucial defects of the trial hidden within the trial. Starting with the difference in surgical protocols. All of the Supremo trial patients with N1 disease had level 2 axillary lymph node dissection. The surgeon had already removed the nodal radiation targets. But what is the current approach? Sentinel lymph node biopsy. In that case, axilla is left undissected and potentially diseased. So who addresses this axilla? The radiation oncologist. Radiation might be the only shield left for this undissected basin. We know that after sentinel lymph node biopsy, there is residual risk of non-sentinel lymph node mets in the undissected axilla. In the MROS trial on axillary lymph node dissection, 25% of the patients were seen to have 1 to 3 non-sentinel positive lymph nodes. In the Z0011 trial, 27.3% patients were there. And in the CENOMAC trial, 34.5% patients had non-sentinel positive lymph nodes on axillary lymph node dissection. And if there were 2 positive lymph nodes, 51.3% non-sentinel lymph nodes were there. These were the trials that established non-inferiority of ALND versus SLNB. How? The MROS and CENOMAC trial mandated adjuvant radiation, and this is how the non-inferiority of SLNB versus ALND was established. Then the fact that the evidence was diluted. Here's the snapshot from the trial itself, and you can see that 25% of the trial patients were node negative. T2N0 group was also included, although with LVSI and grade 3, but we do not usually irradiate those patients. T3N0 also lies in the gray zone. Moreover, 64% of the patients were hormone receptor positive and HER2 negative, and more than 80% of the patients were hormone receptor positive alone, as compared to the aggressive subtypes which were low in number. So the evidence was diluted. Then the paradoxical results of triple negative breast cancer. A 1.91 hazard ratio for death, worse survival with radiation. Does that mean that radiation is causing more mortalities in patients with aggressive histologies? Should we start omitting radiation specifically in aggressive histologies just because of this result? Or should we consider this as a small number noise and a finding based on extreme statistical chance, as it is contradicting every major meta-analysis showing the highest benefit of radiation in high-risk biologies? And if we do not consider the triple negative findings, why are we going to trust this trial for N1 disease? Then the difference in the regional nodal irradiation protocols followed in the trial versus the current standards. Supremo only mandated chest wall radiation in the test group versus the control group. Regional nodal irradiation was not mandated, so some of the patients from either group had that radiation. It was optional. Lateral axilla was explicitly avoided, and this is why the regional nodal irradiation protocols were vastly different from the ones followed today. Then 85% of the patients underwent chemotherapy. Chemotherapy potentially hid the beneficial effects of radiation. When we know that today we can use the Oncotype DX test according to the responder trial, even in N1 disease, to skip chemotherapy. And if we skip chemotherapy, then radiation is the only shield. Then some facts about the power of the trial. Originally, 609 deaths were needed for 80% power for a 0.05 alpha. What was the number of events? Less than 300. And due to that, the power reduced to 50%. A 50% chance of a true positive effect when it actually exists versus a 50% chance of a false negative result, the chance of a coin flip. Moreover, it was a superiority trial. Insignificant difference in superiority trials does not imply non-inferiority. Absence of evidence is not the evidence of absence. Then the trial ended at 10 years, where major meta-analysis such as EBCTCG and Danish trials prove that breast cancer is a 20-year disease. The curves continue to separate even after 10 years. So it's like stopping the movie at halftime. Why stop the trial at 10 years when the benefits of radiations are yet to mature? Then the proponents who talk about empathy. Is recurrence empathy? 0.45 hazard ratio for recurrence without radiation, a 2.3 times higher risk. Is the trauma of local failure ignorable? And we know that in the current era where we can employ modern techniques such as DIBH and IMRT, the toxicity of radiation even in this trial was less than 2%. More cardiac deaths without radiation than with radiation. So what is the harm of radiation? It's negligible. As compared to that, if we want to apply the Supremo trial, we need to cover the morbidity of axillary lymph node dissection. And what is the morbidity of chemosaturation, of adriamycin, cyclophosphamide, the taxanes? As compared to that, what is the morbidity with radiation? Plastic surgeons fear less than ideal aesthetics with radiation, but symmetry is salvageable, recurrence-free survival is not, life is not. Recurrence in a reconstructed flap is a surgical and oncological nightmare. And the proponents who say that radiation omission might lead to reduced economic toxicity, then radiation is a one-time fixed cost. But what is the cost of recurrence? It might amount to infinity depending on the patient's remaining lifespan. Radiation is the ultimate economic shield for that. So for now, we should wait for the Taylor-RT trial, which employs the Oncotype DX, modern sentinel lymph node biopsy, and a comprehensive regional nodal irradiation focus, a trial that truly reflects the current protocols. Till then, we should follow the ASTRO guidelines, which say that Supremo changes nothing, the NCCN guidelines, which did not change after the trial, and we should not compromise 20 years of gain for a 10-year headline. We should hold the line for now, as radiation is the only shield left in this genomic sentinel lymph node biopsy era. Thank you.
Well done. Now you all know something about this Supremo trial. How many of the radiation oncologists here want to implement that in their practice? I just want to emphasize, I went back and looked into my practice. From 1st November to 31st December, in 2 months' time, the hospital generated a revenue of 3.2 million rupees. So keep that in mind. So how many of you want to radiate or omit radiation? How many of you want to implement this trial, the Supremo trial, in your practice? मैं हूँ. How many reject the motion? Okay, so Dr. Mariam wins here, rejecting the Supremo trial for the time being. With this, I thank you all. Thank you, panelists, for being here. Thank you.
Thank you, everyone. This concludes the session number 12. We'll now proceed to next session. Thank you.
Please, Assalamu alaikum. I would be grateful if you kindly take your seats. We are just going to start our immunotherapy symposium soon, so please be seated. Thank you for your attention. We are going to call the panelists, and we need your attention. Please take your seats so we can proceed on time. I would like to call the chairperson, Dr. Ehsanur Rahman, who is a consultant medical oncologist at Northampton Hospital, United Kingdom. Please come and have a seat, sir. I would also like to call the panelist, Dr. Salman Arif, Lieutenant Colonel, consultant clinical oncologist working at CMS Lahore. Thank you, Dr. Salman. Dr. Asma Rashid, consultant clinical oncologist working at Shaukat Khanum Cancer Hospital, Lahore. Please come and have a seat. Thank you. Dr. Talab Maqsood, consultant clinical oncologist working at Combined Military Hospital, Rawalpindi. Thank you. Dr. Khaliqur Rahman, working as a consultant clinical oncologist at University Hospital, Hull. And I would like to invite Dr. Mariam Noman. Dr. Mariam Noman, please come and join us as a panelist. Thank you. Right. So we all know that immunotherapy is the evolving paradigm of a treatment pathway in cancer. Immunotherapy was first introduced for specific tumors, but now its role has been expanding in different tumor sites, and there are some astonishing results. We are trying to focus on to the generic skills needed to develop for immunotherapy and how to handle it. So here I would like to invite the first speaker of this session, Dr. Asghar H. Asghar, who is a director at Kiran, and he has got a lot of other attributes, which includes that he is a very enthusiastic researcher, enthusiastic educationalist. He is the co-chair of this meeting and also holding a portfolio of financial secretary of the Pakistan Society of Clinical Oncology. So I would like to invite him for his talk. Dr. Asghar H. Asghar. Don't worry, take your time.
I have one session to talk over there. Sorry. So I was basically sitting in that session, and that session is quite late. So I thought you must have been late also over here. So in that session, I was talking something advances in the immunotherapy, and here I'm going to start with something basics of the immunotherapy. And what is this immunotherapy? And how it works, and what is the famous clinical trial on the basis of this immunotherapy has been incorporated in our clinical setting also. I'm just going to share all these things over here. This is my favorite topic, and you know that in head and neck tumor, we have started with something which was a palliative regime with the combination of triple metronomic therapy, and we have seen very magic response. I'm going to keep on sharing this thing in our WhatsApp group of Center Tumor Board, and you can see that a very good response, which was a palliative regime but working as just like a neoadjuvant. So what is this immunotherapy and how it works? It basically nothing. It's basically the own body system, immune system, which you have to activate by different ways so that they can start this year working as a good T cell. This is considered to be the fourth pillar of the cancer treatment. First pillar was the surgery. Second pillar is this your adjuvant chemotherapy. And fourth is the radiation therapy. And now this is the third one, the radiation. This is the fourth one is this your immunotherapy. Soon you're seeing that most of the setting immuno and chemo is being combined. And in the two tumor, I can very easily recall that in the cases of 522 trial, keynote trial, in the triple negative breast cancer, they have totally changed with this. They have started with this paclitaxel with the pembro, and then started with the, or this has been recommended now, it's in the guideline also. Same way in the head and neck cancer, which is not a resectable tumor, you can start with the pembro alone, get it resectable, and take it out without giving any chemotherapy. So things are being changed now very frequently. So this fourth pillar, how it works in a different way. It's basically going to activate your T cell, which were not so active because of their binding with the PD-L1 and PD-1. If there is a binding of the PD-1 and PD-L1, there can be the two-way. There will be the inhibitory signal which is started. So I'll show you what is this inhibitory signal and how it works. I'll just let you know. We just see the 5-year survival initially was just in the melanoma in the case of this was 16%. This is your 12% with the RCC, but not this thing with the immunotherapy, this survival is going high, quite high. Initially, with this TKI in the melanoma, like the BRAF mutation, you can have a better survival. But with the immunotherapy, if you see here in the TKI and something, the curve is going to separate from the base, from the very initial time. But in the immunotherapy, you have to wait. It's not going to have the magic response that you're going to start the immunotherapy from today or your patient will get a response, but rather there can be some flare of the response. There can be somewhat progression of the disease because of some flare phenomena. So you can see response after 2 to 3 months, you can say. But in the case of head and neck tumor, because head and neck tumor is something more radiation chemosensitive tumor, squamous cell carcinoma, and they respond very well. They even respond within the week also. But you have to combine with this nivolumab in the case of head and neck tumor with this oral form of methotrexate, with oral form of the celecoxib, and the oral form of gefitinib. So it's a combination of this. This was a trial which was presented in PSCO from the Tata Memorial in India, and because there were a lot of patients have head and neck cancer over the same way as in Pakistan. So they presented as a palliative. We started as a palliative also, but we have seen a very good response as a response in the case of this one, that the patient was resected and there was a pathologically complete response. In the case, I can recall one patient was the case of the tongue cancer who was palliative, who surgery was refused. We started with the TMC protocol and that patient responded very well, then underwent surgery and then it was a pathologically complete response. We're going to share this data very soon. We're going to publish this data also. If you see the cancer journey started with the surgery, then chemo came, in 1901 radiation came, but now things are coming with the TKI and the immunotherapy. In immune system, we have the two different types of system, one the myeloid series and one of the lymphoid series. In the lymphoid series, we have the T cell and we have the B cell. B cell gives the plasma cell antibody, but this is the actual gameplay, which is going to change this immunotherapy whole paradigm. It's basically the T cell, and then the T cell we have CD4 and CD8. We have the natural immunity, which comprise of dendritic cell, macrophages, but we have the adaptive immunity with the B cell and the T cell. Adaptive activated when there is some stimulus to this your body. Natural immunity is innate immunity, it's always there. And there is some combination of this immunity that is shared over here. Innate and adaptive, both are the first line of defense. But this is a slow response, this is an immediate response. This is the antigen non-specific, this is antigen-specific tumor. It's not taken into the memory, but these are taken into the memory. So here it's comprised of the natural killer cell and the neutrophil. These are comprised of the T cell and the B cell. And CD4 and CD8 are going to play the basic role. If you just see, CD8 has itself own capability to take up this this your cytotoxic T cell, like this one. If you just see over here, this is the antigen, and this is the T cell. On this T cell, this is the CD8 expression. When the T cell antigen bind with the T cell, So it activates this T cell, and there is a cytotoxic factor of this T cell. It can kill this tumor itself. But in the case of the CD4, it needs the help of APC, antigen-presenting cell. These APCs activate this your T cell, the release of certain cytokine, and these cytokine are going to take up this your tumor in the different way. So T cell has the capability to take up tumor itself, but the CD4, this your CD8 has the capability to take up itself, but CD4 help the needs of APC. So this, if you see, this is a circle, this is a scheme. This is a whole tumor over here. This is a part of this macrophage. This is a magnified. Say this is the antigen. Antigen is taken up by the APCs. APCs take them to the lymph node. Lymph nodes are taken, releases different T cells, and these T cells are taken into the tumor site, and this tumor cell is going to take up the tumor issue. So this is the way, and you see there are multiple papers are now coming. The tumor which are having more infiltration of the CTL, cytotoxic T cell, they are more immune responsive tumor as compared to the having less T cell, circulating T cell. So this T cell, how much is the T cell active in the body? After this antigen presentation, you can have the better immune response. And this is a very important slide. If you understand this one, then I think you can very easily understand this, your immunotherapy system. Let's say this is the T cell, and T cell have different expression on their. We want the T cell should be activated whenever there is some antigen attacks on this body. If T cell has been activated, so it's a very good thing. And for the activation, antigen should combine with the CD28, OX40, or any of them. If your antigen is going to combine with any of this T cell receptor, automatically there will be the immune response generated. But if any antigen is going to combine or attach with this one, then there is an inhibitory signal will be released, and this inhibitory signal make the T cell to make them inactive. They are not going to respond to this your antigen. So this is the reason that your immune response will not be generated. And this is the way, this is a PD1. PD1 is on the T cell, and if your antigen is having a PDL1 expression, it's going to combine with this one. So T cell will not be acting in this way as you want. If you can block this pathway in any way, then you can have a very good immune response. Now we are going to have the drug. We have the very common drug with the CTLA4 in the case of this your melanoma. Ipilimumab, and this is the PDL1, there are multiple drug with over there. Now we are getting this TIM-3-1 drug also. There is a anti-LAG3 drug with the name of Opdualag. These drugs are now coming in the market. Again, if you just try to understand in a more simpler way, when there is antigen and the T cell activation, like ignition, there can be two-way response. If your B7 antigen receptor is going to attach this one, CD28, there will be the acceleration of this T cell, they're going to have a good immunity. But if your B7 is going to attach with this one, CTLA4, there will be inhibition. Inhibition, if you can stop this combination, then you can have a very good response with this. And you can see in the case of the melanoma. These are different cytokines which are going to have the T regulatory cell, T helper cell. So whenever there is activation of any receptor, there can be the different cytokines released. You can have this one. Okay. Further, if you just elaborate, if your body immune system is good, it can eliminate this tumor. If body system is weak, it can keep them in equilibrium phase. I mean, it's not going to activate further, but in the dormant phase. But if your body system quite weak, there can be the progression of this your tumor. So it all depends on how much T cell are activated in your body, and then you can have a better response. This is a history of this your immune therapy system. These are the different types, and if you just go through this one. Immunotherapy can be in the form of vaccine, can be in the form of oncolytic virus, can be in the form of adaptive T-cell therapy, as in the case of the adaptive radiation therapy. We have adaptive T-cell therapy also. We can have immune checkpoint inhibitor, we can have the monoclonal antibody, and we can have the different immune system modulators. These are all different types of immunotherapy. And the one basic immunotherapy which we are going to use from the very long time, which is the first immunotherapy, that is your intravesical BCG therapy. That is also immunotherapy, and you're going to give something inside the bladder. It's going to generate the immune response, which is going to kill this tumor. So immunotherapy in the form of BCG is a basic one, but now in the quite advanced stage, we have the different drug. Okay, if you just see, this is the same thing. When there is the combination of the CTLA-4 and CD8, if you can block this one, then you can have a response, better response, anti-CTLA-4, ipilimumab, and they in the form of PD-L1, we are different. For PD-1 blockers, we have the nivolumab with pembrolizumab or ipilimumab for CTLA-4 or the tremelimumab with the name of Imjudo. This is also coming on the market. This is for the PD-L1, atezolizumab, this durvalumab, and this your avelumab. All these drugs are unfortunately not available in Pakistan, and I have just talked on the durva in the session over there in the case of this lung cancer. So these things are now coming in the guideline also. This is recommended also that after this year lung cancer chemoradiation therapy, when there is a good response, when it's not a resectable disease, you started with the chemoradiation therapy in the case of lung cancer, you can start with the maintenance therapy of the durva, irrespective of the PD-L1 status. Yes, if PD-L1 expression is higher, you can have a better response. But if PD-L1 test has not been done, or if it is less more than 1%, you can have a better response also. Okay, just 1 minute left. If you just see this response, ipilimumab was given in the case of melanoma, and just after this 16 weeks, this response, and after 96 weeks, almost this response has been gone. So you can have a better see. I can finish it over here, but I have the multiple trials also. This is my center. If you can see this one, this is my Kiran Hospital. So thank you very much. I can have any questions.
Wonderful, Dr. Sir. The best thing is not the presentation only, but the timekeeping is fantastic. So we do need this kind of a spirit. Thank you. So next would be my talk. And again, I can skip some slides if I will be overstretching. Thank you. So somebody has already started my timer like a taxi timer. It's already, I'm 24 seconds consumed. So, is it? Okay, that's fine then. Right, so let's go to the, thank you very much. Well, being a moderator, I think majority of us, you know me, I'm Dr. Waqas Ali. I'm one of the consultants working at Lincolnshire Hospital, NHS Trust in UK. And being a clinical oncologist, I've been involved in immunotherapy by treating breast cancer, renal cancers, prostate. So I decided to focus on immunotherapy response and its duration because that's something which we are not very familiar with, or sometimes we get easily deceived when we come across. These are my disclosures, and the area where I try to focus today is these terms. If you look at these terms, it says typical time to response, TTRs. When you read these papers, you read these kind of terms. Objective response rates, I think we all are quite familiar with this term. Durability of response and duration of response. Do you think for all these four statements we are talking about, are they the same thing or they are different? I don't think so. They are quite same, especially when it comes to the immunotherapy drugs and their responses. So therefore, I have chosen this topic to see how can we better define and understand that what these terms are. So typical time to response, a measure that how quickly those responses occur. That's the lead time. And then objective response rates. Proportion of patients responding to a treatment. That's what we measure exactly, that how many patients are responding. Durability of response. refer to quality of that response. That means length and the depth. And duration of response, that again is a very common term used in paper these days. That means how long effects last, the time from response till progression or death. So that's that's the crux of this presentation, to understand these definitions when you are looking at the responses and when you're reading the literature to better understand what responses are. So lead time. Many clinical trials report that initial measurable responses occur around 6 to 12 weeks, about 1.5 to 3 months after starting the therapy. I'm talking about immunotherapy here. Approximately half of the responding patients show tumor shrinkage within 6 to 8 weeks, but other half may take several months, up to 6 months sometimes. Some combination regimens, when you combine these drugs with either another immunotherapy drug or with chemotherapy, it shows median time to response around 2 to 2.8 months, like 12 weeks in specific cancers like renal cell carcinoma. So response efficacy of PD-1 and PD-L1 inhibitors in clinical trials, there is a systemic review and a meta-analysis on that published, and that I found these numbers a bit interesting, that there were almost 16,000 patients were analyzed from 91 trials, and median time to response was noted around 2 months. Median objective response rates were around 20%, and median duration of response was 10 months. First-line systemic anti-cancer therapy, the objective response rates were higher, like around 36% versus 13%, but shorter duration of response. So basically, the objective responses were higher, but the duration of responses were not higher with subsequent second-line or third-line setting. So immunotherapy, when combined with chemotherapy, the objective response rates went quite high, 46% versus IO alone, which is 17%, or 12% with IO-IO combination. But surprisingly, the duration of responses with IO were better than IO with chemotherapy. So that's the beauty of assessing the IO response, that you should not stuck with the old-fashioned response criteria. So this literature also compared the responses between PD-1 and PD-L1, and they found no much difference, to be fair, between both the drugs. It depends in what particular cancer setting you're using both the drugs. Now, the traditional RECIST criteria does not help. So we have to focus on that part of the graph where it says that there should be a proper or immunotherapy-dedicated RECIST criteria. When you're sitting in your tumor board, MDTs, they talk about the typical traditional RECIST criteria. Here, do not define progression, not included in the sum of measurements. So here they're talking about sum of measurements, not only targeted lesions. So there are different IM RECIST, I RECIST. So there are different modified criteria to analyze the response. So new lesions, again, very important. I highlighted appearance of new lesion does not mean progression. So be very careful in interpreting the response of immunotherapy, please. And get a bit of an educational sessions with your radiologist so to better understand the response criteria and to develop a pathway. Pseudoprogression. I think this term is quite familiar to all of us who are dealing with immunotherapy. Why does it happen? You can see from this graph what happens, that these brown marks, these are tumors, and these blue marks, these are immune cells. And you can see that in the first phase, the duration during which we see the phenomena of pseudoprogression, basically the whole volume of the disease showing increase. Why? Because of the inflammatory cells. In total, the tumor cells are less and dying, but immune cells are increasing in number. And due to the inclusion of more immune cells there, that inflammatory response, we do see the phenomena of pseudoprogression. So be very careful when you're interpreting the first post-treatment scan, whether you do it at 12 weeks, whether you do it in 4 months, or you are doing it 2 months. So basically, whether you're using PD-L1, PD-1, you do get this phenomena in the beginning. So, duration of response in Checkmate 067, where they used Ipi-Nivo, the median duration of response has not yet been reached. And median duration of Nivo was 103 months. And median duration of response with Ipi was obviously poor, and that's not the standard of care to use it in melanomas, you know. In renal cancer, the famous Checkmate 214, again, the Ipi-Nivo combination has made a marvelous improvement as compared to the traditional TKI. I think Ehsan has already shown those things, but I'm just focusing on that median duration of response is 76.2 months. And similarly, another landmark trial of the lung cancer, I don't treat lung cancers, but you all know about this, that there is 29.7 months versus 4.4 months median duration of response for non-small cell lung cancer, where PD-L1 was high and Pembro was used in the first-line setting. So all these trials, they are giving us individual assurance that the duration of response with immunotherapy is something where we need to focus on, and that gives us a reliable picture. So rate of discontinuation of immunotherapy. In landmark trials, discontinuation rate due to immunotherapy-related adverse events, either you're using monotherapy is around 10 to 15%, and if you're combining it with, if you're combining PD-L1 with CTLA, anti-CTLA, that's high, 35 to 45%. Rate of discontinuation of immunotherapy, again, you can see this Checkmate 14 data, almost you can see 42% when they were given exposed to the combined one. There is a 42% rate of discontinuation. In Keynote 522, which is a landmark trial in triple-negative breast cancer, almost 21%. So meta-analysis data, the risk of discontinuation is significantly higher when combining chemotherapy with immunotherapy as compared to immunotherapy alone. And the reasons are obvious. So rate of discontinuation, what were the reasons? What do you think? Is this the correct order? Is this the most likely chronological order to be the cause of discontinuation? Do you think skin toxicity is the most common cause of discontinuation? Gastroenterology, GI disorders? Well, the top 3 reasons. Okay, interesting, very interesting. So the next slide will correct this order. The top reason of discontinuation is GI, then endocrine, and then hepatotoxicity. I just want to highlight it here that predominantly colitis was more seen when the CTLA, anti-CTLA like ipilimumab was included, and more pneumonitis and hepatitis were seen with Nivo, Pembro in the practice. And one very important thing, the cardiotoxicity is rare, but if it happens, the mortality is quite high with cardiotoxicity. I think Hira will focus more on that. So ongoing response beyond discontinuation, very important. This is a very rare aspect of the treatment management pathway, that what happens if we discontinue these treatments, the patients are extremely anxious that if we are discontinuing them due to the repeated grade 2 or severe grade 3 and grade 4 toxicity, the guidelines tell us you treat them, but do not be so brave to go back on the treatment again. But some of the patients, they feel quite nervous, and they said without systemic anti-cancer therapy, where would they go? Whether their disease will progress or not. So there is a reasonable data growing in the background now telling us that it's not always a bad news. If we are discontinuing your drug, there still could be a sustained durable response. And you can see that this watershed chart that is showing that all these browns, these are the ones, the duration of response after discontinuation of the treatment. So there is a significant number. ongoing response beyond discontinuation of IO. No big randomized trials of any large real-world data available to estimate precise number of patients discontinued their immunotherapy due to toxicity. Discontinuation due to toxicity versus elective break, that's another thing. Can we do elective break? In United Kingdom, as not easy because we are resource-conscious healthcare setup, and when we give elective break, we need to justify why we have done it, why we are going back, and we need to make sure that there is no disease progression. There's a blue tech criteria on which we all work around, and we have to fill up a treatment break form with all the justifications and evidence. So newer trials in which duration of immunotherapy treatment capped at 2 years. Now all new trials, they have capped the immunotherapy treatment at 2 years. Would give us a clue of the durability of response beyond discontinuation. So that the follow-up of those trials will be more helpful to better understand what happens. Should we stop? Stopping at 2 years is a good idea, or a bit early is fine. Is re-challenge an option at the time of progression of elective break if stopped? Well, we don't know. Initial depth of response versus, which means CR, partial response, stability, duration of response, exposure more than 1 year or stopping less than 6 months. These are the factors which they do influence the overall outcome. Reasons for discontinuation, elective versus toxicities. Obviously, toxicities, if it's a very early break or discontinuation, that's bad factors. So influencing length of response depend on all these factors, that if there is less than CR, PR, obviously stable disease is less likely to be durable than the CR and PRs. And patients who discontinued beyond 1 year, their chances to be in radiological remission would be higher. So, yeah. Clinical consideration. Management of immunotherapy-related adverse event. Does use of long-term steroids have a negative impact on the durability of response? Some of the patients, they ask us that if we are going on a long-term steroids after discontinuation due to toxicity handling, would we have a worse outcome? Re-challenge on further disease progression, predictive markers, so these are all the questions. So no, there is no negative impact due to the steroid use. Re-challenge, yes or no, depending which environment, which healthcare do you work, what are your resources, and what are you allowed for. Predictive, yes, high PD-L1s, they are better. Detectable circulating DNAs, if they're still there, obviously there is a worse, it's not a better chance to get a response out of this. We have done a pilot study in our center, but I think we are running out of time. So in the best interest of time, we have got a very interesting case at the end. I can present that, so I'll finish my talk here. That's the take-home message. So just give me a second to... So the next speaker is one of our renowned medical oncologists, Dr. Khurram Khan, who is working at University College London Hospital. He's also Sitara Imtiaz, and he's been a leading oncologist there in London. And we welcome Khurram to enlighten us with his talk. Thank you.
Assalamu alaikum. Thank you very much, Vikas, for the very kind introduction. And you've actually taken almost a bigger reward by stopping your presentation at the good time. So I'm very aware of that. So I have a few slides, but I will definitely keep to the time today. So apologies for yesterday. Now, these are my disclosures. I noted my friend Vikas actually went through them very quickly. I want you to have a look. These are the disclosures. And it's also a disclaimer that this talk is sponsored by Roche, so you will see some of those contents. Now, we are shifting the focus a little bit. This is a more generalized session on immunotherapy. And I was thinking in my head, what topics should we actually discuss to make it more interesting for the whole audience? Because this talk is more focused on hepatocellular carcinoma. So I will go through the slides, but in parallel, In last few days, I've been speaking to colleagues from Pakistan, and there are many challenges that obviously you face on a day-to-day basis, which perhaps we don't face. For example, the cost associated with immunotherapy, the side effects associated with immunotherapy. Waqas has extremely well talked about some of those discontinuation rates, how to manage those toxicities, all are critically important. A very brief reminder of the BCLC guidelines on the treatment algorithm of hepatocellular carcinoma. I'm sure those of you who treat HCC are aware of those guidelines. What I want you to focus on is this area of interest where patients are not candidates for resection/curative treatment options/transplantation. So we are talking about the group of patients who are either in that worst category group where there are no treatment options, or those who are good performance status patients, but they have potential immunotherapy or other targeted treatment options. So let's focus on how the treatment algorithm has changed. So like with many other cancers, over the last decade or so, we've seen plethora of examples where immunotherapy has become part and parcel of the treatment paradigms. Why has that happened? It's very complex. We were always aware that immune failure is one of the hallmarks of cancer. And of course, there was a lot of research going on to identify those signals which could help treating the patients in real life. And that only started happening in the last decade or so. So as a result of that, a lot of good things happened, but some negative things happened as well. So a lot of trials started incorporating immunotherapy without solid evidence or preclinical models to suggest that they would definitely have a role. So let's come back to HCC here. And we see that since 2019, 2020, just around the COVID time, these data from I Am Brave study came out, which looked at atezolizumab in combination with bevacizumab. Very interesting combination, because if you look again at the hallmarks of cancer, one of the other important hallmarks is the neoangiogenesis process. So we know that the tumors have this great ability to counteract against the immune system of the body, and at the same time they have the ability to develop their own vessels, which is the way of their survival. So based on that, a lot of these studies since then have concentrated on combining these two mechanisms. You will see 3 different types of immunotherapy combinations. So you will see immune checkpoint inhibitors, you will see immunotherapy chemotherapy combinations, and you will see immunotherapy and other targeted treatment combinations. So if you look at these data side by side, just concentrating back on hepatocellular carcinoma, so you see that compared to the small molecules like sorafenib, we've seen a real transformation of overall survival outcomes, whether it be progression-free survival. Again, Waqas took you through some of the important parameters like duration of response. We are aware progression-free survival, overall survival, these are all the important parameters. But just cast your eye on the numbers, really, and you'll see that these numbers were never in that region. So look at all the efficacy parameters. Now, obviously, that brings you to that usual challenge. We saw an excellent talk yesterday about the use of small molecules in hepatocellular carcinoma. If you're in a clinical setting where a patient asks you, should I actually sell my house for this additional small benefit from immunotherapy? My response to that question, and a lot of people asked me this question today, was that we are not, I think we need to understand our limitations. We are working as clinicians. So our job is to advocate science. Our job is to give them information, honest information about the pros and cons of the treatment. It's very difficult if I put myself in that position where I also need to take a decision about somebody's whole family dynamics, because one could see it differently. I think the key here is good communication, no matter what background of the patients you're dealing with. And again, I understand the counter question to that is, what if the patient says, you tell me what to do? Well, of course, it's a separate communication skill station that we need to run, but I think the key here is honesty and integrity in terms of the information which is being passed to the patients. these clinical trials, one of the questions which commonly gets asked is, are they truly representative of the patients that we see in our clinic? And that is indeed the title of my talk. So there are two aspects to that. One aspect is that, is it actually this Western patient population, Caucasian patient population, representative of the broader patient population all across the world? Of course, we don't have a scientific way to answer that question, but I would say that another narrative would be that, well, what is the alternative? Other than trusting those data, can we actually say that we have our own data? Have we run prospective trials? Have we run prospective studies in order to justify our own treatment approaches? Or would we just benefit from our anecdotes, which is something that I would discourage people to do. And then in the second aspect is that even in the West, actually, where these trials are run, are they truly representative of the real world data? And indeed, there are some challenges to that, because in the trials we know we have to be guided by very strict inclusion and exclusion criteria. In the real world practice, this may vary. So coming back to this study, which is hepatocellular carcinoma, main topic of the discussion today, look at these data. And I think, again, from the educational point of view, I just want you to focus on this tail of the curve. So what we see with immunotherapy is quite an extraordinary pattern. So the progression-free survival at that initial part of the curve, there is separation. And indeed, that separation is important. But what you see at the latter part of the curve is extraordinary, because that separation is maintained. And we all see in our clinical practice that even if the response rate is low with certain immunotherapy agents, the benefit, if they achieve, is long-lasting, which is where the main difference between immunotherapy and targeted therapies is. So have a look at these data with quality of life incorporated. Now, the other question that we commonly get asked is that, how do we look at the quality of life? We earlier looked at there's a high discontinuation rate with GI toxicities, with pulmonary toxicities, endocrine toxicities. So there are a range of toxicities that patients may have. But remember one thing which we cannot see is that patients who would have the effects of the tumor, and as a result of controlling them, there is an improvement in quality of life. And hence you see that quality of life data are always incorporated into those trials, and you would never come across with a situation where a trial would get approval of a drug unless the quality of life was incorporated. So I think the sponsors of this drug, atezolizumab, have done a good job, because they took that narrative into clinical practice and they ran this chief trial or prospective real-world data series, and you'll be glad to hear that that again demonstrated the maintained response even in the real-world data series. So in the interest of time, again, I will move slightly faster across, and if we look at the side-by-side positive phase 3 immunotherapy trials, so there are trials which are looking at, as I said earlier, immunotherapy plus immunotherapy combinations. There are trials looking at immunotherapy plus targeted therapy combinations. And then there is a middle group of patients who actually have a fantastic response to immunotherapy. You can combine TACE with it, so more aggressive therapeutic options. And actually, rarely, this could lead to almost curative options. That doesn't happen every day. You shouldn't promise this to the patients, but I think the key here is to understand that you optimize the chances of these patients getting selected patients very aggressive and curative pathway options if you achieve very good control. And based on that, there are new trials which are now evaluating the combination of TACE or other targeted options along with immunotherapy combinations. So again, I think I'm short of time, so I will move across a little faster to the main case that I wanted to discuss. So this is one of my patients in the private sector in London. So what happens in clinical practice? And that is the key. So guiding treatment in advanced HCC. So this is a lady in her late 70s with hepatocellular carcinoma, segment 7, quite a sizable tumor, 7 centimeters, stage A, initially T2N0M0. So initially treated in January 2017, so almost a decade ago, so 9 years ago, with chemoembolization, then had further chemoembolization, stereotactic radiotherapy to the liver, so all localized treatment options in the beginning, but progressed. And here you're seeing a relatively aggressive disease biology. With more aggressive treatment options, you're seeing a progression within 6 months of the initial diagnosis. So most of these patients in the era of targeted therapies alone would have been dead almost 7, 8, 9 years ago. So this patient went on sorafenib and had actually a good response to it, which probably suggests a good disease biology. But then she had progression with multifocal recurrence. And at that time, atezo and bev were very newly approved. So you saw the data came out in 2020. So we got funding approved. Initially, there were some challenges, so she went on lenvatinib. I saw good data from my colleague yesterday on lenvatinib. This patient could not tolerate it, and then she was switched to atezo and bev. And this is interesting because you would generally feel that the small molecules are better tolerated compared to these aggressive immuno-targeted treatment options. But that's not always the case. With small molecules, we all know there can be quite a lot of hand-foot toxicities, other toxicities which may stop the patients from carrying on. And remember, the benefits, as per the trials, is measured in weeks to short number of months. It's not in years. So this patient started on atezo-bev and had initial excellent response with the doublet, then had stable disease. As a result of this, outside the context of clinical trial, and now consistent with what the trials are exploring, we took this patient through the MDT, and she was offered CERT, stage 1 in January 2022, then in March again, stage 2, and then resumed atezo and bev. And I'll now take you through quickly through the results. So you can see that this patient has been under my care, gets 3 monthly scans, and this is what it looks like. So this is 2020, you're seeing a sizable tumor. This is 2022, you're seeing shrinkage, and you can see the vasculature has improved. And you're seeing this now in 2023. This is 2024. This is very recent, December 2025. So in conclusion, I'm well in time actually, immunotherapy combination are the new standard of care in patients with advanced HCC. Atezo-bev is established first-line care for advanced HCC in the UK as well. Long-time responders exist. I think we need to worry less about the toxicities, be vigilant, be aware of them, but at the same time, it shouldn't inhibit us from treating the patients. Interestingly, this patient had 2 types of toxicities, so joint arthropathy, and I had to actually monitor it carefully. Sometimes she went on high dose of steroids, sometimes she came down on the dose of steroids, and then she had toxicity from bevacizumab as well, which may or may not be related, but she had a thromboembolic event. This was almost a 1.5 years ago, and we took her back to the MDT, and since then she's still on the combination, still surviving. She's now 83. So I think the key message is not to give up on immunotherapy or targeted treatment options early on. Of course, be aware of the funding issues, but at the same time, be a physician, not a philanthropist. Thank you very much.
Wonderful, Khurram. Thank you very much for an excellent talk. And I'm proud of all my speakers to be the best timekeepers. So the next, I'm going to invite one of our medical oncology consultant colleague, Dr. Hira Yusuf. She's been doing a wonderful, marvelous job at St. James's Hospital, Leeds. She has been involved in various projects. You will be seeing her in the Women Symposium as well. But today she's going to enlighten us on immunotherapy toxicities. That's the most wanted kind of a topic to know about toxicity, how to deal with them. So come here, please.
Hello, Assalamu alaikum everyone. Thank you, Dr. Waqas, for the introduction. And I'm not really sure that you can say that you're still proud of me to keep the time on spot. So a little bit of introduction. I'm a consultant medical oncologist working at Leeds Cancer Center. I'm involved in immuno-oncology clinical network at national level in UK, where we discuss complex cases every month and provide educational forum for the doctors. This is my cancer center on the left side, and the right side is the Stanley Ferry, which is a small river nearby where I live. And it's very cloudy and sunny, as you can see, but UK is normally not like that. This is my disclosure. So before I start, very quickly, I know it's not a polling, unfortunately, but please raise your hands. How much confident are you in managing immune-related adverse events? Not confident at all? Slightly confident? Somewhat confident? Good. Easy peasy, I am champion in managing side effects. No? Okay. And I don't know what I'm doing here. I want to go home. Okay. No one wants to go home. That's a good start. A quick timeline. Dr. Asghar went through this slide, but I'll just quickly go that you can see since last 10 years in how many cancer sites immunotherapy has played the role now. The last I read were these two papers, Keynote 689 trial in neoadjuvant and adjuvant pembro in the advanced head and neck cancer, and the Lancet study on pembro with trastuzumab and chemotherapy for HER2-positive gastric or gastroesophageal cancer. So a little bit about selectivity. The chemotherapy is just like a shotgun. It blows away whatever comes in the way, rapidly dividing cells. So the toxicities are most likely bone marrow suppression, GI toxicities, nausea and vomiting, hair loss. And patients have awful time. Dr. Khurram Khan just touched that quality of life really does matter, and people had a very difficult time. While immunotherapy is just like a scalpel where it attacks on the tumor tissue and leaves the normal tissue, well, in most of the cases, and immunotherapy is generally well tolerated by folks. So this is kind of a slide showing glass half full and glass half empty picture. Dr. Vikas has given an excellent talk on durability, so it has a good durable response. Obviously, as you all know, that it has evolved cancer. It has changed the landscape for the cancer treatment, and it's mostly safe. The glass half empty picture, now I'm going to go back to Dr. Asghar's slide in which he mentioned that in metastatic melanoma, the 10-year overall survival was more than 50% of the patient. But being an oncologist, we need to raise the bar a bit higher and need to care more patients. Obviously, the downside is managing the side effects of immunotherapy. So the key piece of information today for my oncology and non-oncology colleagues here, that how and why immunotherapy is a bit different from the chemotherapy. So obviously my colleagues have talked about how immunotherapy works. Once it stimulates your immune system, even if you remove the source, the inflammatory cycle is ongoing. And it does not terminate spontaneously. While with the chemotherapy, it's a short duration, it's given for a short duration of time. And with the chemotherapy, if you stop the chemotherapy and deal with the side effects, patients starts feeling better. Immunotherapy for in the metastatic setting is given for 2 years. In the adjuvant setting, it's given for 1 year. As Dr. Vikas has mentioned earlier, immunotherapy has delayed onset of action, while chemotherapy just goes and starts killing the cancer cell. So if you have rapidly progressive disease, visceral crisis, think about starting chemotherapy instead of immunotherapy. You name it, and you can see the toxicities in this slide. So it can affect any organ or any tissue in the body. Grade 3 and 4 reactions are more common in the combination treatment, up to 58%. And the PD1 and PDL1 is up to 19%. Now, this is the recent paper by my friends, Dr. Anna Olson-Brown and Ricky Fraser. It was published in 2025, in which they discussed about incidence of immune-related adverse events based on the most frequently reported reported, and they studied this in malignant metastatic melanoma and renal cell cancer. And you can see that in the melanoma setting, the colitis was high, followed by skin reactions, followed by hepatitis and endocrinopathies. And obviously you can see that with the combo treatments, the rates are a bit higher than the single agent immunotherapy. However, in the RCC cohort, the skin reactions were more common, followed by hepatitis, followed by colitis, and the other toxicities. Median time of onset, it can start anywhere from giving the first cycle of treatment throughout the continuation of treatment, and even sometimes you discontinue, the immunotherapy patient has completed the course and they can have late side effects. So it can start, median onset is around 4 weeks with the grade 3 and 4 adverse reactions happening around 7.7 weeks. I'm going to just skip the slide. So quickly, CTCA grading for my young doctors here. So obviously, we grade everything in immunotherapy. Grade 1, in chemo and immunotherapy, basically both. So grade 1 is mild, grade 5 is death. That's simple. Things got a little bit mixed up when it's grade 2 and grade 3. Grade 2 is moderate, where the activities are a little bit, it's limited, while grade 3 and grade 4, both of them requires hospital admission. Grade 3 is when your activities of daily living are limited and you can't do your self-care. So quick scenario again, I'm sorry that the slides are not for polling. I would like you to tell the grade. A 63-year-old female with metastatic renal cell cancer on combination therapy with cabo-nivo presents with watery diarrhea occurring 4 times daily. There is no blood, no mucus, and symptoms have not improved with loperamide. She is hemodynamically stable with no dehydration, incontinence, or limitation of self-care activities of daily living. So what do you think which grade this would be? 1, 2, 3, 4, 5. You can shout out if you want. So diarrhea is always calculated by number of stools, and it's grade 2. This is scenario 2 for doctors here, that a 55-year-old female receiving neoadjuvant pembro for metastatic triple-negative breast cancer presents with vague symptoms. Blood pressure was 90/60, and chest pain at the tumor site radiating to the neck. She, apart from hypotension, she was stable. What are the most appropriate initial investigations? A, baseline investigations. B, baseline investigations, blood glucose, cortisol, TFT. C, PET-CT scan to assess the progression. Disease response, ECG, baseline bloods, blood glucose, cortisol, TFT, CK, TROP-I, BNP, or colonoscopy and stool studies. Okay, I'll go with A. Please raise your hands if you think it's A. Is it B? Okay, thank you. Is it C? D? Perfect. Obviously, I'll just ignore that. So going forward, how would you deal with the side effects? I'll just generally give you an overview. Remove the source. आग लगी है तो बुझानी तो पड़ेगी. So obviously remove the source, hold immunotherapy, mitigate the inflammation, provide steroids, supportive management like endocrine treatment if it's endocrine problem, oxygen if it's pneumonitis. Early detection and management is really critical in managing significant morbidity and mortality in patients receiving immunotherapy. As I said earlier, the majority of the adverse events, they occur within 12 weeks. However, there's a small number of patients who could have late effects of immunotherapy. People can die with immune checkpoint inhibitors, and I think I would be really worried about myocarditis and pneumonitis. However, the other side effects can also cause fatality rate. So, immune-related adverse events, they really come on their own. So you need to have Sherlock Holmes-like sharpness to detect them earlier. Why I'm saying that is I have seen lots of patients who have colitis and after a few weeks they develop hypothyroidism, or a patient who just came with a neck pain and fatigue and ended up having triple M syndrome. So please look sharply for any adverse events and look for other signs and symptoms. So please don't worry on managing toxicities. There are lots of international and national guidelines. In UK, we follow international guidelines, ESMO guidelines. We have national guidelines as well, UCON's and Immuno-Oncology Clinical Network. We have local guidelines. Personally, I do like Clatterbridge Cancer Center guidelines because there's a traffic way highlight in which green is grade 1 and it will tell you what to do. Yellow is around grade 2 and grade 3 and 4 is red. So if you want to take a picture of that, you're more than welcome. But please remember, treat your patient as a whole. It's easier to start steroids than to investigate and work on differential diagnosis. Do not treat the numbers, treat the patient. Just for the sake of time, I'm going to skip this slide. So my talk was immune-related adverse events. How to play safe. This is a slide which I have added last night because of a reason. I thought about how easily patients can go to the pharmacist and have anything and everything they want, from a simple anti-sickness to azithromycin, especially in Pakistan. So over-the-counter access, we need to educate our patients. Doctors, they need to know that what's the mechanism of action of immunotherapy and what are the blood investigations. MDT matters. Please do discuss complex cases in MDT. In UK, we are collaborating. I would like to collaborate with Pakistani oncologists and see how can we help our Pakistani doctors to manage immune-related adverse events. We need to create educational forums to discuss complex cases or even simpler ones. This is a slide which I just copied paste from the Leeds Teaching Hospital website, in which if someone is on long-term steroids, please make sure that they have a steroid emergency card. Again, education for patients is really important, and they need to report these symptoms to the acute oncology services. One advice which I would like you to give, to take from today's symposium, from my talk, is please be best friend to your colleagues, endocrinologists, radiologists, nephrologist, neurologist, everyone. These three handsome people are my best friends. That's Dr. Ali Raza from Hull, my go-to place for breast cancer. Ricky Fraser is lead of IOC and network, and Will Ince is a clinical oncologist at Cambridge who does head and neck cancer and immunotherapy. Last slide again, which I added last night. We know that in UK things are changing. We have subcut Nivo and atezolizumab available, and Pembro is on its way. And the safety trials, they confirm there is no difference between the safety signals between the infusion and the subcut injection. However, the local site injection reactions are obviously more common, and it does address lots of capacity issues in NHS. These are my resources. This is my email address and my telephone number. Happy to be contacted for collaboration or any complex case you want to discuss. Thank you very much.
Thank you. No, you're on time, that's fine. Okay. So now we will take questions at the end, if you kindly take a seat. Thank you for a nice presentation covering breadth and width of immunotherapy toxicities and how to manage it. So the next speaker I'm going to invite is one of our wonderful colleague. She's working as a consultant clinical oncologist at Anmol Hospital, Dr. Wajia Anjum. She's going to enlighten us on the Pakistan and the experience of immunotherapy in Pakistan. What are the challenges and the aspirations? Please come, Wajia. Thanks.
Assalamu alaikum, everyone. Thank you, Dr. Vakas, for your kind words, and thank you, PSCO organization, for organizing this scientific session. And I also acknowledge all the insightful talks by the previous speakers of this session. So today I am going to discuss the emerging trends and real-world experience of immunotherapy in Pakistan's cancer patients. We choose this topic after discussion with Dr. Mekan and Dr. Vakas that we should come to this topic that how is immunotherapy is being practiced in Pakistan, what are the challenges and what is the clinical real-world experience of the immunotherapy in Pakistan. So we all know that the cancer treatment has moved beyond chemotherapy and targeted therapy, and immunotherapy does provide us work as immunomodulator, and it identifies and kills the cancer cells. And there is a paradigm shift of the oncology practice by the introduction of the immunotherapy, and it does provide us long-term response which were never seen even before in the early setting as well as in the metastatic setting. And there is improved survival outcome for the tumors which were historically bad prognostic, and this provides a new hope for where the chemotherapy does fails. And it is also an option for previously treated, heavily treated tumor for the resistant and the refractory tumors. And it does provide a personalized medicine based on the biomarkers like the PD-L1, tumor mutational burden, MSI, MMR, and there is the need of advanced therapy at this peak time of the hour that we need the advanced therapies. So talking about the Pakistan, that we are experiencing at a rapidly rising in cancer incidence where with the late presentation and the limited treatment resources. So where the chemotherapy outcomes have reached a plateau, immunotherapy does provide a critically needed new therapeutic window, especially when the conventional treatment offers minimal benefit. So this is a slide from the Globocon 2022, and according to this slide, you can see that there were around 20 million new cancer patients globally and almost half of the deaths. And talking about the males, the most common cancer is the lung, followed by the prostate, colorectal, and head and neck cancer, while in the females, breast cancer is the most common cancer. And I found it very interesting that while seeing the geographical distribution according to Globocon, you can see that the 50% of the global cancer incidence is from the Asia, and similar is the same is the mortality rate in Asia. While you see the Africa and America, the incidence is high, but the mortality rate is low, which shows that there is a role of screening, early diagnosis, and the better treatment options and better cancer care resources. And when you see the Africa, the incidence of the cancer is low, but there is a disproportionate high mortality rate because of lack of the resources. This is just a repetition that's showing that the role of the immunotherapy, for example, in the non-small cell lung cancer, when the PD-L1 is more than 50%, immunotherapy alone versus chemotherapy, immunotherapy alone have improved overall survival with a significant p-value. Okay, this is important that whenever we're talking about immunotherapy, the role of immunotherapy across all cancer, the efficacy of the immunotherapy is between 12 to 15%, and this also depends on the selected tumor types like the melanoma, like PD-L positive, more than 50% positive non-small cell lung cancer, as well as the high MSI and MMR tumors. Here, the maximum response is 12 to 15%. So following are the agents which are readily available in Pakistan, and there is increasingly growing clinical use in the tertiary cancer centers. So you can see that very few agents like the atezolizumab and durvalumab, which are the DRAP-registered immunotherapy available with us, but most of the immunotherapy is not DRAP-registered, and they all are available on NSO basis. So talking about the availability and access of the immunotherapy, then these therapies are available in the larger cities, in the major cities of the Pakistan, and there is uneven immunotherapy, access of immunotherapy. Like in the private setup, generally the patients have easier access because the immunotherapy is self-funded majority of the cases in Pakistan. While in the public hospital, we face major limitations due to the cost issue, due to the import logistics, and also we are lacking reimbursement programs. So here are the few centers like major hospital and specialized center. We are offering the immunotherapy. Atomic Energy Commission Hospital are those, and these are the list of the hospital. I'm sorry if some centers are missed, but the message is that immunotherapy, the major data is coming from mainly from the private hospital as compared to the private government setups. So there is increasing institutional reports, and there is, but the data is, there are new reports and outcomes data, but this is a very small cohort of patients which we can interpolate, and the most commonly used in the non-small cell lung cancer, in the breast, head and neck, RCC, ACC, and so on. Next important thing is identifying the biomarkers that reliably classify the patient response, resistance, and toxicity become the next critical barrier toward the improving care. And in Pakistan, there is like we have a limited access of PDL testing. Here again, we have cost issue to devise these tests, and there are variable lab standardization, and we need to expand MSI, MMR, and TMB testing so we can offer precision oncology, the right therapy to the right patient. Talking about the use, pattern of the use, yes, we are prescribing immunotherapy in the first-line setting, in PDL high tumors, in second-line setting in majority of the tumors in are the salvage setting, and we are also combining immunotherapy with the chemo as well as with the radiation therapy. The pattern of use with the chemotherapy, like in the G-junction tumor with a high MSI, we are combining chemotherapy with immunotherapy, and as in Keynote 522, the standard of care is immunotherapy with chemotherapy, and the results are they are globally comparable with the international data. This is again an important question, as immunotherapy is safe with radiation. Yes, as radiotherapy is not just a local treatment, it acts as an immune modulator, immune primer. How does it work? It releases the tumor antigens, it enhances the antigen presenting cells, and it alters the microenvironment of the tumor, so the cold tumor becomes immunologically hot. Outcomes, yes, local results reflect the global trends, but the long-term follow-up is essential, and the outcome consistent with the international data, but the small sample size samples highlights the need for extended monitoring. The finding cannot yet be generalized across the country. And talking about the toxicity profile, yes, we are basically on a learning curve regarding the immunotherapy, identification of the toxicity and its management. And we need to have more trained staffs and so on. And there are not published Pakistan-specific database for IO toxicity. And the toxicity pattern we usually infer from the global data. Now coming to the INMOL data, this is the IO experience of INMOL for the last 2 years, and the new number of cancer patients registered in the 2 years are almost 16,000, and these are the most common cancers like breast, head and neck, liver, lung, and gynecological tumors, and there are a lot of eligible patients and indications for the immunotherapy. In spite that, we only less than 1% of the patients were able to get this IO treatment. And these are the primary sites which were being treated with IO, like RCC, TNBC, head and neck, gynecological tumors. And 70% of the patients were male and 30% female, and most of them ECOG 0 to 2. Line of action, yeah, in triple negative, RCC, HCC, and melanoma, these were used in the first line setting, while in rest of the tumors, we use in the second line setting, and most commonly use the pembrolizumab, then atezo, and we also have experience with the EP and EVO in the melanoma patient with the brain metastasis. Talking about the toxicity, yes, we do have a non-specific toxicity profile, and few of our patients also experience the hypersensitivity, which does not commonly was documented in the international or theoretical data. And the other commonly seen toxicity was fatigue, and the few patients also experienced the pneumonitis. So IO use is rising in Pakistan, and real-world data is developing. And we need to have some national level IO registries. We need to have DRAP registered immunotherapy. There should be subsidized and standardized biomarker testing, and we should develop some coordinated national strategy for pricing and strategy to make the IO available for the maximum number of the patient. For example, this paper was published in the ESMO 2025. According to this, that substantial price discounts are unlikely to be provided by the pharmaceutical companies. So here is a strategy to greatly improve the access of immunotherapy to the cancer patient. Like we can give off-label weight reduction of the immunotherapy. As for Atizo, the dose is standard dose is 3 milligram, but we can prescribe the 0.6 milligram per kg. Similarly, for the pembrolizumab and atezolizumab, we can reduce the dose off-label, and by this way we can make it possible that maximum number of patients can be offered with the standard of care. The support programs in Pakistan, yes, here in Pakistan we are having the PSCO and SMOP. These two societies are working on indigenous treatment protocols that adapt the global IO standard to the local economic realities. And there is a good news for the cancer patient that is in this January 2026, Ministry of Health has signed an agreement for cancer patients relief. And we also have Anmol patient support program for the cancer patient, where we can offer them targeted therapy as well as immunotherapy. So in summary, the oncology market in Pakistan faces a large affordability gap that limits a doctor's willingness to prescribe high-cost novel medicine. With coordinated national database, affordable testing, trained clinicians, and negotiated drug pricing, Pakistan can equitably improve immunotherapy. One of the important things that if early diagnosis is made possible, approximately 45% of the cancer burden can be preventable, and yet many patients present at advanced stage where IO is less effective and mainly palliative. So by thinking creatively, we can bring together the entire ecosystem to change the paradigm of the cancer care for the patient in developing countries. Thank you very much.
Thank you, Vijaya, for giving a very nice perspective what's been going on locally in Pakistan, what provisions do we have. Can we move on to the case-based discussion, please? Can you put that next presentation? Yeah. I deliberately compromised on my pilot data, which I was about to present in my presentation, just because of this case-based, because that's more interactive, interesting as well, hopefully interesting, yeah. So we, in collaboration, prepared this case. This is my own case from my own center. And can we move on to the next slide, please? Yeah. Yeah. So we deliberately did not put any picture of the patient because the patient was having mild learning disabilities and he was lacking capacity. And as a best interest decision, we just anonymized his scans, and we did not put any picture because there was no way to obtain a consent, and being professional, we did not feel comfortable to put his picture. So he was a 59-year-old gentleman. The background was that he was treated in 2020, and if you remember, that was a peak COVID time, for a poorly differentiated squamous cell carcinoma of the head and neck origin, and he had a right hemimandibulectomy, neck dissection, 1 out of 49 node positive, LVI, perineural invasion, both positive, adequately excised at the margins, and he was treated at Nottingham University Hospital. Then he was referred to Lincoln to receive postoperative radiotherapy, which he completed, receiving 60 grain 30 fractions to the primary and ipsilateral neck due to the high-risk features, and he completed the treatment in April 2020. So he was mildly autistic on the spectrum, living on his own with support of his sister who was not living with him, but there is no much to offer, and he was not much compliant with the follow-ups. No known drug allergies. So in March 2022, almost around 2 years' time, he presented with this kind of a PET scan picture. with an extensive fungating tumor affecting the right side of the ear, parotid, encroaching all the way to the right eye. So luckily, despite this bad news, which looks radiologically not very good, there was no distant spread. So as an audience, what would you like to do as a next step? Would you like to jump onto these options directly, or do you like to do something different? So your option A is the traditional chemotherapies. Nivo, you know, there's immunotherapy. Can we go back to the surgeons and can seek help from them? Or should we do a biopsy? Or should we look at a traditional first-line combination, which we always think about, head and neck ones? Biopsy. Thank you very much, Dr. Abu Bakr. Who else is in favor of biopsy, and who else just want to go on to any of these treatment options? No one. I think everyone is wiser here. Surgery. Okay, fair enough. Well, that's not entirely wrong, because it's better to take this case back to the MDT. So that exactly happened. The case was taken back to the MDT, head and neck MDT, and they decided to do the biopsy first. Obviously, 2 years is not a big time gap from the treatment of the primary tumor, but that's where the surprise came up. The head and neck MDT decided to do a biopsy. It came back as poorly differentiated squamous cell carcinoma, P16 and CK7 negative. I mean, they had thorough discussion among themselves. They have done multidisciplinary. Nottingham itself is a very good histopathological center. So they concluded that this time this is not a head and neck cancer. Unfortunately, it was a skin malignancy, which was destroying his right ear, might be arising from the pinna or preauricular area, because the gentleman was not very conscious about follow-ups and things. He kept ignoring these things and unfortunately ended up with a situation which looked quite unresectable. So the MDT recommended referral to the skin MDT. The skin MDT decided that no, we can't do an operation. It will be a very mutilating surgery. So they recommended to send it to the oncology for systemic anti-cancer therapy plus minus radiotherapy. So he ended up in my clinic as a new patient. So if it would be you, when you see this patient in the clinic, what would you do? I mean, obviously he was lacking capacity. He was having no robust support in place in the community. So it was quite challenging, to be fair. And obviously he was not comprehensively understanding the situation. So option, do you go for chemotherapy or do you go for immunotherapy, palliative radiotherapy, enough, not more than that, best supportive care, do nothing. That again is your prerogative. You are not, MDT recommendations are just recommendations. You being clinicians are not legally bound to follow them. If you decide in the clinic that patient is no more fit for anything, you can simply feed it back to the MDT that I have reviewed the patient, I had a complete discussion, I took a holistic approach, and we ended up with this solution that he is no more safe to have any treatment. Or cetuximab again is used in some of the malignancies of head and neck origin. So which option would you go for? A, B, C, D, E? Yes, well, it is quite extensive. I think I missed to, I'll show you the PET scan again, because it was quite extensive and destructive. So, and he received the head and neck radiotherapy previously, so there was a bit of an overlap with the previous head and neck field as well. So it was almost impossible to achieve the curative doses and to achieve the constraints for the OARs. So that was a bit out of option, unfortunately. So we decided to start with cemiplimab. Everyone knows what cemiplimab does. Cemiplimab basically is anti-PD-1, and it's approved treatment, evidence-based, to use it in cutaneous squamous cell carcinomas. So in the beginning, we know that we have talked about this, that there is a bit of an pseudo-progression element, and then we do see sustained response. Duration of response, we have all talked about. This is the trial which has changed the practice, and I don't want to waste any time into the trial because that's not the reason to present this case. So April 2021, cycle 1 of cemiplimab, so that exactly was the baseline disease, and you can see it's quite extensive within a significant overlap with the previous radiotherapy fields as well. So after completing, we also then considered 5 fractions of radiotherapy because it was a bit symptomatic, so we tried to cover it with as much as we can. We planned it with VMAT, to exactly know what we are doing, what has been done previously, to know exactly what is the overlap. So it was safe to deliver it. So in June, after 4 months, this was the first scan to assess the treatment. You still can see there is avidity here. And I think that was the first scan, so we did not panic to call it a residual disease. I think we thought that still there will be a chance of an ongoing response, so no need to panic. There is a significant improvement, so let's carry on. So many clinical trials report the initial measurable responses. That's a slide I have already presented, I think, in my talk, that 6 to 12 weeks, or 1.5 to 3 months, approximately half of the responding patients show tumor shrinkage within 6 to 8 weeks, So you just need to carry on what you're doing at the moment. After 17 cycles of cemiplimab is a 3-weekly treatment. Sorry. You raising hand for a question? Sure, we'll give you a chance to ask the question. Don't worry about that. Right, so this is a PET scan where there is no PET-avid progression of the disease at the primary site, but we have found, this is kidney, don't worry about it, this has been identified as a new mesenteric PET-avid area. I'm sorry, I could not put a complete scan to go through up and down, so these are the most suitable slices through the scan. So what would you do if you see this kind of a PET scan in your clinic? Will you stop cemiplimab? Will you change the systemic treatment to something else? Or will you consider some palliative radiotherapy to this mesenteric PET-avid area? Laparoscopic exploration? Or you will stop the treatment and say, thank you very much, we can't help you anymore, best supportive care. All right, so one option is laparoscopy. Laparoscopy, okay. I can't read Dr. Asgar's mind what he wants to do. Okay. So what would you go for? Do you go for laparoscope? Observation, okay, that's a very reasonable option, observation. And will you continue with the rest of the cycles of the cemiplimab? Okay, that's a good idea. That's one take, thank you. So any more suggestions to pick? Yes? Yeah, take the mic please so we can hear you.
Chemotherapy and after operation, why is radiation is important?
Because the patient was quite symptomatic. He was having a symptomatic weeping wound with bleeding. So for the sake of symptom control, the palliative radiotherapy was considered at that point. We did not delay the start of his treatment just because of palliative radiotherapy. We were also thinking that with the help of some immunotherapy to start with, we might get a bit of a shrinkage. We were expecting
I get a breast cancer, but I don't get radiation. Alhamdulillah, I get only chemotherapy and surgery.
Yeah.
So my neighbors, she also get breast cancer, and she had first surgery, and then she get chemotherapy, and then she get radiation.
Sure. Breast cancer is a very different disease. Here we are just talking about role of immunotherapy in skin cancers. So we will definitely be happy to answer your question after the session to address that particular issue about breast cancer. But the case here is entirely a different case with a different dynamics and responses. Thank you. So shall we move on? And we opted for laparoscopic exploration, and that was the right choice. And Dr. Asghar's choice was not wrong either, to continue treatment and just observe. And the skin MDT also suggested this. So the first laparoscopic exploration did not identify any measurable disease there. And he was referred back to us in the skin oncology clinic. What to do with cemiplimab? I mean, we were again back to square one with no answer. So shall we continue? Yeah, I think that was the choice. And I think that we came back to your point that that exactly happened. But at least we took an opportunity to seek help from the surgeons to see whether they can help us to know what it is. So it was continued, and after cycle 22, after a few more cycles, unfortunately, the following PET showed further progression of disease within the mesenteric area, same place, with no progression at the primary site. So we took it back to the MDT. The MDT recommended the same. Can you ask the surgeons? And surgeons were kind enough. She was a lady surgeon, fantastic colleague, and she said, fair enough, we will give it another go. There is nothing else. That's the only area persistently growing. The primary site was showing no metabolic progression on the PET scan. The second attempt of laparoscopy was made, and that has brought this answer. So it was it's a stage 1 follicular lymphoma removed by surgery. So the patient has completed 35 cycles of cemiplimab as planned. He is under observation under the hematology because the stage 1 lymphoma follicular has been removed. So in either way, it was a win-win situation for us as well as for hematologists, and the patient is still in radiological remission from a skin cancer point of view. Sorry? No, that was not recommended by the hematology MDT because that was an adequately removed disease. They removed the whole disease laparoscopically, so they thought there's no point of giving or burning the bowel at that point, because bowel and kidney and so many other areas. And again, it was a mesenteric node. When you remove it, the radiotherapy is quite challenging field-wise to see what you. It was more mesenteric at that point. Yeah, it was not para-aortic. So thank you very much for your patience. Any questions to any of the speakers in our, obviously, we have had fantastic, wonderful talks by Khurram, Hira, Wajia. I'm not including myself. So yes, Khurram. Please, can you give a mic to, thank you, Dr. Asghar. Thank you. Just so everybody can hear your question. Yeah.
My question is regarding your case. This was the third malignancy in the same patient. Do you consider, are you considered about some genetic syndrome like a P53 mutation or like this?
I think that's a very good question. That came in our mind. But to be fair, so far there is no reported relevant higher genetic risk in patients with learning disabilities to blame that particular disorder to be linked with multiple malignancies. But he was 59, so again, that genetic disorders usually present a bit early in the stage. So that was an option, but there is a criteria of referral to the genetist in Nottingham, so that did not, that there was no particular answer for that, yeah. Yeah, I mean, that's another thing. The thing is that you might identify a molecular marker, but then if that is not helping to predict you the drug, either you're doing a fantastic job like Khurram in US. He's here now for the next session. You might be listening me. If you're doing a fantastic job like Khurram in US to doing things out of box, which we are not allowed to do in UK, yes, there is no harm to explore the options by setting up a phase 1 or preclinical studies. But again, there is no marker so far. Thank you. Yeah.
I have a question. I'm Dr. Misbah. You must understand that we are at the very start of immunotherapy use. So I am quite excited about this pseudo-progression of the tumor, and it is very critical for making the decisions of the patients where to stop and where to continue. So my question is, how common is pseudo-progression do you see in your cases? Do we expect to see in each and every case? And
no, pseudo-progression is not necessarily to be seen in every case. Pseudo-progression, it can be seen in quarter of the patients. So it depends which area you are doing measurements. Even in cemiplimab trial, they said even on subsequent progression, if there is radiological progression, don't stop it. Continue if the clinically patients are responding. So the first 2 scans, when we did all these audits, we have collected data on cemiplimab over the last 5 years, and we will be presenting audit in UK soon. And similarly, we have done a pilot study to look at the duration of response after discontinuation. So the timeline from which we started measuring it after the second scan. So the first scan always can deceive you due to the pseudo-progression phenomena. So it's not happening in every patient, but if you see increasing volume of disease on the first scan, there is no need to give a bad news to your patient.
okay, so the graph you showed that initially the immune cells are entering and then the cells.
Yes.
So it should be quite common.
Sorry?
The initial increase in size should be quite common if it is not a pseudo-progression as well.
Yeah.
Yeah.
Yeah. You want to make any comment, Zisha? Can you go back to my presentation, please?
I think this is a very important question about the pseudo-progression. When you are giving immunotherapy to a patient, in my experience and opinion, there are 2 factors. One is the clinical response, and other is a radiological response. If my patient is getting clinically better, and if the radiologist comments in MDT that this patient is progressing, as per RECIST criteria, then I will gauge between that if I am getting any clinical responses rather than radiological responses. I always go with the clinical response if the symptoms and the quality of life, because I have seen these patients in start, if they are improving, I will go with that. Very important factor is to see the gaps between the scans done, the gap of the pre-treatment scan, and when you start the treatment. If we read the reports in UK when we have all the record available, so sometimes the pre-treatment scans are done more than 8 weeks or 6 weeks time. And when you get this situation, again, I will go with the clinical response and the clinical improvement. And it is not always that all the tumor sites will be responding. So my patient with the renal cell carcinoma presented with a lot of skin nodules, big nodules, lymph nodes. He was responding in those visible area, but he was progressing in the mass, which was a big mass in the rib. But he was clinically improving. So again, in the MDT, you will take a lead that my patient is clinically responding. It may be a pseudo-progression. I will continue the treatment and repeat the scan at a shorter interval, maybe in 8 weeks' time.
Thank you, Aswan. I mean, yeah, the pseudo-progression phenomena is the thing which is a diagnosis of exclusion, and it would happen in the beginning of the spectrum of the treatment, not at a later stage. Yes, Professor Ibrahim, yeah.
Thank you very much.
Hello, can you hear me? Yeah.
My concern is there's one very good point made by one of the speakers of the side effects, that how many of us knew what are going to be the side effects of immunotherapy. In our context, in this scenario in Pakistan, we are going to have, a lot of people now going to have immunotherapy, and the side effect profile in such a setup where patient comes and goes back to his village or to his town, and are the physicians, are the medical professionals, are they really trained to treat these side effects of immunotherapy, or either when he's off immunotherapy and the side effect profile? Probably we have to recommend to our polygraphists and in the medical field whether they have to train their medical specialists to counter these side effects in these patients.
That's a wonderful question, Professor Ibrar, and that very pragmatic question related to the community here. I would like to highlight two things. How to deal with immunotherapy-related toxicity is a new learning curve, and we even all are learning in that part of the world. The new pathways we are developing, not within oncology being in to improve the acute oncology understanding about this immunotherapy toxicity, but we are also engaging the other specialities to develop pathways and streamlines and streams to streamline these treatments, especially for steroid refractory patients. Now, when it comes to the toxicity, I mean, some of the toxicities, they are quite asymptomatic. I think I will also like Hera to give her input, that some of the toxicities are quite asymptomatic, like patients don't complain if their LFTs are getting deranged. Patients, they have got no idea if they have got asymptomatic or subclinical kind of a hypothyroidism. So we have to develop a very simplified literature in the languages to hand it over to the patient as an information leaflet on that drug, that what could be the possibilities, what could you feel as a side effects, and if it happens, please flag it to us. The most dangerous situation, which even is happening in that part of the world, is when we wean off the steroids and we forget to rule out any adrenal crisis. And patients sometimes, they come and die with adrenal crisis. So we are quite now vigilant to make sure that they are not into adrenal crisis or something like that. But yes, more engagement with the specialities and development of a literature in a simplified way in your own languages would be helpful. You agree with Hira? Yeah?
Actually, what we are seeing, we are using immuno, and we really, truly speaking, we don't see so many side effects. But one thing very important in this case, if you're expecting there is some pituitary hypophysitis, like there is a hypothyroidism and all these things, but we don't check TSH even before starting this Pembro or something Nivo. If you're expecting that these could be the major side effects, we are saying that these are the side effects, but in total percentage, I think not more than 10%. You can see in less than 10% cases maybe having, or they're usually asymptomatic. So to worry about and to make the patient anxious about all these side effects, better to check their profile before starting this treatment, and then you can better comment on that.
UK Systemic Anti-Cancer Therapy Recommendation Board guidelines have made our lives easier. I, being a systemic anti-cancer therapy lead, takes a lot of help from them to update our own protocols in the trust. So if I will be happy to share those recommendations with you, and you can simply identify that what protocols do you need to put in place to make sure that the necessary test should be done as a baseline, and then on what frequency should you repeat those tests. The main thing here is if patient is symptomatic with pneumonitis, he would not sit at home. He would definitely present in any medical facility. If the patient is symptomatic with colitis, he would not sit at home. He would definitely present to you or any nearby medical facilities with this. Or severe skin toxicities, they would go to the dermatologist or any doctor. Here we are talking about those toxicities or immune-related adverse events where there is an asymptomatic derangement And if that time window is lost, then obviously that could end up in irreversible damage. So that's where you guys need to work to produce some literature in the local languages like information leaflets, so patients can be vigilant.
Can I ask one question, Vikas?
Yeah, sure.
Thank you so much, Doctor. This question is from you, Dr. Hira. Very nice presentation. My question is, as we know, we are using more combination treatments like chemotherapy and immunotherapies. So how do you differentiate among GI side effects, especially colitis, whether it's happening from the chemotherapy or from immunotherapy?
Can we give her the mic, please? Yeah.
Thank you. Thank you. Can you hear me? Yeah. Thank you so much. That's a very good question, and that's what we see in breast cancer, for example. I do triple-negative breast cancer, and you give pembro along with the chemotherapy. And I would say that if it is still grade 1, give them loperamide. But if it comes to grade 2, then most likely start treating that as potential side effect of immunotherapy. There is no clear way to differentiate that it's chemotherapy-induced or immunotherapy-induced. They are safe if it's still grade 1, but I would have a very low threshold to start them on steroids if it comes to grade 2.
And my second quick question is about cardiotoxicity, because you presented one case which was quite good.
Yeah.
So if you're suspecting cardiotoxicity, how soon you start immunomodulators on the top of steroids? Do you start within 24 hours, or you wait for the investigation to confirm it, because it will usually takes time? Yeah.
No. So start steroids straight away. Okay. Do an echocardiogram. And if they're not responding, then you just straight away give them immunomodulating agent.
Thank you so much.
I just want to add, I was unlucky to have one patient with cardiotoxicity. She was the mother-in-law of one of my chemotherapy nurse. So you can imagine how much it was a pressure event for me. So that lady had a first cycle of Ipi-Nivo for renal cancer, which was poor risk. And she ended up with quite symptomatic cardiotoxicity. So we treated her with high-dose steroids, intravenous methylprednisolone, for 72 hours. And despite giving 72 hours, there is no much improvement. We are lucky to have cardiac MRIs in Lincoln. And there is a criteria called Luke's criteria on MRI to define the immunotherapy-induced myocarditis. And that established the myocarditis straight away. And we started on mycophenolate. We added that mycophenolate and on a high dose, 1 gram BD. Cardiologists, oncologists, we all were in a learning phase at that point. So that was a good learning case. So eventually she recovered. And her, obviously, because the mortality is quite high with the cardiotoxicity, so we decided to discontinue the treatment. She is still in radiological remission. That's a durable response. So fingers crossed. So we had a chance to come across this cardiotoxicity. So introducing immunomodulator after 72 hours, usually but you have a proper investigation to establish it's because there is another thing which can mimic like myocarditis is pericarditis. So pericarditis should be ruled out. Okay, thank you very much. So we have already, we have done very good time management for when we were giving our talks, but we had a very nice discussion on this. Thank you very much to all of you, and hope to see you again soon in another session. Thank you.
Thank you very much.
So we're going to start to the next session. So please stay in the room, so don't leave. Assalamu alaikum. We'd like to have the moderators come to the stage, and we'll start transitioning to our next session. So welcome, everyone. So should we start, or want to wait another minute, or we start? Okay. Welcome, everyone. We'll get started with our session. So once again, this is session 2 of a previous session that we had yesterday. Yesterday's session 4 was about immunotherapy and how radiotherapy can modulate the immune system. And that was our session 4 yesterday, Friday. Thank you for all that attended that session. And as you know, as a background to that session, we talked about various concepts, and we had amazing speakers like Dr. Quinn Lee, who talked about phase 3 trials from the NRG perspective. We talked about adjuvant and concurrent immunotherapy with radiotherapy. And we talked about multiple cancer subtypes like head and neck cancer, lung cancer, cervical cancers. And Dr. Lee from NRG highlighted kind of where the standard of care is currently. And also highlighted some of the gaps that still exist and how we don't really quite have a full handle on radiotherapy and immunotherapy combinations, but there's some data that's emerging. We also talked about LDRT and chemosensitization. Dr. Mazur Ahmed talked about LDRT, which can enhance chemotherapy combinations. We also talked about LDRT and how that could also enhance immunotherapy. And then we also talked about LDRT for benign indications. I personally talked about the role of radiotherapy for osteoarthritis, and also talked about low-dose radiotherapy in combination with checkpoint inhibitors. And then lastly, I did talk a little bit about the future of where things might be moving in the US with new indication like Alzheimer's and also potentially congestive heart failure, but that was preliminary. So this was the background for our session today. So our session today, session 14, we have some really, really great speakers here. Our session 14 is going to talk about clinical trial and infrastructure building within Pakistan. What we would like to do is to sort of have collaborations internationally with key stakeholders with Pakistan and internationally to talk about clinical trial and infrastructure. As a background, what I want to do is introduce our first speaker, and would like to recommend Dr. Majid Mohideen, who's going to talk about the U.S. Pakistan Oncology Working Group that we kind of helped sort of talk about in 2023. And Dr. Majid Mohideen, by way of background, went to Brown University, and actually I met at Harvard, where he did his residency. And that's actually the first time I met him over 20 years ago, actually. I was a medical student, and he was a senior resident at Harvard. Amazing guy, very good friend. I've known him for over 20 plus years now. He's an associate professor at Wake Forest School of Medicine, very academically talented, loves to give back to the community, loves to give back to the world. He is a radiation oncology consultant in Chicago, and he wears a lot of hats. And one of his hats that he currently wears right now is he serves as an advisory board of the International Cancer Expert Corps. So please give a round of applause for Dr. Mohideen as he comes to the stage.
Bismillah. Okay, do we? I don't know if that's up. Okay, perfect. Okay, so my role today is basically to set up a framework for Dr. Mackin. That is my job, okay? And this is not just for this session. This is 3 years in the making, at least 3 or 4 years. And I just wanted to explain how this came about. So I am part of a group, we are called the U.S. Pakistani Oncology Working Group. Who are we? Why are we here? What have we been trying to do? And I want you to get the sense that where we are at now is inevitable. And really, there's no going back. So let's start the story in about 2002. So Dr. Bilal Qureshi, who's here as well, was at AKU, and he came to the US to learn a little bit more at Emory and at St. Jude's. So while he was there, he connected with Khurram, and they were just talking about, what are the challenges in the US versus what they have over there. They were talking about protons and no protons and things of that nature. And Dr. Qureshi was talking about, the issues in Pakistan. So Khurram got very excited, and he said, you know what, I need to tell and share this with two of my buddies. So we had a Zoom call in August of 2022 where Dr. Qureshi just presented to the three of us. So that's me in Chicago, that's Atif Khan in New York, and there's Khurram. This is 2022. But the story, like Khurram was just suggesting, goes back in 20 years before that. How did the three of us even get to know each other? And we met in Boston. I was doing residency. I was at Mass General. Atif was a fellow at the Brigham. And Khurram just came as a medical student rotating for a rotation. And there are three Muslim guys in radiation oncology in the city of Boston. We just start talking. We become friends. And as you know, you're still an outsider, even if you're born in the US in certain circles. We just have to stick together. And that's what we did over the last 25 years. We shared ideas, we helped each other, we gave advice, we said this is a good job, this is not a good job, just informally over the last 25 years. And what I want to say with that, the thing that I would emphasize is this relationship is one that does not have egos. People's lives go up, they go down, people move forward, they move back, it doesn't matter, we're just here to help each other. And so when this opportunity came to talk about how we can help Pakistan, Khurram was like, I need to share it with my other two friends. Okay. So we started doing a little bit of investigation, and this is a paper that was published in 2023, the clinical trials landscape in Pakistan specifically. And it goes through a number of barriers and opportunities. And so we were looking at this and saying, what are some of the issues? So what they describe as lack of funding, mostly, funding coming from the West, pharmaceutical companies, lack of skilled personnel. The big one was regulatory issues, streamlining ethical approval, simplifying IRB, all that stuff, red tape stuff that no one enjoys doing, big problem. Addressing cultural and religious concerns specific to Pakistan, and really, how do we participate in global efforts to bridge this gap? So if you look, this is, looking at Pakistan's sort of clinical trial output over the last 20 years, up to 2022, you can see that there's been quite a bit of activity, actually, and it increased after COVID. But if you look at the phase not applicable, you've got about 1,700 studies. It's kind of hard to label what exactly was done, okay? If you look down lower at the intervention types, whether it's drug, device, radiation, only 27 studies in 20 years. It's other, mostly, 1,000. So it's kind of this mixed bag that's hard to label. Now, you compare that with most of the research that's being done in the, in the world. You all are quoting studies, specific studies, keynote studies, all these studies. 83% of all trials are being done in 25 high-income countries. So less than 5% is done in the other 91 countries. And so the question to some degree is what's happening in those other 25 countries really relevant to Pakistan and vice versa? How can we change this? So the three of us listening to this talk, getting excited, saying, hey, maybe we can do something, and seeing that we're in a different place now than we were when we were just students or fellows 20 years later, because we helped each other, maybe we can actually help Pakistan, maybe we can help others. But we realized we couldn't do it alone. So 3 of us are physicians, but we definitely need somebody with biology experience. So we roped in Mansoor Ahmed, who's at the NIH. And then we also roped in a physicist, Bushra Rana, who's from Pakistan, who came from here, went to the US, and then does a lot of IROC accrediting and things of that nature for clinical trials. So between the 5 of us, we figured maybe we can figure out a vision and try to help out in general. And what I want to emphasize in this is this only works because we have a culture of being very collaborative. Like, I enjoy hanging out and working with these people because there isn't any ego involved. So we were invited in 2023 to come, and Khurram and Atif came in person, and I think that was very important because they were able to meet all of you who are the key stakeholders, and we were able to learn a lot because we were just looking at a paper, but it's different when you talk to people in person. And so 3 of the things that were identified through all of you was that you needed some clinical trial training and education. There was a strong interest in stereotactic training specifically, and then this whole idea of end-to-end quality assurance and standardization, you know, between physics and IRB and things of that nature. So we proposed 2 sessions that year. The first session was introduction to some interesting areas of radiation or expertise. So Atif is at Memorial Sloan Kettering. He's the breast specialist there. He gave a talk on breast. Khurram, lymphoma, coming from Emory. Mansoor gave a talk on immunoradiotherapy, which is the rage this whole year, 2026. That's almost half of what I'm hearing. And then I gave a talk on spatially fractionary radiation treatment. So this is just some areas of our expertise. But then we had a second session, and the second session was to address what you all were looking for. Can we bring some speakers of international repute to Pakistan? And by having them come here and speak to you, now Pakistan is on the radar. If you all put in a trial idea and this person has spoken to Pakistan, it might make them think, you know what, there was something in Pakistan, let me give them a chance. So we're just trying to open the door. So in this case, we had 2 people, Norm Coleman, who is at the NCI, and we had May Abdul Wahab, who is the director at the IAEA. So 2 international people, both of them who are Astro Gold Medal winners, coming to Pakistan to discuss where are we in terms of global cancer research. And at the same time, we have people local. We had Ara Khan, we had Shokal Khanam, and then we had INMOL. So we have representation from IAEA as well, or PAEA as well. And these talks were a little bit more general. So Norm Coleman, although he's coming from the NCI and the NIH, actually is the scientific advisor to the International Cancer Expert Corps. He's a mentor of mine, and I serve on that organization as well. He was just talking generally on the international collaborative fight against cancer. And the question is, where does Pakistan maybe fit in that? And May did the same thing. What's the role of the IAEA in the fight against cancer at the global and regional level? And so the question then is, where does Pakistan fit in that? So they're just describing the landscape currently and kind of the absence of Pakistan in some ways on the stage, or areas where they can do more. So after that meeting, we went back and we had a number of Zoom calls, and most of those Zoom calls were between ourselves, but also with Pakistan, just to find out how we could help. And we came up with this idea of this Global Cancer Research Leadership Training Awards. So we applied for a grant, and we were working back and forth, trying to get feedback. So this is, Zoom calls with Pakistan and the US. And we put together this grant, and we thought that the need at that time was skilled personnel. So there's a lack of emphasis on clinical research training in medical school and in the hospitals. There's a brain drain. Physicists they come to the US, they're supposed to come back, but they kind of stay for jobs in the US. Where's that expertise in stereotactic or other things going? And then a lack of government funding. So we just came up with a proposal, using the players that were interested at the time. So Agha Khan, Shaukat Khanam, and said, can we create something, like a clinical training course? And that's what we tried to do, something that mimics what the NCI would be able to have. And the idea was to try to get US funds to do this and apply that way. So we came up with a very ambitious budget. It was $200,000 over 2 years to sort of jumpstart this idea. And again, this was a collaborative thing. We were trying to use the resources here, match them with the USA, and then hopefully connect them with international options. Now, this proposal for the first time was actually very favorably reviewed. It got a high score, okay? But ultimately, it was not funded, okay? And when we went to go resubmit, the resubmission was closed, okay? Not because of anything that we did. It was just the politics of what was going on there. So the next year, we said, okay, that's okay. Let's move forward. Let's make it more Pakistan-specific. So the idea here was global expertise for oncological advancements in Pakistan. And so we identified these 6 different areas that were Pakistan-specific. Understanding these models of clinical trials, the barriers and opportunities. Can we get more bench work to clinical trials? How do we foster a commitment to research? And here's the big thing, national cohesion. Nothing's going to happen unless everybody is getting along and wants to do this together. And then can we help with grants and then capacity building? So this is in 2024. This was in Islamabad. And we had these speakers. Now, Norm Coleman, unfortunately, a day or 2 before this event, passed away. It's sort of the similar situation that we're having this year. But Dr. Vikram stepped in from the NIH, and he gave his thoughts on how he could help. And then May also spoke as well. This was more specific to Pakistan. And this time, 2 people every year are coming here in person, and this time it was me and Atif. So we came, and then what we also were able to do was do insight visits. And I got the chance to go to Lahore, Islamabad, and Karachi and visit a bunch of centers. And that really, really helped, because it's one thing to just read it on paper, it's another thing to actually see the centers and talk to people. And going back to that paper that I showed you before, this is the roadmap of where research is happening in Pakistan. And if you can look at the areas that are green, those are the major centers. So what we had proposed as part of that proposal that we had submitted was this idea of, and we called it CIRO, we just made this up, like a council on education. But the idea was we need the country to work together in some way, and in these 3 areas. And whoever's in these areas, can they participate and work together? So we had identified a couple of actors, PIAES, Shaukat Khanam, Inmol, Kiran, Agha Khan, not limited to. We were saying at least, to incorporate some people, but not limited to. It's basically anyone who puts up their hand and wants to volunteer, they can be included. And so that's where we are here now. So the same model, session 1 that we do is let's introduce a new idea or a new topic. This year it's low dose radiation, whether it's for benign or for radiation diseases. But now this symposium here, which is about clinical trials in infrastructure building. And I am sensing an inflection point. The PSCO is growing in a way. You're creating a new journal, JCOP. You're creating a new venue for you to be able to have your voice heard. You are participating in FARO and other things. The organization needs to take another step forward. And that needs to come from you all. So this is when I was here in Lahore last time. But what is our role? Our role is we can't necessarily get you funding directly. We can help open the door to the funding, but we're really just a vehicle to close that gap. We can get you experts that can help you. We can get you advice to help you. But ultimately, it's going to need to come from you all working together. And I want to give you an example. I know Pakistan has its challenges, but let's think about Iran. Iran is literally banned by most of the world in terms of publishing any papers. I've published a couple papers with Iranian colleagues, largely because they can't publish it themselves. They need somebody else to connect with. But they're smart people, but they're boycotted. But still, they're not refusing to kind of just say, well, we can't do it. They're obviously not going to be able to apply for NIH funding. But they'll do it themselves. But they're smart. So this is a study, and we just talked about this in the low dose rate session, but it's a well-done study. It's a double-blind, sham-controlled, randomized control study looking at low-dose radiation in osteoarthritis. It's only 60 patients, 30 patients in each arm, 30 in a control, 30 in an experimental arm. But they did it well. Centralized review, clean IRB, clean parameters, okay? And they just published this. And they didn't publish it in the red journal. They published it in another journal that was accepting to them, but they got it out there. And the point being is, if you talk about low-dose radiation for OA, they're on the map. Here are the different centers that are quoted. Germany, Iran, Dutch, Russian, Dutch, South Korea, and Spanish are coming up. But Iran is on the map. They're part of that discussion. And they've gone on to write a number of review articles. So their experience is considered expert in this area outside of Germany. So it's not hard to make a splash if you're just intentional. I just wanted to give you that as an example. We're here just to try to open that door to help facilitate, but ultimately we're really looking for all of you to be able to put your heads together and work together.
Thank you, Dr. Modine, for a great insightful about the U.S. Pakistan Oncology Working Group and what we can do to help. The next speaker I would like to introduce, actually we introduced him yesterday, Dr. Vikram Bhadrasian from NIH. I think we sent an email. You guys can contact him. And he, because of NIH restrictions and some issues, couldn't be here to give a virtual talk. But just by way of background, Dr. Bhadrasian was the chief clinical radiation oncology branch program director at NCI. He trained in radiation oncology at Memorial Sloan Kettering Cancer Center. He has served as a professor and a university chair of the Department of Radiation Oncology at the Albert Einstein College of Medicine. And he does send his regards. He's supportive of the initiative that is being done here in Pakistan, and actually gave his personal email, and we can email that out to everyone. And he said, any question you have about R1, NIH funding, clinical trials, he can help facilitate and guide that. So I just want to kind of highlight that. I think our next talk I would like to is to introduce is Dr. Quinn Lee. Dr. Quinn Lee is from the chair of Stanford. She is also the NRG participant. She serves as the Catherine Dexter McCormick and Stanley McCormick Memorial Professor and the chair of the Department of Radiation Oncology at Stanford University. She won the 2025 Gold Award for Astro in 2025. And a big hat that she actually wears, which is relevant to us, is she's one of the co-chairs of the NRG Oncology Group of the NCI-sponsored National Cancer Trials Network. And that's a big deal. I mean, a lot of radiation trials are run through the NRG in the US. And I think having her, being involved and connected is going to be a very important link. And she has been involved in conducting many practice-changing phase 3 trials, some of which were actually highlighted at yesterday's talk by her. She's also a very fluent and amazing grant writer. She's held multiple R1 grants, PO1 grants, R21 grants from NIH. I think we have slides from her. If we can start her PowerPoint slide, that would be wonderful. Thank you. Do we have a pre-recorded video? Thank you.
Good afternoon. I will be talking about advancing international collaboration through energy oncology. For the next 12 minutes, I'd like to review the National Clinical Trial Network, or NCTN for short, to provide an overview of energy oncology structure, discuss the process behind clinical trial development and quality assurance, and international collaborations. So in 2010, the Institute of Medicine of the US proposed to restructure the cooperative group system. So 2012, the system was dissolved by the NCI for the plan for 4 new adult group as part of the new network. 2013, the new network formed with the groups as shown here for adult and a children oncology group. And energy oncology will form between NSABP, RTOG, and GOJ. 2014, the groups were funded for the first cycle. And here's the structure of NCTN, as you can see here. Together, in addition to adult and pediatric group, we also have a Canadian network group and an NCORP, which we'll talk about in a few minutes. And then the group will renew for 2019 for 7-year funding. And last year, we submitted a competitive renewal for grant submission. We were score, and we're still waiting for funding. So the goal of the NCTN system is to perform late-stage cancer trial that define the standard of care for the US and the world. It should be available to a broad constituency of diverse patients, ensure that all results are published timely, objectively. We need to maintain high-quality data repositories for clinical imaging biospecimens, and it should complement the research by non-North American groups and industry. Some facts about a few years ago, and so it probably need to be updated, but we have over 2,000 participating sites in North America and some international member with over 14,000 investigators across the network. The funding is we enroll about 17,000 patients per year with a budget about 171 million. So the funding is about $10,000 investment from NCI per patient. And the proposed trials are rigorously reviewed and approved or rejected by NCI-sponsored disease steering committee. About a little bit less than 5 years ago, the groups get together and they analyzed 162 positive NCTN trials published over a 40-year period. It represents 30% of all completed trials, include over 100,000 patients. Most commonly in breast, GYN, lung, prostate, and most of these trials were cited in cancer care guideline. And the model estimates that these trials have added about 14.2 million life year to cancer patients. And if you extrapolate it to 2030, it'll be 24.1 million life years saved. And at the cost of $10,000 per patient, the life year saved gain is about 326 per life year gain. Which is quite cheap and cost effective. Within energy, as I mentioned, we're formed by 3 legacy groups, NSABP, R for RTOG, and G for GOG. So we have 3 group chairs. We have 7 disease site chair in brain, breast, GI, GU, GYN, and head and neck. We also have development therapeutic committee. And these committee really focus on therapy improvement using survival endpoint. Whereas we also have a separate grant structure called NCORP, which is NCI Community Oncology Research Program, and they focus on developing clinical trial and studies that involve cancer screening, prevention, control, and treatment to improve mainly quality of life of patients using patient-reported outcome. These are pictures of some of the leaders here. We do have a rotation after some terms out, so we will have some new leaders in March. This is the organization structure within energy. I'm not going to spend too much time on it, but we have the 3 group chair with the data statistic management. We have a big research center and a big operations center. And the research center, as I mentioned, we have 7 disease sites. The committee, we also have scientific committee, mainly to develop therapeutics, cancer delivery, cancer control, patient-reported outcome. We have the core committees that actually support the scientific, such as surgical, pathology, medical, radiation, etc. We have administrative committee that focus on career development, communication, membership, publication. And then we have a lot of oversight committees as well. Within the latest data for energy, we up until 2024, when we gather our data for our grand renewal, we have about 66 protocol and follow-up, 36 active protocol, 10 new protocol in development, 18 new concept submission. We have over 200 main members, over 1,800 performance site, and 7 countries outside of North America. And we accrued up to about a third of patient to our NCTN adult group trial. And so we are the largest group. And of note, the last submission in 2025, we also had the best score of all the group. Well, we have the perfect score, 10. So if you look at how you develop energy within the protocol development process, people come in with new ideas, and that new idea either come from data mining or preclinical research or from investigator-initiated study. These ideas are then get incubated and developed and optimized and perfected within each of the disease site team. For example, if you have an idea in brain, then it'll come out of the brain committee. Then it will go to what we call research strategy, which is a oversight committee within energy to make sure that for us to review the proposed concept and whether to, again, approve or disapprove or a recommendation to improve the study to go back. So once it get out of research committee, and we have an executive committee here to kind of prioritize which concept to go first, then it gets submission to the NCI steering committee. And so there will be, for example, if you have a brain concept, it will go to the brain NCI steering committee for review. And with that, it will be either approved or disapproved. For the approved concept, then we'll actually move forward to full trial development with protocol and activation and accrual. And we work in collaboration with NCI and the Central IRB for that. Sometime in some study, we also have to loop in the FDA because if it's involving a new drug. And then how long does it take? It takes about, from incubation to activation and enrollment, it takes about 2 to 3 years. So in addition to protocol development, we have a lot of support because it's the radiation oncology. And so we have for imaging, and we use a lot of imaging and treatment planning. And so we work with IROC, which is a separate structure that's funded through the NCI to support a lot of quality assurance of radiation oncology and imaging. And the structure of IROC it's a distributed structure with a principal investigator from Ohio, Houston, Rhode Island, and Philadelphia. And the role is for site quantification, such as, they need to make sure that you can deliver the treatment that you want to deliver, either proton, IMRT, or IGRT. They have provided support for trial designs, such as protocol review and template, that credentials the site, and to provide data management. And then obviously the cases are submitted. It has to be reviewed. Most of the time it's post-treatment review, but there's if you bring in new study with new treatment modalities, sometime it will be on pre or on treatment review. The other center that we have quite a bit, and this is more, we call the CIRO, which is Center of Innovation for Radiation Oncology. It's mainly focused on harmonizing and education. So they provide contour atlases and protocol template to the disease site for guidance. They've also created guidances for new modality treatment. They ensure that all resources are standardized with TG263 structure naming structure. They have consensus definition for all the organ at risk, and they have summaries of dose volume constrained with conversion tools between fraction size. So if you go into Energy Oncology website, there's a lot of contours and atlases and templates in CIRO. You have to register in order to see this, and it's not a login, but we ask you to register so you can keep track of who's looking into this and what the reach is of CIRO. So as I mentioned, we resubmitted the grant competitive renewal last year. The theme that we focus on continued to be focused on sex-specific malignancy in GYN, prostate, and breast cancer, leveraging the strength of our legacy group. We've also focused on localized and locally advanced malignancy, originally from the lung, head and neck, CNS, GI, and GU tract. We have 3 aims. One is to use biomarker and clinical algorithm for risk stratification to optimize treatment regimen and duration in our for our clinical trials. We want to apply emerging knowledge and novel therapeutics to the development of early and phase-late clinical trial. And we want to test application of novel technologies in radiation oncology, surgery, imaging, and most recently AI platforms for clinical trial. We do have a large membership committee, and within the membership committee, we have an international subcommittee that's led by Ben Korn and Kaiichi Fujiwara. Ben is from Israel and Kaiichi from Japan. They meet twice a year at Energy Oncology semi-annual meeting, and they discuss audit guidance, membership requirement, regulatory guidelines, and study that could be open to international participation. We do have international member liaison to each of the disease site committee to make sure that they connect back to the international committee. There are different type of international collaboration that you can do with the NCTN. So this is not just energy oncology, but across NCTN network. If it's an NCTN-led trial, then NCI provide full funding support, and you can become an affiliate or more commonly an international full member. And you have to meet the same requirement as a U.S. full member in terms of ethics, registration, security, compliance, and accrual. But you can access all trial within the NCTN network. We have a category called non-member collaborator. It's not, these collaborators are not subjected to the same requirement as full member, but they do need NCI approval, be compliance with GCP and NIH policy, and they need to they can only access specific trial, and we need to sign a memorandum of understanding with each of the group. And then for non-NCTN lead trial, for example, if there's a network outside, like TROC and ERTC, and they want to lead trial and we want to work with them, it has to have a binding agreement with the US NCTN group. So let's say if we want to bring on an ERTC study, we need to have a binding agreement with NRG, which is led inside the US. The trial has to be approved by the NCI, by Disease Steering Committee and NCI. But within that, you have to create a specific steering committee for the trial to oversee the trial conduct across the two groups. And then it has to get approved by US State Department for countries that will be participating in research. But NCI funding is only going to support the involved US site, but not international site. So I hope that's clear, and this can also be shared with you for you to look over. So to conclude, NCTN and Energy Oncology, we conduct high-impact practice-changing trial. Quality assurance is important for radiation-related trials, and also now we're leading a lot of surgical trial. That's also important for quality assurance, and it can impact outcome. International collaboration is crucial for rapid trial accrual and to access diverse patient population and success of the trial in rare disease. And with that, I will conclude, and I do my acknowledgement before, so I'm just going to stop here.
The time zone differences, Dr. Quinley was not available online to do a question and answer session, but she did yesterday actually stayed online. And I think it's like 3 or 4 a.m. USA time, so we didn't want to inconvenience her. But her talk really highlighted some really key points. I think the last slide, the second one, talked about how international organizations can get involved at a different level. One was basically as a non-member. Another one could be a partnership with the US-based organization that actually is a lead member, and they can be a subside of that. So that's an important point. So I think that's an opportunity, and also like importance of IROC accreditation is important, quality assurances, things like that. So I think those are things to think about. I think the nice thing is what Majid highlighted, that you have friends and partners internationally, overseas. If that's an avenue that the PSCO or other hospitals want to move forward, you have partnership and friendships to help you move in that direction. But so Dr. Quinley just highlighted some avenues, and they have international partnership with many, many other countries that are actually participating and enrolling patients on NRG trials. So I think with that as a background, I want to now introduce our next speaker. I think he does really need introduction. We all know him very well, Dr. Rob Nawaz-Makin. He is going to highlight, he's a Deputy Chief Medical Officer. He serves as a clinical oncologist at the PSCO Hospital. I met him in 2023, was really privileged to meet him. We become friends, actually. So I got to meet his family. He'll meet my wife as well today. He's actually met her as well. So we're becoming not just colleagues, but actually family members or friends, actually, right? So it's kind of nice to be able to share stories. Without much further ado, please give a round of applause to Dr. Makin as he kind of enlightens us about what's happening in Pakistan.
Thank you very much. Before I start this presentation, if somebody asks us, can you do something good, big, reliable, and acceptable to the world, we say, yes, we can do it. We can make atom bombs, we can make missiles, we can make jets. But what about research? Can we develop a research environment on oncology in Pakistan? That is more important for our community. We do have international trialists. Our colleagues have participated in the international trials. But those trials were coming from other countries. If I ask my colleagues, is there credible prospective data from Pakistan? Although we have participated, but a national prospective trial is missing. Credible retrospective data or credible audit, from that we can learn, we can improve our practices. Again, it is difficult to say yes. These two areas, review article, meta-analysis, if we look at the literature, these two segments are coming from China. They're sitting, they're doing review articles, they're doing meta-analysis. If we look in the past, these segments were being covered by Western world and America, North America. And nowadays, major portion is coming from China. But from this part of the world, not only Pakistan, from Southeast Asia, this segment is also missing. What is the need of the day? There should be collaborative group, oncology group. What can be the role, advisory, consultative, approval of a trial, look into the progress of the trial, and it will help in analysis, write-up, and publication and dissemination as well. VN can be to become a leading national regional organization for high-quality oncology research that drives innovation, evidence-based practice, and better cancer cure. Objectives, list of objectives can be laid down, and it is nothing new to invent. We can follow, we can take any example of any group, and we can just follow those lines. It can be clinical research, translational research, clinical trials, education and training, publication and dissemination. Dissemination is also very important. If you are doing something and it is not properly disseminated, it is not visible on the globe. Composition of group can be pattern advisor, coordinator, core members. I was in continuous discussion with my like-minded colleagues from US POC Oncology Working Group and Dr. Waqas and Dr. Irfan as well. And if it was very easy to make a group and announce this. But if I look at history of research groups in my country, I was disappointed. And I was not very sure to announce the group. Then what to do? I was in discussion with Dr. Irfan. he suggested something different. He told me it is better to identify centers which can collaborate with each other for a standardization of radiation facility. For that purpose, I am lucky that I have Mr. Noman. He is medical physicist, very energetic, very visionary. And I discussed with him. He took the responsibility to standardize radiotherapy process of 4 centers. We have selected 4 centers in Mole, including in Mole. And another center, Cancer Care Hospital, they are also on board. They will participate in that process as well. I have initiated the departmental approvals. All centers are on board, their directors are on board. And I have requested them to nominate 2 radiation oncologists, 2 physicists, and 2 radiation technologists. And that process will be completed hopefully within a week or 2. That is the first step. And then standardization, that is a process. Documentation is in process as well. On background, we are doing that job. Radiation physicists and technologists and doctors, they will be updated by giving them material, doing workshops, and practices will be standardized. This can be through workshops, online meetings, and after doing this, we are going to launch a pilot study, and this was idea of Dr. Irfan. He suggested that we should do, he will be with me in this whole process. We should conduct a pilot study. And that whole process will be documented. For next step, that we go for phase 3 trial, that will need approval from a regulatory body and national institutional and national ethical boards. And hold this process, maybe it will take me 1 year or more than 1 year. Internationally, it takes approximately 1.5 years or 2 years to get it approved if you have phase 3 trial. I am working on the trial document of phase 3 trial. That is also almost complete, that I discussed with Dr. Irfan as well, shared with him, and got his input. But in spite of getting centers registered for that particular trial and approval of the trial, it was the first step that we should take, that is to launch a pilot study after standardization of the institutes, and then proceed on. Retrospective data. This is another source that we can learn from our own work that we are doing in our departments. Credible audit that can guide you to change your practices, to improve your practices, and we can get help from the clinical audit of other departments. For that is also missing, and usually papers that are coming from our departments are from trainees, and trainees are doing for the purpose of their publication, meeting the requirement. And as a senior, we are not considering it very important as a clinical audit to improve the practices in the institutes. This is a reality that I am telling you. If I look at the data of InMol, I have identified these 5 areas and showing the data of 2022 and 2023. If I look at the bladder, that we have registered 338 patients, for prostate 464 patients, and rectum and rectosigmoid tumors, those are 236. And nasopharynx, that is 86 cases. These are with at least 2-year follow-up. And if we look at this data, In coming year, I have assigned these topics to different colleagues in my department. We'll be working on it, and inshallah, in next annual meeting, we will be coming up with the results of the data those patients has been treated in my center. And if we look at the data in cervix, you see 551 patients with at least 2-year follow-up. That is a huge data. And multiple publications can come out of these 5 areas. Thank you very much. Wish me good luck. It is a difficult path that I have opted. In early meetings with my US colleagues, they asked me, go for research. My response was, no, I cannot do this job. I am a clinician, I can treat the patient, but I am not a researcher. But during this time, I realized that at least I should start the process, and my colleagues will take over, inshallah, and this should go on. Thank you very much. Any question?
So the next 5-10 minutes, we want to do some question and answer sessions. Yes? Please come to the mic and ask your question.
Assalamu alaikum. Dr. Abnawaz, I'm Dr. Maria. I have a question for you. Like you mentioned that about building the oncological research ecosystem in Pakistan, clearly highlighting the clinical trials, the translational trials, but as we today stand in the AI era and we are oncologists, how do we factor in the data-heavy approaches that would perhaps include the translational bioinformatics trial or the pragmatic RCTs? Do we have like any approaches to integrate that as we stand in the data-heavy area, the AI era, that we can say?
There are a lot of issues that I have also. But presently, because we don't have infrastructure, number one. Unfortunately, we don't have any clinical trial presently approved by the governing body or regulatory body. We have to go through this process. To make things simple, we should know the path. We should realize that this is the need of the time for our society, our patients, our oncology community. Definitely, that is the ultimate goal. Translational research, that is the ultimate goal. But at least we should start it. We should start this journey. Ultimately, we will reach there, and you people will reach there, inshallah.
Yes, I want to echo that. So I think you start the research with your heart and passion, and things line in place is my experience. Institution will support that. Your leaders will support that. When your passion and interests are sincere and you really want to improve the care for your patient in the future, everything, inshallah, will fall in place. You know, a lot of the drugs we all use, chemotherapy drugs, how many of them are actually tested in the Pakistani patients? Very few. How many immunotherapy drugs we talk about are actually tested in Pakistani patients? Do they work? We don't know. Toxicity might be different. You know, so I think it's very, very important. If you really want to improve care for Pakistani patients, this is where you start what Dr. Macon is saying, start. And you all unite and overcome the barriers. So I think that's, you know, very valid point.
I just asked this question as we are all radiation oncologists and we work in a very data-heavy field. We generate a lot of images and we generate a lot of treatment-related data. So my point was basically, like, where do we look? Even asking my US colleagues, like, where do you factor in all the predictive and prognostic modeling sort of research in this ecosystem?
Maya, do you want to take that? Or anyone up on the stage want to take that first? Or sure, we can. Yeah. So translation research, I'll give you my background. So if you look at my CV, you'll see, you know, several millions of dollars grants funding, and a lot of them are based on radiation abscopal research. What that means, you have to be an immunologist to be able to do the basic science of research, all right? My PhD is not in immunology, but I started in 2011 because I had a single patient mid-20s, who had a melanoma brain met. And I want to give her hope. And I say, look, if radiation works, and also she was CTLA-4, ipilimumab was just getting approved back then in 2011, 2012. I told her, look, maybe radiation, brain metastasis radiosurgery might combine with the CTLA-4 we're about to give you. And that was part of the melanoma discussion. I said, you might live longer. And I didn't have any evidence to show that. So what did I do? I was like, okay, I am not an expert, but I went across the street at Emory University, found Dr. Ahmed. I would actually encourage Rafi Ahmed to give you guys a talk. So he's a nationally, internationally recognized top physician, and actually a PhD immunologist from Harvard, actually. And he's like, Khurram, let's meet together, let's figure out what the issues were. I said, look, let's create a mouse model, and I don't know what to do. He's like, what mouse model do you want? I'm like, melanoma, I got a melanoma patient. That's how it started. He's like, well, I've got the best expertise here, do a melanoma mouse model. We created it. Then I was like, what experiments do we want to ask? What question do we want to ask? Dose, fractionation, timing. We answered that. And it showed that CTLA-4 and radiation work. That then led to so much downstream effects. With translation biologists, I'm not the translation biologist, but his postdoc is what that I funded once I started getting grants. That 4 or 5 years of work, then turned around, I went to pharmaceutical companies, Merck and others, say, hey, look, here's the science we've generated, basic sciences, with collaboration with other basic scientists in your own institution. It doesn't actually have to be within your own institution. You can go across to universities that are looking for this opportunity. So you cross barriers, then turn around, got clinical trial funding. And that clinical trial funding kept going over 10 years, mentored many, many students that are now basic scientists getting NIH funding now. So that's how this leads, this collaboration, cross-institutional, cross boundaries, really helps move the science forward. So this is a good start. So that's kind of what I would like to say.
Thank you.
Majid?
I just want to make 2 points. Yeah, I just wanted to make 2 points, and I think it's what I was driving at in the little spiel that I was giving. Number one, no one person has all the answers, okay? No one institution has all the answers, okay? He wants to do some research at INMO. He doesn't have a biostatistician, but maybe Khan or someone else has a biostatistician. Or maybe I know a biostatistician in the US who'd be willing to work with you over here, because that's the one piece you don't have. The whole point when we were students or fellows is we can't make it on our own, but if we group together, we can help everybody rise. And we've been able to help each other in our career. One of the things I did as a med student is I created a group of residents, fellows, and we called it Muslim Radiation Oncology. It's called Murado. And we made a Yahoo group, we made a Gmail group, now it's a WhatsApp group. And it includes a lot of people all over the world. It started out with like me talking to 4 people and saying, okay, I'll just put it into a group. And now lots of people are using it for things. So we all rise if we help each other out. It requires you to, I want to say this nicely. Like I went to dinner yesterday with an orthopedic surgeon, okay? He was a friend of Dr. Rana's. And he was saying there's a tendency, if you, let's say, go abroad and let's say I'm just making up for radiation, you become the proton expert and you come back here. But you want to build your own proton center and have it for myself so that I become famous for myself. Do you know what I'm saying? And I make, I don't know, whatever it is. But the idea is really to share that. And actually, if you do share it, you will rise way more than if you tried to keep it for yourself. Like, everyone will benefit. And I'm just saying that from our career point of view, we all sort of rise when we're all helping everybody, sharing equally. Everybody goes up. Like, not just you. And you can't do it by yourself. I can't do anything by myself. You know, that's the whole point of the working group. The second point I just want to make is we should keep this simple. Like, I know we get excited about like the immunotherapies and the translational stuff, and that's all good, but like if we can just start off simple and just create the structure to make sure it works, that's really what's on trial first, not even the patient, is does the structure work? Can we work together? And let's do a simple question. So the point of the Iran study, it's low-dose radiation, no IMRT, no stereotac, nothing. Just asking a very simple question, but they asked it so well. It's one of the positive trials that everyone is quoting because they did a good job. And they did it quickly, and that's one of the advantages you actually have here. I don't know if you want to answer that. Like we were talking, you had a trial proposal that you proposed earlier today.
I think excellent talks and setting up the scene for what could be classed as a difference of structural research between a first world country and a third world country. And the lack of resources is not only the lack of resources in terms of funding, but as you already highlighted, it is a difference between the culture of physicians and culture of the patients. And at the same time, there is a tribal culture which we were talking about that kicks in as well. But among all this, I think I started my training in Pakistan. I did my FCPS, so I am fully aware of how things work here. And then I went to UK. I was PI for so many trials. So I worked there, so I know how the National Cancer Research works and all kind of stuff. What I see is that when I started with our favorite Dr. Shahryar, we had lots of pharmaceutical-sponsored trial. We worked on Prostalicin, which are Alimta development. We did Gemzars, all kind of stuff in 1990s. They were pharmaceutical-sponsored drug trials. They will bring all the infrastructure. They will bring their statistician, their data managers, their everything. Where we really lack is what even in the US, I mean, you guys have taken like so many years still formatting the RTOG into NRG or IROC or whatever. We are way behind that in terms of radiation oncology research because unfortunately, no pharmaceutical support, no organizational or governmental support, and you are at your own while you are seeing 1,000 million patients every day. So how do you cope with the stress of that? At the same time, you don't carry a research-based appointment just for the sake of research. So this is, I find this is the most crucial point. And luckily, I'm very happy to see that there are so many residents now coming through who are very interested in projects, building the new research kind of projects, but also building the new techniques. Like we were talking about the grade and SFRT, for example, simple things. So when I was talking with Dr. Macon, we thought that, look, let's start with a baby step. And the baby step would be just to get your house in order first. Yeah. Before you jump out and look at everything and all kind of stuff. So the first step is, let's decide to become like Mr. Numan becomes the RTT QA center, where you go and convince your like-minded people that, okay, you plan, send it to the center, you plan, send it to the center, and Mr. Numan and his team, using their standard phantom treated, can come up with that, okay, this is now standardized. Then move to the next step. So this is a slow process. I think there's a lot of will to do it. Yeah. And with you guys' help, they are now getting a good roadmap as well, that how to do it. And with the live support from the group with US, I think that is the best thing which could have happened for radiation research. I am for translation research and the drug research, and I think because I strongly believe that our patient population is not exactly the same as Caucasians or African Americans. So we have never had any data on how do a woman with cervix cancer responds in Pakistan versus in New York. So we don't know. So this is where I think we need to work, and this is where Dr. Macon is doing a great job to also formalize the retrospective data, bring in whatever he can, and set up the scene.
Let me give you a real live example of 3 points that Majid, Dr. Macon, and Dr. Rana saying, Irfan. So give you an example. So look at 2020 COVID work. The first paper that came out, and we got a lot of national press, international press, was from Emory. 5 patients' data is all it was. Emory, we started a clinical trial because we were small, we were smart, we wanted to be efficient, and we kept it simple. Just go to IRB, asking for 5 patients, knowing there was no mouse model data on ARDS at that time, let alone, but we had enough, clinical extrapolations where we know we do low dose for TBI, cause inflammation. I'm not going to go into the biology, but the bottom line is IRB took all that background. They said, Dr. Khan, you're only asking for 5 patients. You show us safety data, we'll allow you to do more. And Ohio State was doing the same thing. We were competing. And Ohio State made a complex trial, 100 patients, phase 2 randomized. And they were going to have like 8 or 10 different sites to do it. Do you know what happened to that trial? It never even launched, even today. They never got 1 patient on there. Too complicated. We got 5 patients. We got our first paper. Turns out we were competing with Iran. Like we mentioned, they kept a simple trial. We got as soon as my paper got published, their paper came out. And they were cited. In the Red Journal, they were cited. We were cited as well in the cancer. And then we had 10 patients, and they came up. So, and then India came forward, small trials. So I agree with all the points here. Start with simple. Get your house in order first. Then you move to the more complex level, and you build the infrastructure as you move forward. Does that make sense? So, yeah, any other questions? Great questions, actually. Yes, Dr. Bilal, Dr. Qureshi?
Thank you, Dr. Khurram, Majid, and everyone in the US Park Oncology Working Group on being consistent over the years and bringing it to this stage that we are today. So I just wanted to expand on what Dr. Irfan said, and before that, some of the points, Majid, you highlighted. You talked about simplicity, collaboration, coming together, and starting simple. So I think in Pakistan, we always already have the stage set with all the review and commitment from Dr. Makin and in Mole. We do have examples in the oncology workspace in Pakistan, and it comes from the pediatric oncology group. They started simple. They now have, you might have heard about the Global Initiative for Childhood Cancer that targets 6 major cancers consistent with the WHO strategy. So the Pakistan Society of Pediatric Oncology 5 years ago started working upon 6 different tumors, Burkitt's, Wells, low-grade glioma, retinoblastoma, and Hodgkin's lymphoma. They started with simple trials, nothing fancy investigational in this, no comparative arm, but they did modify the doses or the diagnostics according to the local criteria. So that's standard of care protocols running at multiple centers in Pakistan. And that's also an example of collaboration. It includes Shaukat Khanam, us at Khan University, examples of philanthropy-based hospitals like Indal Hospital and NICH, which works in both government spaces with philanthropy and without philanthropy. It includes provincial government hospitals like Children's Hospital, Lahore, Multan, and Faisalabad. So it's running, and it completes recruitment of around more than 1,000 patients for ALL, around 800 patients for Hodgkin's disease. We did put in a radiation oncology component for standardization. There was a lot of restrictions. I felt that why you want to know more than the doses and the number of fractions, and unless you know that what was the area treated, how are you going to track the relapses for Hodgkin's disease? So we went through all the NBC stuff, the national regulation, the institutional IRBs, and it was not the giants in oncology, in pediatric oncology workspace who launched them. It was mid-level, mid-cadre oncology, pediatric oncologists, one from Shaukat Khanam, one from government hospital, someone from Indus leading Hodgkin's, or all of those things. So I do think that we do have an example set in. It does not require huge money. It does require few, like 1 statistician for all those centers, part-time data recorders for overlapping between different centers, and then even for the IROC thing, like in Mole is pioneering in that. We know Noman, great person. We have a setup through the pediatric radiation therapy, centralization of all the treatment plans. The experience is there with our work through ProperNet, which is also a funded project. I went through the whole of the NBC project, the National Bioethics Committee approval. So it's all doable. So it requires some time. Yeah. We need enthusiastic mid-level people coming in and
And the passion to build it and the interest, I think the passion what drives it and things fall in place. And I'm sure, let me ask you the second question. Once you started doing this and things started falling in place, did you feel like the institution supported you to do more and more and grow the complexity?
Definitely it does. It does not only happen at my institute where I am appraised for my academic work, it also happens at public sector hospitals.
Yes.
At philanthropy hospital, because they know that Indus or Children's Hospital Lahore is doing the same thing which Aga Khan or Shaukat Khan Hospital does. And they build up trust in the patient care. And we at private centers, someone at Shaukat Khanum trusts a child being treated at Children's Hospital in Multan because they know that this is being treated on a standard PSCO protocol, which is consistent with international standards. And there is regulations and monitoring of side effects, there is regulation and monitoring of doses of chemotherapy and all the diagnostic things.
Yeah. And do you feel like that also helped your practice and your ability to improve the patient outcomes and kind of really tell the patients what you're learning in the research? And do you feel like that also helped you as well?
This definitely helps in our practice too, because the patients are often switching between different hospitals in the city. I being part of the radiation oncology space, I'm being contacted that, hey, I'm not getting the radiation data from somewhere. So we do get help for standardization, of course.
Okay. Sorry, we have about 15 more minutes. I think we're about to be done. But so I think you bring up a good point. I think once you start small, slowly build the collaborations, across just not only within your institution, but maybe outside of your institution as well. And you find resources that you may not have, but someone else has. But you combine those, the resources become even more powerful. And what you think might be a barrier is actually not a barrier. So, but no, it's very good points.
Yeah, but that comes through an umbrella of the Pediatric Oncology Society, and I believe that PSCO has more structured, more collaboration right now than Pediatric Oncology Society had at that time.
That's good. Any other questions you guys have? Audience, any responses from the audience or from the guests on stage?
To comment, I think most of the things have been covered by all of you. It's a fantastic session. The main thing, there are two components of this session. One is to better understand the importance of the research and then to ensure the infrastructure. There are two types of infrastructures, national and institutional. When it comes to the institutional infrastructure, that's where we can do a lot of things. In Britain, we have got different bodies as a regulator, then we have got NICE to overview the funding, obviously REC as an ethical committee to look at. I think it's more or less the same everywhere. To keep things simple, the first thing is to learn what national infrastructure is already there, because some of the trials have been happening in Pakistan. So I think you could still get some help at what is already in place. Better understand your system first, and then you can add the bricks to build up a wall, the remaining wall. And as all of you said, that keep things simple. Do you start with the very simple projects? What kind of research do you want to do? I think that's the next step, where you can seek help from all of the people involved in research actively. So first of all, it is very important to understand your own infrastructure at a national level, which is already there in place, and to understand the regular. I mean, when I was talking to different people, I mean, not many people were aware of the regulatory authority or their essential criteria to get things approved, and where to go for any ethical approval and things like that. I think the first thing is to better understand your own system, then develop institutional infrastructure, and then think about all the projects you can do. I think that's what.
Yeah, and that's what the session's about, is looking internally and see what your own internal infrastructure allows for and what doesn't allow for, right? That's step one. When you get into research, you realize what you have, what you don't have, both at the departmental level and then maybe at an institution level, you figure out what is not possible. But then you have the national level collaboration across different institutions. Say, hey, what research do you have? What research do I have? And what research we both don't have? And what do we need? And that's where you have other partners across Pakistan that can kind of leverage. That's why the concept Dr. Macon mentioned is this sort of national collaborative group, Where nationally, you're working together to overcome these. And with nationally, you have more power. You can go to your leaders nationally and say, hey, multiple hospitals want this to happen. Then they listen. So at least hopefully they'll listen. But you also have international partners as well, too.
There's one thing I need to add. For the beginners and learners, there is an online course in Britain called GCP, Good Clinical Practice, that gives you a very basic idea of the framework of the trial, what is the role of a principal investigator, co-investigators, nurses, data managers, and how to report adverse events, what kind of trials, phase 1, phase 0, phase 2. So I think that's a very good opportunity to learn the basics of the trial.
Yep.
And we keep refreshing this GCP competency. We are not allowed to see any trial patients, new or follow-up, if the GCP is expired. We have to do it every 2 years to refresh ourselves. So that's another resource which will provide you a good understanding.
And that's a great point. So I think that resource will be available. You can use it. And actually part of the grant that Majid talked about, in that grant, that $200,000 we were asking for, Bilal, you were the PI. And do you want to tell us what that trial, what that $200,000 was going to be used for? About the course, you want to highlight it a little bit? What the course was going to be is exactly what you mentioned.
Building up the research capacity for the radiation oncologist and for the physicist.
Yeah.
It was to mentor people how to write grants, how to do QA on part of the radiation therapy technologists and the physicists, and training and spreading those information. So it actually built up a hybrid structure that someone from the US like yourself or your group, Bushra or someone else will come in and train people both on the grant writing. It's a hand-to-hand building up on a project which a young investigator could start up with, and at the same time building up the QA tools and going for IROC accreditation.
And it was about clinical trial and how to actually run a clinical trial. What does it mean? Actually drafting a clinical trial. How do you get funding for the clinical trial, and getting it through the IRB process, and getting to GCP, HIPAA compliance. So there was a clinical trial course. And we were going to recruit people from Mole Hospital and other hospitals. And if that funding would have come forward, you would actually have an official course. So all your junior colleagues that are interested in learning how to do clinical trials, this is exactly what would have the course been for, is to teach you all the steps involved. And institutionally, you could look at what the resources were, what the infrastructures were, and what weren't there, and how do you sort of overcome those. And this was supposed to be a clinical trial course that we were going to try to create. But unfortunately, it didn't take off. But the idea is still there.
On this point, my take is a little bit different.
Yeah, mine is also having gone through
If you want to work, if we look for the certifications, if I am having certified, then I can do research. It is not the path that I will follow.
No.
I have taken first step. Wherever I will need some resource, that in the form of money, in the form of training, in the form of biostatistician or data managers, or infrastructure, space, machines, I'll do it. We will do it.
Yeah,
we are together.
That's the way I'm feeling. So we applied for this grant. It didn't happen to come through. You could just throw up your hands and say, well, there's no money, so why bother? And I don't feel that way. I feel like, fine, so you have to pivot. What can we do with what we have? And if there's small things we can supplement, let's supplement them, but let's work at the level that we have. We can always build to that idea, and maybe it will come, but it might not come immediately. And I agree with whatever you have right now, whether it's 1 or 2 institutions, what can we do to do something moving forward that's built in from ourselves? And I mentioned this like JCOP thing, for example. Let's say you feel you can't publish in the red journal or the green journal. Publish in your own journal. It's still valid. Build it yourself.
Yep.
Don't just rely on maybe trying to get it in, in the US or something. Like, you can build it yourself. It might feel humble in the beginning, but it won't be humble. Because I think the things that will come out of here will be very unique and different from anywhere else in the world. To help Pakistan, but just to help other people from this area.
I think the need of certification is not to validate yourself. I think the need of certification is to learn formally about the things. You don't need to repeat it every 2 years. to get validated for that. But if you do it at least once, you would have a better understanding of your studies and set up what you're doing, how to report it. Even if you're reporting locally about the adverse events, you must be aware of that there is a way of reporting, how to obtain a proper consent according to Helsinki protocol and stuff like that. That's just a very important resource for us to learn formally about the structure of the trial. And that would be enough for that one-off kind of a certification would be enough. So that will be very helpful for the beginners.
Yeah, I think it's a very valid point that if you are going to participate in clinical trials, you perhaps will have to show that you have done something to satisfy the IRBs or whatever. But I think my experience in Pakistan is as junior oncologist and then went outside, and now for the last 5 years, I'm quite involved, so I can see the transition. So generally, unfortunately, I have to say that like everything in Pakistan, everything has gone down in the last 20 years. I mean, in late 90s and early 2000s, we had so many investigator initiative trials. We had pharmaceutical sponsored trials. People were, Dr. Abrar was sitting here, Dr. Shahryar was there, Sayyid Naveed Akhtar sitting there. He established his whole Gemzar story with us as well from Lilly. So we were very, very busy. And we had ISC, GACPs, we were going to Malaysia, we were going to Thailand to present the pharmaceutical sponsored trials and investigator initiative trials. Unfortunately, there has been a decline. So now, somebody who comes back into the country, I see two types of doctors here. One are those who are not interested. They are just, just money making or whatever. They just turn up and do 100 patients, whatever, and go home. And then there are other people who are interested in research, sitting here in this late evening. They are interested in research, and I see the frustration part because, as Vikas said, they look for national, I was PI for CHIP trial, for PACE trial, for Stampede trial. We have so much support from the national agencies, from the National Cancer Network. There is nothing in Pakistan. And you are hitting the wall in most of the situations. There are obstacles after obstacles. And I think the best person who can help this is Dr. Sayyid Naveed Akhtar for motivational talks. Okay? Because we need motivational speakers as well who can encourage. Like, for example, Dr. Macon said that Mr. Noman is going to be the focal point for setting up the thing. Is he getting any reimbursement for that? No. Is he going to spend his own time out of the other things? Yes. So what is motivating him to do this and go late home? What is motivating him? So this is where I think we definitely need a motivational team building exercises which can tell people, do not get frustrated, go for very low hanging fruit, go for very baby step, quoting Iran example, come out something that encourages you to take the next step. I think, in my opinion, the drug trials are not a big deal because they come, because people need patients and they don't have patients, they will bring it here. Radiotherapy trials are the real frustrating part. We have no central physics RTQA, which is Vikas trials in the UK. We have the central system. You plan a patient, you send your phantom, you plan your contours, come back, fix it, blah, blah, and then you get signed off. Where is that here? So you don't want to start the trials with you mess up the patients and then you kind of, where are we now? So as a baby step, we don't even have a retrospective proper data. If I ask any of our oncologists, what is your 5-year biochemical control for prostate cancer? There is no answer. Nobody has ever looked at that in a formal way other than Dr. Macon said that there are some residents who will do that for their, the upbringing or whatever. So we are way, way behind. Translational and other things will come far off. And we need to focus on the very basic radiation, low-hanging fruits. Iran is the classical example quoted here, and that is what we need to focus on. I think that's when, and Naveed Akhtar, I'm not joking, he's the one who needs to go to all centers and motivate people to say, spend your own time for the betterment of people of this country. They don't get reimbursement for that.
I agree, it's a good point. So that's a passion is what drives the research, not that you're going to get some research funding or whatnot sometimes. Just passion, just something you're interested in doing because it's the right thing to do for patients, the right thing to do for our, for Pakistanis. So that's what drives a lot of that research. You're right, a lot of it comes at your own cost. So, but sometimes maybe the institution supports it, and sometimes it doesn't. Sometimes you get grants, sometimes you don't. But that doesn't mean you give up. That doesn't mean you stop. You keep doing it because you want to do the right thing for your patients. Iran did it. India did it. Many other countries have done it. We'd like to see Pakistan doing it too. I think we may have time for one more question with 6:59. I'm going to get cut. So one last question, anyone? Nope. Okay. Yes, yep. We have one question, one last question.
Encouragement, what you are suggesting us. Nowadays, we are representing BMJ here in Pakistan. What we ask our doctors, if you are not getting place over there, what you can start with that. Why don't you present your case studies over there?
Yeah.
Just start with that. You see, what you will get out of that from there. What would happen? They will tell you these are the area of improvement in your case study. You improve it. You see, we are still deficit. We are not able to even present our case studies over there. That is much easier to print over there. Mm-hmm. So this is again motivation and environment that you are going to get on anything as far as emolument is concerned. I still remember when I was in a pharmaceutical company, we had one trial in Shaukat Khanam of CA cervix, which were phase 3 trials, and that was FDA approval for FDA approval. And as far as patient is concerned, we have a lot of patients here in Pakistan. One again, phase 3 trials for Pemetrexed, which was done in Pakistan. And you see Tony Mock, one of the famous doctors from Hong Kong, he differed from the data generated in USA. He said, you have got different data, I have got different data from South Asian countries. Yeah. And he presented sub-analysis over there. Yeah. And the data was approved, and the indication was first line, Pemetrexed was approved in US. So this is what we can do. Yes, motivation is required, and environment is required.
We are sitting on a gold mine of data and the patient. I mean, Majid was telling me, like we were discussing about the advanced cervix cancer patients, 10, 15, 20 centimeter tumors. We were talking about the SFRT as a shot before radiation. And this is what me and Majid were saying, that if he started in Chicago with all the centers and we started at the same time, we will be done like way, way ahead of those centers.
Absolutely.
Because we have all these patients. We have a very unique population and case mix.
That's a good point. Well, great discussions tonight. Thank you so much. This was very insightful. It's going to take a village to help all of us working together to move forward with some of the initiatives being discussed. Thank you so much. I know we're out of time. And thank you to all of our panelists here and all of our speakers. Please give a round of applause for everyone. So I think we're going to go to Ambassador 3 room, I believe, is what I'm being asked to announce. So, okay, so I think there's a session or something going on in Ambassador 3.